we are left with some, we have ruled out everything, now we are left with some functional causes as the cause for his voiding problems. So what are they? If you go back to our Campbell's urology or even the monograms, we have got things like Hinman syndrome, Fowler syndrome, dysfunctional voiding, and today I will be talking on PBNO, that is primary bladder obstruction. And I think we should be concentrating more on PBNO rather than Hinman syndrome, Fowler syndrome or dysfunctional voiding, which are very rare entities and probably I think overrated and historical. When Frank Hinman saw one case, he described it and called it eponymously, and it was called as Hinman syndrome. And nowadays, the trend is not to give names to the syndromes, but to give the pathophysiological name. So it's called a non-neurogenic neurogenic bladder rather than Hinman syndrome now. So what is it? In this index patient that I talked about, is it Hinman syndrome? Could it be possible? Is it possible that it is Hinman syndrome or non-neurogenic neurogenic bladder? Well, it was first described in the pediatric age group, and typically it is described in children and who are growing up, pre-adolescents, and they say it's behavioral or psychological in cause, and they do not attribute any particular reason. In the sense, no organic lesion is found in the neurological system. That's why it is called a non-neurogenic bladder. That's what happened when Hinman first described it. He found a lot of imaging and endoscopic abnormalities, but he did not find any abnormality in the neurological system, either by clinical examination or by endoscope or by imaging. So, this is a rare entity. I think all of us agree that we hardly see such patients in our clinical practice. But of course, if you see, that's Hinman syndrome, but that's a rarity. Fowler syndrome, idiopathic retention of urine in a young female. Basically, that's a classic description of Fowler syndrome. You see, there are so many names. Every time a urologist or someone saw a particular case and he did not know how to make a diagnosis, he published as a case report and it was called by his name. That's what has happened in most of these historical named syndromes. That's why they are syndromes. They are not disorders. So, Fowler syndrome, typically young woman, lack of relaxation of the external sphincter is the pathogenesis there, and the diagnosis is done by EMG. Now, in this index case, is it Fowler syndrome? Of course, it could be a male or a female, but then if you do video urodynamics, you can rule out or confirm it. But since we don't have video urodynamics, MCU is good enough. And if MCU does not show that the bladder neck is open, you have to be, of course, diligent about it. Then you can rule out, or you may not consider Fowler syndrome in such a big thing. And in any case, I think you'll all agree with me that in our clinical practice, we hardly see these things. These are more for passing our exams, MCH exams, and many examiners found of these syndromes and named syndrome. That's why we learn these things, but otherwise we don't have. Dysfunctional voiding. Dysfunctional voiding is again a ICC nomenclature. It occurs in any age, and it is typically a dyssynergic striated sphincter. The cause is unknown. Again, the diagnosis is made by urodynamics and video urodynamics. So basically, we have got a situation where in our index case that I am talking, which all of us see, all these things do not just fit in. You do urodynamics, you do MCU, mixed urinating cystogram, and if you have access to VUDS, they just don't fit in. So we are left with a very common diagnosis, which is primary bladder neck obstruction. I think we should make a diagnosis of this, and I think all of us see this. Only thing, as we were discussing, we don't categorize it, we don't document it. But what is PBNO? It is a urological condition affecting both sexes in which the bladder neck fails to open adequately during voiding, resulting in obstruction of urinary flow in the absence of anatomical obstruction. Now, the last few words are important. In the absence of anatomical obstruction. Again, this is a moot point, whether there is an absence of anatomical obstruction, which means it's purely a functional disorder, or is there any change, or are there any changes in the bladder neck which are responsible for the holdup of urine. So the definition probably is a working definition, but not an exact definition, not a correct definition. Because there are many reasons why it may not, this last line, in the absence of anatomical obstruction, may not be correct. So what is the characteristic of PBNO? Physical abnormalities are absent. You do physical examination, absolutely everything is okay. UFR in UDS shows obstructed flow with effective detrusor contraction. That's what I showed in the UDS, that this thing. And cystoscopy is useful. These are the few cystoscopies I do, and you see most of the time you don't find anything major abnormality. Sometimes you find the bladder neck a bit elevated, but the cystoscope always goes in. It never is, there is never obstruction. It's something like PUJ obstruction. In PUJ obstruction, you can never make a diagnosis by doing ureteroscopy, because the ureteroscope always goes into the kidney. It never stops. Same thing with bladder neck obstruction. The cystoscope always goes in. You may find some subtle abnormalities in the form of little elevation or nothing at all. And the bladder sometimes is trabeculated. Even the trabeculations are not very severe. They are mild trabeculations, or many times they are normal. The mucosa is normal. There are no, the ureteric orifice is normal. The capacity is good. Everything is good. Now the incidence, as per literature, is it is more common in males, 30 to 50% incidence of PBNO in males, and about up to 16% in females. This is, the denominator is a voiding, undiagnosed voiding dysfunction. That's the denominator here. Now what is the pathogenesis? How does it occur? Now no one knows how it occurs, why it occurs. It is like CPPS. We don't know why it occurs. Same thing with here also. One of the hypotheses is there is a chronic urinary tract infection in the form of acute prostatitis. It becomes chronic prostatitis, and then it leads to bladder neck obstruction. This is a, again, we don't know whether this is correct or wrong, but then I think we'll never find out, because as you see, the history goes back to years. The patient says, no, I've been having this problem for years together, and there is no way you can pinpoint when it started and what is the exact triggering point. So I think this is just a hypothesis, just to be kept in mind. Now the treatment options, behavioral therapy, I think it just doesn't this thing, even though literature says behavioral therapy is one of them, but behavioral therapy, I think it is mentioned for completion's sake, but it doesn't work. Alpha blockers sometimes work, sometimes do not work. The reason why alpha blockers do not work so many times is, one of the hypotheses is there is a residual skeletal muscle element in the bladder neck which is not responsive, because alpha blockers typically work on smooth muscles, not on skeletal muscles. So one of the hypotheses is that there are skeletal muscles. That's why alpha blockers work in about 40–50% of the cases. Even then they are not effective, unlike BPH, where the effectiveness of alpha blockers is unquestioned. Botox injection has been given and tried in literature. Again, in some centers have done it. I mean, not centers, some people have done it. But the problem is it has to be repeated every now and then, which means about 6 months to 1 year it has to be repeated. But this is one of the therapies. Sacral neuromodulation has been tried, but not FDA approved, not a common therapy. But if you don't have anything to do, no other way of treating, this is one of the options. Bladder neck incision is what, at least what I do is two things. One is alpha blockers. If it doesn't work, then bladder neck incision. That's what I do, and I think probably most of us, to be on the practical the way of dealing with this is that.
Dr. Girish, you have 2 more minutes.
How many minutes? 1 minute?
2 more minutes. 2
more minutes. Okay. I'll just, I'm okay. Why it's not playing here, video? It's playing here, but not there. Sorry about that. It's playing here. So I got some videos where I had a pediatric patient with primary bladder neck obstruction, a female with bladder neck obstruction primarily, and also a male. So the entire gamut, where I have done bladder neck incisions. And the message, it's not showing here, I hope it works. The message that I want to convey is bladder neck incision can be done safely. And in a young male, most of us are wary of doing bladder neck incision because of fear of infertility. But the thing is, in case we had to do it, we can do it without, because I have done, and as long as you don't resect it completely or aggressively, it's you can preserve this thing, ejaculation. So it's a balance between doing too much and too little. They don't have very good outflow after this, but at the same time the ejaculation is preserved. So I have done many patients in young patients who wanted to preserve their ejaculation. So I'll show this thing. There is a problem. It is playing here. So take a Collins knife, make an incision at 6 o'clock position. It opens up the bladder neck quite well, and they have got good flow of urine after that, but ejaculation is preserved. So there is no need to worry too much of ejaculation because we are not resecting the bladder neck. Unfortunately, the videos are not playing. I got a pre-incision and a post-incision UFR, the incision, everything there, but there is a problem there. If the chairpersons want me to stop, I can stop anytime, but I have got the video here, but somehow it's not being transmitted there. So the message that I want to convey is primary bladder neck obstruction is a common entity which I think all of us see regularly, much more common than most of the syndromes that I talked about. And if alpha blockers do not work, don't hesitate either in a male or a female or even in a pediatric group, because I've got all the videos where you make an incision in the bladder neck. You incise the bladder neck at 6 o'clock, the bladder neck collapses, the flow improves, but the only problem is it is not long lasting. After 1 year or 1.5 years, they come back again with the same symptoms, but at least we have a solution which is better than no solution at all. Yeah, just you can have a look at this. Here it's not playing now. I think it either plays here or there. So this is you can see the way this bladder neck, this thing is there. ಹೌದಾ ಹಾಗಿತ್ತಂತಂದ್ರೆ ಅದು TRP ಅಂತದೆ ಅದು ಹಾಕಿ. ಅದು ಹಾಕಿ. ಬೇಕಾದ್ರೆ ಸ್ವಲ್ಪ ಫಾರ್ವರ್ಡ್ ಮಾಡಿ ಇದನ್ನ, ಸ್ವಲ್ಪ ಫಾರ್ವರ್ಡ್ ಅಂತ ಇದೆ 20 ಸೆಕೆಂಡ್. So you can see there's an elevation of the bladder neck. So this patient again had a poor UFR. He came with the typical PBNO, and you make an incision at 6 o'clock position. You see the incision that I'm making. I'm very slow and tentative. Anyone can say, why is he delaying so much? Why is he so hesitant to make a cut? But then there is always a fear of an ejaculation, retrograde ejaculation. But then nothing, over a period of time, I have learned that it's okay, that nothing happens. See this bladder neck elevation? This is a young person. Okay, next you can go to the, okay, just a minute, let us finish this video. See, you see the hesitant cuts of a person scared of creating a retrograde ejaculation. Yeah. UFR, UFR. I got another video of a child, but then I think I'll skip that. Yeah, pre. So this is a child who had undergone vesicostomy, 5-year-old child, vesicostomy with primary bladder obstruction. I did post, go to post, next. Or laser hogi, laser on body. Yeah, this is a child, the same child. I use a laser to make an incision in the bladder neck. This was the first video. So you see there is elevated bladder neck here, absolutely no other cause, elevated bladder neck. You make an incision. So in an adult, use a Collins knife. In a child, I use this because I use a ureteroscope with this thing. Post UFR hogiga. Post bladder neck incision UFR. Yeah, this is the same child. You can see the post this thing UFR, and you can see the vesicostomy there. Okay, you can stop. So, thank you. Thank you for giving me this time.
That was an excellent display.
Yeah.
That the last slide was really, taken up. The last film which you showed that good projectile flow after BNO. Could that be the secondary BNO because he had undergone vesicostomy and the posterior wall fulguration?
Vesicostomy was done because he was not voiding.
Was it for something like PUV which was treated before?
No, PUV was not there. This patient is from outside India. They had done cystoscopy elsewhere also.
Yeah.
PUV was ruled out. And I got all this thing. I did an MCO. MCU did not show PUV. Endoscopy did not show PUV. Once I went in, I saw that there is elevated bladder neck. I made incision, closed the vesicostomy. He's voiding well. Only thing he has CKD.
Okay.
2.5, 5-year-old child with 2.5 creatinine.
The other thing which it comes in my mind is this primary internal sphincter dysenergia. Like as much as we have got external sphincter dysenergia, so whether this primary BNOs, if you don't say it is not a Marian's, it is not due to organic obstruction, could this be internal sphincter dysenergia wherein the incision would help? Because something like PUJ obstruction wherein even incision or the pyeloplasty would help. Like that comes to my mind.
Yeah.
So urodynamic investigation, would it show any features of dysenergia picture? Is it easy to diagnose?
That won't show. Only a video aerodynamics will show that their bladder, the detrusor is functioning well, contracting well, but there is no outflow beyond the bladder neck.
Yeah.
So basically it is impossible to know why it happens.
Yeah.
One thing is certain, it is not usually a congenital condition, it is something acquired.
Okay.
Yeah, young people come, they say it has been there for many years. So most likely it's an acquired condition. We don't know why it happens. And practically there is no use in dissecting it too much because we have got only two options in this patient. Either you give alpha blocker, all of us do that. Once it fails, the only message I want to convey is don't be scared of bladder neck incision. That's the message that I want to convey here.
Okay.
Otherwise, practically we don't have too many ways of dealing with this.
Thank you so much.
I have one little concern, sir. You know, the statement which you put on that if the alpha blocker doesn't work, then you do BNI. I would actually do it other way around. You know, if the alpha blocker works, it becomes a therapeutic trial that, you know, patient will respond to the BNI. So I don't agree to that statement, sir. Second thing, you know, many a time this young, you know, patients, they are still to complete their family. So we give them this alpha blocker so that, you know, they can have drug holidays, they can have ejaculation, because we cannot guarantee after BNI that 100% will have ejaculation. So we give them some time, they complete their family, and once they do that, and then we offer them. So I don't agree to that statement.
No, I never said we offer.
If someone doesn't respond to alpha blocker, then you switch over to BNI. No, sir.
No, but you are contradicting yourself. If they don't respond to alpha blockers, and if they are young people, then we are forced to do BNI, but BNI is not the first choice that anyone wants
Correct.
to do.
But even if somebody responds to alpha blocker, that also it becomes it's a kind of therapeutic, you know, evidence that, you know, he will definitely respond to the BNI.
Yeah, but in that case, I don't switch. If they respond well to alpha blockers, I don't do surgery.
Correct. So there are several other reasons why they want to switch over from long-standing alpha blocker to the BNI. But that statement, I don't agree.
Thank you.
One more small doubt, sir.
I saw you doing a BNI in a child. Is this the standard of care to do a BNI in children, and how safe it is? I just want to know, have you done a study about it?
No. These are all anecdotes. There is no study. In fact, even in literature, absolutely there is no study. You see, everything is fragmented in literature. These are all rare cases. That's the reason why I presented 3. But the message that I want to convey is, it works. You can see that it works. That's all. But the most important thing is, what are the outcomes? Are there any adverse outcomes of cutting the bladder neck in anyone? Hardly anything. That's the message.
In fact, before endoscopic days, I remember when we used to do open surgery, we used to take out a small wedge of the bladder neck. I don't know if you know about it, but it used to be done. After surgery, a wedge of the bladder neck used to be taken out. I think, and then the mucosa used to be brought in and sutured. I don't know if you, I think Mahesh Desai would vouch for it.
Okay. I have no idea.
Yeah, Dr. Girish, sir. Girish,
I have seen it being done before the endoscopic era, and in child, because that time it was going anterior, and you take a weight of the bladder neck and then advance your bladder flap into that, so that the narrowing opens up. It's just like plastic.
Yeah. That was mainly for Marion's disease when we were suspected, and even in small prostates, fibrous prostate, it was very commonly done.
But this was done mostly in children.
Yeah.
So, that time prostate is not even enlarged. So I think what I feel that because what happens in the child, if you have a bladder neck this thing, there is a bladder dysfunction, there may be a back pressure changes, and these are the important factor. So you make a bladder neck incision, and then his flow improves. prostate has a chance to develop later on because child is not yet, the child is in a very young age and the prostate is not developed fully. So as child grows up, the prostate develops, urethra develops and they become all right.
Yeah. Thank you. I think we can go on for the
One more small question, sir.
Yeah.
Regarding this bladder neck incision, especially in the female. So we have got two cases where we have done with the laser with the neck. Inside means just pricking, so that we are tearing the fibers of the bladder neck. So in the fear of incontinence. So that's what we are doing in the adult also.
Yeah.
So one case we have done, it is good result. Primary bladder neck obstruction in the female.
Okay.
So even in case of male also we have not tried, but we are doing.
Yeah, the first one that I saw, her name is Alka. She's a
Police
female.
line.
In fact, I posted in our Urology Society of India female extensive discussion. Because before I did that, I was wondering whether we should do a female bladder neck incision or not. There were a lot of inputs from in the Urology Society group. Ultimately, I did, and I posted the results also. We are done. Whether you do it with a calling knife or a laser, I think it's the same. How does it matter?
I think basically what he wants to say that is the primary bladder neck obstruction is little more common diseases.
Thank you. Sorry. Okay. Thank you, KUA, for this opportunity. And it feels strange to come back discuss about prostatic diseases, which is not my main focus of practice, and that too in front of Dr. Naga and Hasit, who are my colleagues, where we started this urodynamics. My only claim to fame is probably I'm just continuing diagnosing patients a problem with urodynamics, but I don't deal with prostatic diseases. That is my first disclaimer. Thank you. So anyway, this is a very controversial area because as I was a part of the International Continence Society Urodynamic School, and when we were preparing kids for evaluation. So basically, just to give you a brief, urodynamic study is a measurement of the relevant physiological parameters of lower urinary tract to assess both the function as well as dysfunction. So the components all of you are aware of, I don't need to educate you on that, but what is important is we need to have a clear indication for appropriate selection of relevant test measurements and procedures, ensure precise measurement with data quality control and complete documentation, accurately analyze, critically report results. This includes interpreting UDS in the context of patient's history and symptoms. And that is where the challenge comes, because sometimes when I do urodynamics, I may not have all the information, and that is very crucial to have that. So the indications are, you need to identify what the symptomatology to a dysfunction, assessing probably the outcomes of an intervention, predicting the consequences of lower urinary tract dysfunction on the upper urinary tract, predicting outcomes of management, and assessing treatment failure. These are the broad guidelines of indications which are there. What are the risks? Are there any risks of urodynamic? Yes, there is a risk of dysuria, hematuria, urinary tract infection, urinary retention, inability to catheterize the bladder, or a failure of diagnosis, which can happen during a urodynamic study. And what about, so because there is a risk of an infection, is there a higher risk of developing peri-procedural urinary tract infection? In certain groups of people, there is a known risk, which is in the neurogenic lower urinary tract dysfunction, elevated post-void residual urine, asymptomatic bacteriuria, immunosuppression, and in people over 70, where there is a recommendation of an antibiotic prophylaxis. So what is the absolute contraindication? The absolute contraindication is a urinary tract infection, and there are certain relative contraindications. We all know about autonomic dysreflexia. Of course, if we can't catheterize the bladder, then that is a and most importantly, if the patient is unable to comply with instructions or communicate the sensations, then the urodynamic is a waste of time. So men voiding studies, are they worth it? That's the big question mark, because it partially predict preoperative or operative success of a TURP, and unobstructed and poor contractility do less well. That is the concept. But pure uroflow measurements are almost equally good at predicting.
That is the big challenge we have. And certainly pressure flow studies are indicated after failed treatment of obstruction by whatever methodology you follow. Maybe it's a medical management and so on. So, but there is a role of urodynamics in prostatic diseases where bladder outlet obstruction can be distinguished from detrusor or underactivity, can identify detrusor overactivity as a cause of storage dysfunction, useful to guide treatment decisions, especially where surgery is a consideration in certain groups of patients. Patients with urodynamically proven bladder outlet obstruction experience significantly better outcomes following bladder outlet surgery. So, role is clearly in men with LUTS not arising from bladder outlet obstruction will be far less likely to benefit from interventions needed to relieve bladder outlet obstruction. Data shows that men have overall high satisfaction with invasive urodynamic testing. Diagnosis of low compliance neurogenic and non-neurogenic bladders identifies the risk of irreversible damage to upper urinary tracts and guides subsequent intervention. So what I'm trying to say is, this is a physician call. At the end of the day, whether you need urodynamics or whether you can manage the patient without urodynamics, because most of us do a primary uroflow in our clinical setting, and you have a post-void measurement and you have an ultrasound which gives you an assessment of the upper tracts, relative assessment of the upper tracts, and you have the renal function assessment. So consequently, this is only reserved in certain situations where you feel you might require additional information. So what is it that we measure during a urodynamics? Of course, we measure the bladder capacity, which can be anywhere between 300 to 600 ml. Flow rate, roughly to give you an idea, it's higher in the younger males and adults, and lower as we all age. And compliance, which is one of the things which we measure, which is calculated by change in the bladder volume by a change in the bladder pressure, and it is expressed as ml per second. And this, I'm sure most of you have seen. This is an important and criteria for recognizing a detrusor contraction. This again, if somebody is interested in urodynamic, you need to know what is a detrusor contraction, how does it, where does it initiate, where does it stop, and detrusor contractility. And this is the most important thing, where we measure what is the contractility index and bladder voiding efficiency. And these will give you an efficiency of the bladder capacity, contractility, and compliance along with efficiency. So why is it important? Because there are two types of contractions, the two aspects of the contraction. One is the strength of the contraction and how long it is sustained. And so there are various nomograms which are developed, which are automatic, which are calculated nowadays in the latest urodynamic machines. And consequently, we are able to decide whether this contraction is in the normal range, equivocal range, or an obstructed range. So, and we also combine this information with the clinical history and the post-void residual, and with comprehensive information, you are able to arrive at a diagnosis of an obstructed bladder, non-obstructed bladder, which what we call as a high pressure voiding, normal voiding, or an equivocal voiding, or an underactivity, overactivity, and so on. So primarily for diagnosing bladder outlet obstruction, if you are looking at, you are likely to be, if you are looking at only a uroflow, if it is less than 10 ml per second, it's likely to be obstructed. And so similarly, if you are going by an ICS nomogram, which is the most common nomogram which is followed, we had earlier various other nomograms. You have clear definition of criteria, and of course you have the bladder outlet obstruction index also, which is available. So all these are tools during an urodynamic evaluation which we use to understand bladder outlet obstruction. And typically high detrusor pressure and a low flow rate is what you see in a urodynamic. And this also you should understand could be because of a stricture, prostate, or functional detrusor sphincteric dyssynergia. So the diagnosis becomes more complex unless you have a proper history. And always do not overdiagnose. High pressure can be an artifact. Check that free flow is consistent. Repeat test if it is necessary. So these are some of the principles. So it's just to give you a representative slides of an obstructed voiding, which is during a urodynamic study. And this is the ICS normogram which we use to tell you whether it is an obstructed or an unobstructed voiding flow. And this is an obstructed voiding pattern where you see typically high pressure voiding with low flow rate, which is normally what is seen during a urodynamic. And this is a patient with a normal voiding pattern with a normal uroflow, which is no bladder outlet obstruction. And this is again a bladder outlet obstruction. So these are representative pictures of what you see. Of course, you have a complex graph, and this is an equivocal voiding. So certain things we are able to diagnose along with bladder obstruction is detrusor overactivity, which can be associated in bladder outlet obstruction. And detrusor overactivity is present in 60 to 80% of men with lower urinary tract symptoms, and up to 93% of men with urgency urinary incontinence. SUI can be prevalent in men with adult post-radical prostatectomy in some cases, not all the cases. The cause is most commonly due to post-operative intrinsic sphincter deficiency, but may also be contributed by detrusor overactivity, mixed urinary incontinence. So all these are diagnoses which you can make on the basis of urodynamics. So it's a clinician call. This is a detrusor overactivity which is seen during a urodynamic study where you can classically demonstrate detrusor overactivity. And one of the things which we are concerned about, especially in long-standing obstruction, is what is a detrusor contraction? Is it an acontractile detrusor? And this can again be diagnosed very clearly whether the detrusor is acontractile, where voiding can only occur by straining, and this is inefficient and unusual and should also show in the free flow uroflow, which you should. So this is acontractile detrusor, which is seen in the urodynamic study. So, and detrusor underactivity, if you go by the urodynamic criteria, you have a detrusor contractility index which is less than 100%, voiding efficiency of less than 90%, bladder outlet obstruction index of less than 20%, and up to 40% of men with lower urinary tract symptoms may have detrusor underactivity. And the last thing is detrusor sphincteric dyssynergia, where you are looking at a detrusor contraction with involuntary contraction of the urethra and the pelvic floor, typical of patients with spinal cord injury above the sacral level, and detrusor contraction is usually involuntary. This is a neurogenic detrusor overactivity. Do not diagnose if there is no evidence of neuropathy, because it is always goes hand in hand with neuropathy, and this is the detrusor sphincteric dyssynergia which is seen in the urodynamic study. So the take home, ladies and gentlemen, is there is a need for urodynamics only in certain special situations in prostatic diseases. Not all prostatic diseases require, especially if you are looking at only bladder outlet obstruction because of a BPH, I don't think urodynamic is necessary. But if you are looking at diagnosing some of the symptoms which do not correlate only with obstruction, or there is a neurologic injury, then only urodynamic evaluation is needed. Just to give you an overview of where all urodynamic would be helpful, and that's what my presentation was all about. Thank you very much, ladies and gentlemen.
Thank you, Dr. Vasan. Open for discussion. Dr. Nagaraj.
Enlargement of the prostate. Any prostatic enlargement, if you are planning for surgery, urodynamic evaluation is a must.
No, sir.
That's the guidelines say.
I don't think so. I don't think so, sir.
That is.
And we rarely do a urodynamic evaluation for an enlarged prostate. Clinically, when we suspect, by seeing at the various yardsticks, 99% we don't do urodynamic evaluation, we operate. Majority of the urologists. So why that concept of urodynamic evaluation before surgery?
Sir, my first statement was, of course, Naga will take it.
No, I think now it is not there. I mean, we used to do it, maybe 40 years ago. But now I don't think it is necessary for every patient with prostate enlargement or before surgery.
Yeah, I started this thing saying that, first of all, if you're looking at prostatic disease, only uroflow and a post-void assessment along with your ultrasound is good enough. And you get an assessment of the upper tract, you get an assessment of the functional capacity of the bladder by uroflow, and only in situations where you are unable to explain certain situations, then only you would require a urodynamics. Urodynamics is an invasive test. It doesn't add value beyond what you have with those kind of measurements.
Yes, doctor.
One question is, sir, BPH with the atonic bladder, where we advise the CIC. So, what is your advice when we should stop the CIC? And at what frequently we can do the urodynamic repeatedly?
No, see, the point is, if there is no bladder contraction documented and the patient is in retention, he is unlikely to void after surgery. It is as simple as that. It could be a primary detrusor failure or a secondary detrusor failure. So the simplest way is put in a catheter, wait for the bladder to recover and repeat urodynamics. If there is detrusor contraction and if you can document an obstruction, surgery will be helpful. Otherwise, the prostate he may go on CIC. If the prostate is large, there is a school of thought that you still remove the prostate with the hope that he will pass urine, which most often he will not.
My question is, sir, when we should stop the CIC? At what frequently we can do the urodynamic study repeatedly?
No, the CIC, if you are starting, we wait for at least 12 weeks before we redo a urodynamics.
Yeah.
And if it is not working, if the bladder is still not working, which quite often it does in long-standing obstructions or in primary detrusor failure or the so-called detrusor underactivity, then CIC is the answer, maybe for life.
See, if you are asking the question from my clinical experience, what I see a lot of people referring, usually patient comes back between CIC episodes of some amount of voluntary voiding. And that is when you probably think you would want to reassess. But if there is no voluntary voiding in between CIC, I don't think in India anybody sticks to 4 times a day. I have seen, though we advise 4 times a day, people will do twice a day, thrice a day. They don't stick to 4 times a day of 6 hours. They find it little inconvenient. So you will find some men coming back with episodes of voluntary voiding in between, and that's when you need to intervene.
Yeah, thank you. And in fact, in our experience, we have all seen that the people who come with a chronic retention, there were patients with more than 2 liters of urine in their bladder and with a large prostate. Of course, if you are in hurry to do a TURP and or HOLEP and make him void, he may not void, he will never void for some time. And in the past, this was a thing that we used to do 2-stage prostatectomies. And the bladder used to be drained for 1 month continuously. And then the second stage, the prostatectomy is to be done. I think that is wise because that will give again the tone back to the bladder. All that we look forward is to get back the tone to the bladder. When you will get, we don't know. So that till that time, he may have to continue CIC if he has undergone surgery. Otherwise, be on a catheter for 1 month and do the surgery. That gives a more better result than doing early. Thank you.
Thank you. Thank you, Dr. Vasan. We move on to the 4th lecture. Dr. Vinay S. Kundargi from Bijapur will be speaking on CPPS, presentation, evaluation, management, and new treatment options. Over to Dr. Vinay.
Good morning all. Greetings from Vijaypura. Respected dignitaries on the dais, off the dais, senior faculties, delegates, KU members, and my friends. My talk has been simplified by the earlier presenters, by Dr. Rangnath sir. He talked on prostatitis. So I will be talking on chronic pelvic pain syndrome, and 15 minutes is not sufficient to talk over this topic, but I simplified as much as possible to finish my talk and give a final message to the delegates. I'll stick to the time. All of us know that prostatitis is classified as by NIH acute bacterial prostatitis, chronic bacterial prostatitis, chronic non-bacterial prostatitis, and asymptomatic inflammatory prostatitis. And my talk will be, I am sticking to the category 3A and most probably to the 3B. And previously it was called as by various names, prostatodynia, primary prostate pain syndrome. CPPS is a set of symptoms rather than an entity of disease. So it is defined by EAU. There are no EAU guidelines or EAU definition, but EAU has come forward in during limited edition of updated version for the definition of CPPS. They have defined as chronic pelvic pain syndrome is the occurrence of chronic pain when there is no proven infection or other obvious local pathology that may account for the pain. And it is often associated with negative cognitive, behavioral, sexual or emotional consequences as well as lower urinary tract symptoms, sexual, bowel and gynecological dysfunction. Symptoms of pain or discomfort in the pelvis for at least 3 out of the 6 months, previous 6 months, in the absence of UTI, but in the presence of urinary symptoms and sexual discomfort. CPPS require 4 elements to be essential: symptoms occurring in perineal or lower abdominal region, infection or inflammatory changes of the prostate with laboratory evidence, clinical presentation derived or associated with prostate or lower urinary tract, symptoms appearing more or less after an inducible cause. The symptoms usually fluctuate over the period of at least 3 months, and its prevalence is seen anywhere between 2 to 16%, and it is the most common urological disease less than 50 years of age. The proposed cascade of events that are going to happen in CPPS patients are these things, and there are no definitive etiological diagnosis or there are definitive diagnostic modalities to diagnose the disease. So these are the cascade of events. First, it will initiate with infection, immunogen, toxin, perineal trauma, psychological disorders like stress, and body will respond in the form of inflammation and neurological injury. Over that, there will be endocrine mechanisms, and the disease process will propagate through immunological and neurogenic factors affecting, and finally the outcome will be in the form of neuropathic pain. I said earlier, there are no definitive etiological factors, but these are some of the hypothetical etiological factors put forward in the various literatures I found. Infections, CPPS patients will have history of prior sexual transmitted disease. Inflammation will be there only in 1/3 of the patients of CPPS patients. 2/3 they don't have the inflammation, and the degree of inflammation doesn't correlate with the severity of symptoms. As you know that the CPPS patients will have pain, and pain is mediated by nervous system, and they will have neurological causes accentuating the pain. They will have central increased sensitization and decreased connectivity between the motor areas involved in the pelvic floor control and the area of the brain, posterior insula, where the pain is perceived. Endocrine abnormalities they can have in the form of alteration in the hypothalamus pituitary adrenal axis, greater cortisol rise, and blunted response to ACTH when there is stress is there. Continuing with the etiology, and they will have pelvic floor dysfunction or pelvic floor spasm in the form of tenderness in the straight pelvic floor muscles, and they won't relax the pelvic floor effectively, and EMG shows resting hypertonicity and instability, and they have decreased voluntary contractile amplitude. And over that, the psychological factors will be affecting the patient, and they will have greater perceived stress, and these patients they will have sexual, emotional, physical abuse, where at increased risk of symptoms of CPPS. And the patients CPPS they can have abnormal sensory processing, and there is genetics, and genetics has some role to play, and they found that in the literature the biomarker nerve growth factor is increased in these patients. Presentation, they will have pelvic pain, and in the order of preference they will have most commonly in the perineum, and they can have pain in the testes, They can have pain in the tip of the penis, suprapubic region, and they can have dysuria and ejaculatory pain. And they have voiding symptoms, mostly in the form of irritative and obstructive voiding symptoms, sexual dysfunction in the form of erectile dysfunction, and ejaculatory problems and post-orgasm pain. And associated, they will have anxiety and depression. And CPPS patient, they can have associated medical disorders in the form of hypertension and neurological diseases. They'll be complaining of numbness and tingling in the limbs, vertebral disc disease, or they can give the history of undergone previous vertebral surgery. Continuing with the review of symptoms, they will have associated GI symptoms in the form of irritable bowel syndrome and rheumatological disorders like this is the component of chronic overlapping pain syndromes like fibromyalgia and chronic fatigue syndrome. And psychosocial symptoms, they form the major component of CPPS patients. And in 2010, Shosky et al., he has come with a what is called as U point. Initially it was 6 domain, now it is extended to involve the sexual dysfunction. They form the 7-point classification. It is easier to the symptomatic patients, CPPS symptomatic patients, assign them under these 7 symptom domains. The U points, that is U for urinary, P psychosocial, O organ specific, I infection, N for neurologic bar systemic, and T for tenderness in the pelvic floor muscles, and finally they included the 7th one is sexual dysfunction. And with this classification, therapy can be targeted to specific domains of symptoms, and it is helpful in evaluating and whether the patient is responding or not, you can assess after the treatment also. And in 2017, the ICS has come with the standard terminology for CPPS. They have categorized the CPPS patient under these 9 clinical domains: lower urinary tract, female genital, male genital, GIT, musculoskeletal, neurological, psychological, sexual, and comorbidities. And the evaluation of CPPS patients, because they lack proper etiology and till now there are no proper diagnostic modalities. So we need to evaluate the CPPS patients with history and thorough clinical examination. History starts with assessment of what is called as NIH CPSI symptom scoring evaluation. That is National Institute of Health Chronic Prostate Symptom Index. That includes or that categorize the symptom scoring includes pain in the form of location, frequency, severity of pain, voiding symptoms, and quality of life. It has 9 question surveys and total score can go up to 43. A modification of NIH CPI is called as genitourinary pain index. So that includes, along with the NIH CPI SI scoring system, 2 questions are asked related to pain with bladder filling or emptying. And this is the NIH CPI SI scoring system, and the right one on the podium is male genitourinary pain index. As I said earlier, there is because of lack of proper etiology and diagnostic methods, the CPPS is a diagnosis of exclusion. Evaluation must be done to rule out the treatable cause. To meet the NIH definition, patients should not have active urethritis, urogenital cancer, urinary tract disease, functionally significant urethral stricture, and neurological disease affecting the bladder. And these patients require thorough clinical examination. Abdominal examination, look for any tenderness, organomegaly, and genital examination to rule out any hernia, hydrocele, testicular masses, penile lesions. Rectal examination should look for prostate and whether it is tender prostate to exclude acute prostatitis, and the nodularity and signs of CA prostate to look for the further evaluation for CA prostate. And the clinical examination must include the muscle tenderness. Patients during our distal rectal examination, palpation of the muscle lateral to the prostate extended to the coccyx can identify the myofascial trigger points, and if there is any tenderness is felt, these are the ideal candidates for pelvic floor physical therapy and relaxation techniques straight away. And we should do focused neurological examination to exclude neurological causes for the CPPS. And this diagram depicts where the male pelvic muscle examination, patient in prone position, and the elliptical blue diagram depicts the prostate, and the star blue dot indicates anus. The number 11 and 1 indicates levator muscle, 9 and 3 indicates obstetric internus muscle, 5 and 7 indicates urogenital diaphragm, and 6 is our perineal body. The history examination, urine examination are the mandatory investigations, but uroflowmetry, urodynamics, cystoscopy, evaluation for hematuria, PSA is not mandatory. They are optional investigation in the evaluation of CPPS patients. Imaging studies have certain role, but their indication is very minimal. CT scan of the abdomen and pelvis is done in patients with concomitant abdominal pain. Scrotal ultrasound done if you are looking for any testicular abnormality. MRI is done to rule out the radiculopathies. In 2014, Gallo et al. Identified these are the potential risk factors that needs to be identified in the initial history taking in evaluation of patients of CPPS, and these are the modifiable risk factors where the patient can be advised to modify the risk factors or identify the risk factors and eliminate these risks so that the patient will be benefited later in the treatment part.
3 more minutes.
Yes. Principles of management and treatment goals will be the multimodality and individualized management is a preferred choice. Management options should be selected with caution in order to achieve the best clinical results. And treatment should be aimed at not at the cure, but relieving the symptoms and improving the quality of life. That is the main treatment goal in patients with CPPS. And monotherapeutic protocols seldom yields satisfactory results. Multidisciplinary team approach is the highly recommended, and that includes urology care providers, pain control specialists, physiotherapists, psychologists, cognitive behavioral therapies, and sexual health counselors. Treatment of CPPS. These are that's given in the literature, but no single therapy is relieve the CPPS patient. It is based on the patient's individual symptoms. We have to choose accordingly, and the basic medical line of treatment is 3 A's. That includes antibiotics, anti-inflammatory, and alpha blockers. Recently, there is question about the role of inflammation in CPPS, and the antibiotic treatment, the indication for antibiotic treatment is becoming very less and less. And when the antibiotics are chosen, the preferred antibiotics are quinolones and tetracyclines given over a period of 6 weeks. In treatment, neo patients with a duration of CPPS less than 1 year. And repeated course of antibiotics should be based on urine culture, and in the absence of urine culture, the repeated course of antibiotics is not recommended. Alpha blocker treatment, the EA guideline says they recommend alpha blockers when the symptomatic duration is less than 1 year, and the selected uroselective alpha blockers are the preferable. Anti-inflammatories like NSAIDs are used, or any phytotherapies, those have anti-inflammatory, their mechanism of action are used, but as a monoline of treatment, anti-inflammatory drugs are never indicated. There is a role for alpha reductase inhibitors, best used in patients of widening symptoms of BPH along with CPPS, and dutasteride, they claim that dutasteride reduces intraprostatic reflux and widening dysfunction and relieves the symptoms, and finally it reduces the NIH CPSI scoring score. And when I are prescribing this alpha reductase inhibitors, we should have caution when we are considering the young patients. The main component of CPPS, the symptomatic patients, are the pain, and there is a role for medication for neuropathic pain. In the anticonvulsants and antidepressants are used in the form of, most commonly used drugs are pregabalin and tricyclic antidepressants. Bladder specific drugs like pentazone polysulfate has a limited role. It works by augmenting the bladder layer, that is the GAG layers of the bladder, and EAA recommends gives a rating for a weak strength. It is used when it is the patient has primary bladder pain syndrome along with PPPS, CPPS, but alone the role of PPS in CPPS is very limited. PDE5 inhibitors, when there is a patient along with CPPS has erectile dysfunction, they can be used. The first line of management in EAA guideline says that conservative line of management, probably the potential risk factors, you identify them and modify the risk factors in the form of diet and exercise and stress management and psychosocial treatments. It will reduce the catastrophizing and improving the coping symptoms, guided imagery, progressive relaxation training, biofeedback, self-hypnosis and cognitive behavioral therapies. Patient and spousal support is very important in patients of CPPS. And these are advised in the guidelines, the local hypothermia, needle ablation, but they have been tried in CPPS patients but not recommended as a treatment for CPPS. And there is a role for minute role for intraprostatic injection of onabotulinum toxin A to relieve the pelvic floor spasm. Minimally therapies includes pelvic floor physical therapy in the form of biofeedback and pelvic floor retraining. They will relax the pelvic floor muscles and relieve the pelvic floor spasm and ultimately the pain. And as an adjunct to pelvic floor physical therapy for refractory cases of pelvic floor spasm, there are recently updation on injection of local anesthesia or botulinum toxin to relax the pressure points, and prostatic massage has been used in CPPS patient, but not as a single therapy. It is combined with antibiotics along with alpha blockers, and it has given the good results in some patients, some selected patients. And circumcision has been used as an anecdotal surgery in CPPS patients. It is not recommended nowadays. And coming to the newer treatment options, I'll enumerate and finally summarize. The time is up now. So the phytotherapeutic agents used are sunliton, quercetin, pumpkin seed oil, AV prostatin, terpene mixture. They have been given good results in the form of relieving pain, quality of life, improved the quality of life, and total NIS-CPR score is decreased. And possible on the right side of the slide, the possible mechanisms has been given. And recently, there are so many articles on physical therapies in the form of acupuncture, extracorporeal wave therapy to the perineum, thermobalancing, transurethral needle ablation, and transcutaneous electrical nerve stimulation.
Okay, thank you.
If chairpersons permit, I have 2-3 slides only, sir.
Okay. Quickly go through, time is up.
The extracorporeal shock wave therapy, I am not going to talk detail. In the afternoon session, one of our faculty, Dr. Prashant Ganesi, is going to talk on ESWT. It relieves it is delivered to the perineum weekly for 4 weeks, and it relieves the local muscle spasm, stimulate the pudendal nerve, and interrupt the nerve impulses. And the acupuncture is becoming very popular among the patients because there is no side effects and the patient compliance is better. And these are the acupoints depicted in the picture, and it acts to the pudendal nerve, stimulation of the pudendal nerve. We know that pudendal nerve is the main sensory and motor nerve to the perineum, genital sensation control of the urethral sphincter and sphincters. And some anecdotally, the role of Sitz bath also have been given, and some of our senior faculties, they can highlight on the role of Sitz baths in CPPS. I have never used cyst baths in CPPS patients. And these are the surgical therapies when there is a associated bladder neck obstruction is there, and persistent refractable pain along with urinary symptoms are there. Sacral nerve stimulation is advised, and electromagnetic stimulation. And I end my talk with this is the management algorithm. And when you evaluate, all the symptoms are ruled out, no cause is found, and microbiologically culture, urine routine and urine culture is everything sterile, and the diagnosis of CPPS is made finally. And we follow the best method is U points classification according to the patient symptom domain, and the patient needs evaluation and treatment. And if patient is refractory resistant to that, and finally he can be referred to the pain clinic. And take home summary and take home message is, no positive clinical trials monotherapy is useful in CPPS patients. Start with most conservative treatment as possible, followed by multimodal therapy based on patient's individual phenotype. U-point classification offers convenient framework in which to plan treatment, recommending current guidelines for treatment of patients for CPPS according to EAU. Need to see more than one type of specialist in addition to urology. Referral to pain clinic, especially one with a multimodal approach, is also helpful. Thank you for your patient hearing.
Thank you. Very nicely elaborated. Very nicely elaborated. And the whole urology is there in this patient, actually.
Yes, sir. And non-urological conditions are also there, sir.
In fact, this has become what we call in nutshell, the patient is a nut and we become also. And we get lot of headache, when this patient, you see the patient when he walks in, he comes first time, yes, you try to investigate and try to give your all modalities, multimodalities, etc., etc. Finally, when he keeps coming to you, when he enters inside your chamber, you feel like remembering your own good friend. Whom should I send him? So you try to redirect him to another urologist who is a good friend. So this has become the chronic problem for all the urologists. This is what we used to dub it as chronic prostatitis. And my prof used to always teach us, I can name him also, even he had advised to do the prostatic massage by himself. To that extent, the relaxation of the perineum was called for. And I believe in my treatment line, I always ask them to go for a cyst bath. 98% of them get a good relief by prostatic massage and this cyst bath. And of course, in the beginning, some of these doxycyclines, and most of them are all what you call this tricyclic antidepressant drugs. And for the youngsters, we do advise them to to do this masturbation twice a week, and the elderly people, to some extent, they keep doing the intercourse regularly with his own wife. So these are the things which we are streamlining the following protocol for the treatment for them. After studying so much here, but the treatment remains the same.
Yes, sir.
And we never become, fruitful to him also. Thank you so much.
I thank KU and organizing committee led by Dr. Manohar sir for giving this opportunity. Thank you.
Taking just a minute.
I think
now this is a difficult disorder. So when we were studying in our UG days, our urology days, so there used to be such patient coming in our OPD. So whenever he comes, we maintain the hierarchy. We see first year resident, second year, third year, then assistant professor. Then that hierarchy, and the whole OPD discussion was ending because of that one patient. So one fine day when he landed, 6-7 times, that his symptoms were only pain in his terminal 2 centimeter of penis. That was his symptom. So finally, we had courage to take him to our head of the department, and without taking any discussion, the head of the department told him, "Itna nikalna padega." That day onward, that patient never turned up.
That's the fear you have to create it. Yeah.
thank you.
We must recognize this is an entity, and we are treating this incompletely and incomprehensively. It does not fit into what we know.
His talk was on detailed studies, and he has also mentioned there is no specific studies conducted on multimodal basis. With all this vast knowledge, we have been not able to get this. Please, yeah.
Good morning to you all, Dr. Atkal. I agree with Kamath. These are the unfortunate patients. We should have a lot of sympathy and empathy with these patients.
Yeah.
You have to spend a lot of time, discuss with them, tell them, educate them about the problem. This can come. I will treat you, but still it will keep on recurring.
Yeah.
The best way to treat them is educate them properly about this disease.
Yeah.
And how to manage their stress. Because lot of stress-related disease. That's why these are the most important. Instead of going for prostatic massage, so many other things, I think you have to spend a lot of time with them. You have to go into deep.
Yeah.
Then so many things will come out. The patient will come out with so many problems what he faces because of those things.
That is the problem.
Otherwise you should stop practicing.
So, no, this initially in the beginning of our urological practice, we used to have a lot of time. But if you want me to tell the truth,
at the end of the day, also you will have more time. You have to spend more time.
Now for everybody, the time is a very precious factor. And lifestyle management is really, I understand, is very important in all the aspects. To an extent that we tell everywhere, yoga therapy, then meditation, then your lifestyle changes, food arrangement. In fact, I keep on telling them to become a vegetarian. And I told them 3 products which they should not eat. One is papaya, another is drumstick, another is brinjal. So these 3 things I have made it very common because it becomes easy for me to tell. They immediately ask me what should not be eaten.
No.
So 3 things
Prabhu,
you remember.
About food, I tell them to do yourself research.
Can we have this discussion on the tea break?
So
I think
that's
it's
why
time to
I
have
will
a
end
tea
the
break.
discussion here.
Yeah. We have come to the end of the first session and we have crossed the timings by about 15 minutes. I think we'll have a small tea break as the compere would tell you.
Before that, I would request all the chairpersons to stay back and to all the speakers of session 1 to kindly come forward. I request Dr. Mahesh Desai sir to kindly come forward and facilitate our speakers and chairpersons for first session. Dr. S.S. Vasan. Vasan sir. I think sir is not here. Dr. Vinay S. Kundaragi. Chandrasekhar sir. Thank you, Mahesh Desai sir, and thanks to all the speakers and chairpersons. With this, we conclude first session of the day, and we'll have a quick 10-15 minutes of tea break, followed by an inauguration program. I request all delegates to quickly have a tea break and join us back for inauguration. Thank you. welcome you all back. I kindly request all delegates to kindly take their seats so we can resume back with our program. Ladies and gentlemen and distinguished guests, it's my great honor and privilege to stand before you all today as we inaugurate this continued urological education program on benign prostatic diseases being organized by hospitals in association with Karnataka Urology Association. As we all gather here today, we are reminded of the remarkable advancements and the breakthroughs that have been achieved in the benign prostate management domain and the impact it has had and is going to have on our clinical practice. This conference shall serve as a platform for all of us to exchange knowledge, share experiences, and to get inspired by the doyens of Indian urology. Well, I would like to call upon our chief guest of today, Honorable President of Karnataka Urological Association, Dr. Chandrasekhar Rao, sir. Sir, please, sir. Our organizing chairperson for today's conference, Dr. Manohar T. Sir, please. Our CEO of Apollo Hospitals, Karnataka region, Dr. Manish Mattu, sir. Sir, please. Chief Operating Officer of Apollo Hospital, Seshadripuram, Mr. Uday Davde, sir. Chief Operating Officer of Apollo Hospital, Jainagar, Dr. Retish. Our Secretary of Karnataka Urological Association, Dr. Narendra JB. Sir, please. Before we embark on our day's proceedings, let's seek divine blessing by invoking Lord Ganapati, for which I would like to call upon Mrs. Yashashwini, Aishwarya, and Pranita to do the needful.
शुक्लाम्बरधरं विष्णुं शशिवर्णं चतुर्भुजं प्रसन्नवदनं ध्यायेत् सर्वविघ्नोपशान्तये
ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ ನಂಬಿದವರ ಪಾಲಿನ ಕಲ್ಪತರು ನೀನೇ ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ ನಂಬಿದವರ ಪಾಲಿನ ಕಲ್ಪತರು ನೀನೇ ಭಾದ್ರಪದ ಶುಕ್ಲದ ಚೌತಿಯಂದು ನೀ ಮನೆ ಮನೆಗೂ ದಯ ಮಾಡಿ ಹರಸು ಎಂದು ಭಾದ್ರಪದ ಶುಕ್ಲದ ಚೌತಿಯಂದು ನೀ ಮನೆ ಮನೆಗೂ ದಯ ಮಾಡಿ ಹರಸು ಎಂದು ನಿನ್ನ ಸನ್ನಿಧಾನದಿ ತಲೆ ಬಾಗಿ ಕೈಯ ಮುಗಿದು ಬೇಡುವ ಭಕ್ತರಿಗೆ ನೀ ದಯಾ ಸಿಂಧು ವಂದನೆ ನಂಬಿದವರ ಪಾಲಿನ ಕಲ್ಪತರು ನೀನೇ ಏಳು ಲೋಕದಾಡು ಅಡುವಿನ ಇಹ ಪರದ ಸಾಧನೆಗೆ ನೀನೆ ಕಾರಣ ಏಳು ಲೋಕದಾಡು ಅಡುವಿನ ಇಹ ಪರದ ಸಾಧನೆಗೆ ನೀನೆ ಕಾರಣ ನಿನ್ನೊಲುಮೆ ನೋಟದ ಒಂದು ಹೊನ್ನ ಕಿರಣ ನೀಡಿದರೆ ಸಾಕಯ್ಯ ಜನ್ಮ ಪಾವನ ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ ನಂಬಿದವರ ಪಾಲಿನ ಕಲ್ಪತರು ನೀನೇ ಪಾರ್ವತಿ ಪರಶಿವನ ಪ್ರೇಮ ಪುತ್ರನೇ ಪಾಲಿಸುವ ಪರದೈವ ನೀರೆ ಕಾಣೆ ಪಾರ್ವತಿ ಪರಶಿವನ ಪ್ರೇಮ ಪುತ್ರನೇ ಪಾಲಿಸುವ ಪರದೈವ ಬೇರೆ ಕಾಣೆ ಪಾಪದ ಪಂಕದಲ್ಲಿ ಪದುಮ ಎನಿಸು ಎಲ್ಲ ಪಾದ ಸೇವೆ ಒಂದೇ ಧರ್ಮ ಸಾಧನ ಗಜಮುಖನೇ ಗಣಪತಿಯೇ ನಿನಗೆ ವಂದನೆ ನಂಬಿದವರ ಪಾಲಿನ ಕಲ್ಪತರು ನೀನೇ
Thank you. In our tradition, act of lighting the lamp holds a profound symbolism. It represents the triumph of light over darkness, knowledge over ignorance, and virtue over vice. May I now request all our respected dignitaries to kindly join us in partaking the ceremonial lighting of lamp. Sir, please. May now request Dr. Sanjay Kulkarni sir and Mahesh Desai sir to also join us for ceremonial lighting of lamp, sir.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो.
May I now call upon Honorable President of Karnataka Urology Association to address this gathering.
Good morning. Welcome to all the delegates and faculty who have assembled here. As President of the Karnataka Urology Association, I am extremely happy to be a part of this inauguration ceremony for this program, which is titled as an update on benign prostatic diseases. Karnataka Urology Association has always supported all academic activities all over Karnataka, and this is one such venture from a local hospital, from our hospital in Bangalore. So it's a local council kind of activity, and we will continue to support such activities all over Karnataka.
Check will be presented back to the KUA for the utilization of the academic activities in future.
My special thanks and regards to Dr. Mahesh Desai and Dr. Sanjay Kulkarni, our USI President, for making it to this event. I wish the best for the program ahead and all the best. Thank you.
Thank you, sir. May I now call upon our CEO, Dr. Manish Mattu, to kindly address the gathering. Sir.
Good morning, everyone. Members and the respected dignitaries on the dais, senior consultants, members of Karnataka Urology Association, my colleagues from Apollo and our friends from the industry, good morning to all of you. It's my privilege to be here to interact with all of you and be witness to some of the interesting sessions on advances in urology, especially benign part of the disease. Urology is one of the fastest growing specialties in the country today. And not just the fastest growing, it's perhaps the most innovative specialty as well. Over the last couple of years, we have seen newer technologies coming in, average lengths of stay drastically being reduced, complications of procedures drastically being reduced. And I think all of you have a big role in that, in giving much better outcomes to our patients and longer lives and giving high quality of lives to our patients. So I must congratulate all of you who have collaborated with industry to bring this technology to our patients. Apollo Hospitals, Sheshadripuram, Apollo Hospitals, Bangalore overall, I think in the last year and a half has also made huge strides in advancements in urology ever since Dr. Manohar joined us and led that effort from the top, and we've seen some very innovative things happen in our hospitals in the last year and a half. Patient testimonials, patient experience has been just fabulous, and some of the innovative things that have happened in all the hospitals in Bangalore are testimony to the fact that Dr. Manohar, is one of the leading lights in the industry, in the specialty today, and very privileged to have him in our midst. I think sessions like these are very important for administrators, for younger doctors, and I would like to thank Karnataka Urology Association for having conducted this and request them to have these sessions in partnership with all the hospitals in the times to come, so then we can take these advancements to the public forum and use these platforms to spread awareness and communication about what's happening in urology in the country today. Because I feel innovation is important to prevent commoditization of some really niche work that's happening. Patients a lot of times do not understand and realize how is MOLEP, HOLEP better than some of the other procedures that other hospitals are offering. So if you're spending time and hospitals are spending capital in getting that technology in, it's a responsibility also to spread that awareness to patients so that they see the value in the effort that is being put in here. So with that hope, I must thank all of you once again for inviting me here and look forward to such sessions in the future too. Thank you and have a very good day.
Thank you, sir. May I now call upon organizing chairman, Dr. Manohar T, to address the gathering, please.
Yeah, good afternoon. Dear President, KVA Chandrasekhar Rao, our chief guest, CEO Dr. Manish Mattu, and our Vice President and CEO Uday Dauda. Dr. Yatish has left now, and Secretary of KVA Dr. Narendra, and President of USA Dr. Kulkarni, and my teachers, Dr. Mahesh Desai, my mentors, respected colleagues. So on behalf of Apollo and KUA, I'm very delighted to host this program in association with Apollo Hospital and KUA. In fact, our president, he just messaged me on 12th of December, Manohar, can you do a program of council meet? So when is it? He said that probably 3 to 4 weeks. So how is it possible? Okay, then I thought that initially I got an idea of, okay, one theme, let me have one theme, like a one-day program. He said a one-day program, only 50 people, let us stick to 50 people if we want to do good program. Okay, good program means fine. Okay, I sat there in the early morning. I used to get up I get up at 3:30, so I don't know, somehow I don't get sleep after 3:30. So I woke up at 4 o'clock and then consumed my idea of doing the prostatic diseases. So just started searching out all the other specialty and then brought into the benign prostatic diseases, basic to advances, so that we can cover up every range of the prostatic diseases in the. So that way it is conceived that we are able to, today we are able to do that then as a CUE program. So it was heartening that, okay, once we did it, it's not easy that we can do it. But all the faculty, be it whoever, they're all busy people. I just give only one call. Tell me that only one call to all my faculty said, nobody said no. Dr. Kulkarni, for that matter, said, where is the venue, Manohar? Dr. Mahesh is a professor, he said that, when is it? So it was, for me, then it become, okay, my job is done. So all the faculty, Vinay Kundargi, Dr. Vasan, there's so many people, I think all the faculty said that, even Manish, Sinha, everybody said that. No, not even one time, okay, I look at the calendar, it's not there. So I think big clap to all our faculty who has come here. I think because of them, we are able to do this as a program. So in that, I think probably we would have gone there at 50 now, I think, because of the topic. And I think we have crossed already more than 100 registrations with that. And so then we have to move out of the hospital to come and do a decent program in a hotel here. Hope all of you will enjoy the stay and topics here, where you can scientific program. I think management has mentioned that innovations are very important and we need to learn and we have to educate and we have to interact with each other. So I once again thank for the KUA for giving us an opportunity and the support, and they are always behind me, both the secretary and then you go ahead, sir, we will do it, and then there will be the support and with the hospital support, and we have done this. Thank you so much, sir. On this occasion, it's a personal feeling for me, and then I would like to honor a special person on this occasion. I can keep a chair here. This is just a few formalities which I thought that as a student, to the best student, he is the mentor of mentor, teacher of teachers, students of students, and the best student of Urology Surgical Society is none other than Dr. R. Mahesh Desai, my mentor and professor. I request him to please come, and he is the best student still today. He is maybe a professor emeritus, he is everything. And I would like to facilitate on this occasion. Please, sir. So please sit down. Sir, we take pride and honor to facilitate you for all your mountainous achievements and human services rendered to mankind. Apart from being a world-class surgeon, you are a great teacher and mentor to our 145 students who have trained in urology under your guidance. At the Jairam Das Patel Academic Center, where you have instilled the motto of the institute, enter to learn and exit to serve, in the minds of young trainees, and at MPH, where you are the managing trustee and honorary managing director, has produced his endourology fellows till date, many of whom have published prizes-winning essays. Dear sir, you are a master of the most modern treatment for the stone disease, and you are responsible for the development of most modern innovative techniques in percutaneous nephrolithotomy, ureteroscopy, and ESWL, and other allied procedures. You have performed over 14,000 PCNLs, the largest series across the globe. You have pioneered the service of kidney transplantation in Gujarat, along with expanding the use of ultrasound in urology. It was the year 1980 that you have performed your first ever kidney transplant, and since then 3,505 renal transplant plus another few cases have been performed at MPH. Dear sir, You have created voluminous knowledge resource in the field of medicine and surgery by conducting workshops, publishing 255 scientific papers, peer-reviewed, international journals, and contributed over 43 books, for which the present and future medical doctors remain ever grateful. Dear sir, you are deservedly decorated with many national and prestigious international awards. Also, I have chaired many conventions and seminars across the globe, but it is very difficult to mention all of them, but I'm going to mention few of your awarded the membership by American Urological Association in April 2023, awarded Girish Chandra Shah Artpagarian Award for Outstanding Services to Medicine and Social Services by Ahmedabad Medical Association of Indian Medical Association on 16th of July 2023, facilitated by Chief Minister of Gujarat Shri Bhupendra Bhai Patel for the contribution of renal transplant by MPH during the Angadan Mahotsav held at Ahmedabad on 30th July 2023, the Overseas Urologist INAUA Award to foreign urologists who have made significant contribution to urology education, research, community services, and development in Indonesia by Indonesian Urological Association on 16 September 2023. This is just few awards which to read about it. And you created a valuable knowledge and resource. The medical community, the present and future, owes you a debt of gratitude for this legacy. Your accolades and numerous prestigious awards and other things will make one of our students or anybody who is going to listen to you will become the best doctor, and you have won the best top 10 doctors in the whole world, and the best hospitals. You are chairing the best hospital. We recognize that these achievements were made possible with the unwavering support of your family, particularly Dr. Nalini Desai, Dr. Mihir Desai, and Mrs. Renu Chokshi. While others, this letter briefly touches upon your accolades, it is with a great joy and respect that we felicitate you. We are immensely grateful for your acceptance of our felicitation and hope the medical fraternity will continue to benefit from your guidance and knowledge for many years to come. Thank you sincerely. Please. Momento, please. Can put the music. This is a small token of love for you, sir.
This was a surprise. One of my passion was the urology, nephrology, and developing a center of excellence. But then another thing was the teaching students and making them a future urologists, That was my investment. I am a Gujarati. I always look at the return on my investment. Here's my return. I am following him and like him many, but he has done wonderful. When we were doing PCNL, which he has learned, but when he came here, he started doing more flexible urotoscopy. And then he came to Marriott and demonstrated his skill on flexible urotoscopy. I'm doing the ultrasound I knew I'm the master in ultrasound till the time he came and demonstrated the fusion biopsy, which I have not done yet. So it's a pleasure. When you say he phoned every faculty and nobody said no. Why? Because they could not say no. Because he is the person who has been cultivated his commitment to urology, to education, and to spread all that thing, hard work. I'm really proud, Manohar, that what you have achieved and what was his commitment. I didn't want him to leave Nadiad. But he said, my wife has sacrificed for me, and she left her education just for me to complete the 3 years in MPH. Now she has to finish her post-graduation in dentistry. And then that's why he came back. I couldn't say no, because that was his commitment. Both together have done a wonderful job. I'm very proud of you, very, very proud of you. Thank you very much.
I thank all our respected dignitaries for making some time and for joining us on this beautiful occasion. And it was really warming to see MRD sir being felicitated, and it's a great honor for all of us. Well, we would like to extend our heartfelt gratitude to all the faculty, chairpersons for their commitment, and we owe them a great depth of gratitude for them being here with us on this invaluable platform. And I welcome all the delegates, and we shall go ahead with the rest of the sessions. Thank you. Off with our second session, which is on semi-live procedures and invited lectures. I'd want to call upon our chairpersons, Dr. G.K. Venkatesh sir. Please, sir. Dr. Kamath A.J. Dr. H.K. Nagaraj. Ramesh sir. Dr. Ratkal sir. Sir, kindly join us, sir.
It's working. Shall we invite this first speaker, Rohit Joshi from Ahmedabad, who is going to speak on Eurolift.
चलेगा इसमें Good morning, Bangalore. Warm greetings from West Zone. Warm greetings from Ahmedabad. At the outset, let me thank KUA leadership and especially Manohar to have sent us a kind invitation to be a part of this August gathering and a fantastic and meaningful kind of a CUE on a very, very relevant subject, which is BPH. So thank you, Manohar. Thank you, chairpersons, for this kind introduction. I have something to disclaim about is I do believe that TURP is the gold standard, no second thoughts. I do also believe that HOLEP over last 2 decades has emerged as a size independent gold standard. I have an experience of close to 2,000 odd HOLEPs till now for last 12 years. I still do 15-20 nucleations in a month. As a matter of fact, Tuesday we have 5 HOLEPs, so we all concur on that. But this gold standard remains gold standard only if we consider the LUTS component of BPH. My friend, BPH has many more components. And currently what is most relevant is the quality of life. Even in the cancerous conditions, what we focus mostly is the quality of life. So we need to train our minds as a urologist to broaden our perspectives about BPH and its impact on the elderly man. And when we do so, there is a space for mists. Now we all have to agree to it sooner or later that there is a definitely space for mist as much as there is a space in this slide. Nowadays I do see 1 or 2 out of 20 prospective enucleation patients who do qualify for Urolift or Rezum or something of these mists. So broadly we can categorize mist into either tissue ablating or tissue sparing. Today my talk would be restricted on Urolift. I also have started doing Rezum, so there is a good promising technology there also. Now what is Urolift? It's in simple, kind of a sentence if you can describe this, it's a mechanical solution for a mechanical problem and it's the most logical one. Now I'll fragment my talk in this 12 different subjects. Let's start with the history and sanctions. Wu et al. Published the first series in 2011 in Australia. It got approved by TGA in 2010, US FDA cleared it in 2013, UK sanctioned it for 2014, and in India it was introduced exactly 13 months ago during last November. And we are close to finishing more than 150 odd cases pan-India. The basic concept of the Urolift is to create an anterior channel. If you look at the process from the cystoscopic view, what we are intending is to create a channel in the anterior 1/3 compartment. We are not doing anything in the posterior 2/3 compartment. Now, there are 2 kinds of mechanism of action. One is the immediate, that's a mechanical mechanism that we tack the prostatic lobes laterally and create a channel in the midline. So that's a mechanical and immediate action. And this is what we get. On the left side of the slide, you see the pre-implant picture, and on the right side, you see the post-implant picture. And we can see a very good channel through which a urine flow shall happen without any obstruction. Having said that, many of you might have a question that what happens if there is a gradual growth of the prostate and how it can be durable if it is only about mechanical action. But no, my friends, there is a delayed secondary mechanism of action, that's a remodeling, what nature does to us. So there is, this kind of an experiment has been done in the animal studies, and what they see is that the scar that happens, there is an ischemic atrophy that happens. Because of that, even if the prostate keeps on growing, it grows in the same model. So the groove which is created in the midline, it persists even and it remains durable. Now these are the classical indications. Any man with bothersome LUTS more than 50 years, but now we are doing even at 45 years of age. IPSS more than 12, QMAX less than 15, PVR less than 35 ml, 30-50 ml, and the prostatic volume 30 to 80 ml. These are the standard indications. Having said that, there are few contraindications. There are absolute contraindications like active urinary infections, any urethral pathology which prohibits doing anything cystoscopically, any suspicion of CA prostate, my friend. Because in Urolift we do not take any tissue out. So if there is a slightest of suspicion of carcinoma prostate, we need to rule that out by prior hand by doing a biopsy. And prostatic volume more than 80 or say 100 ml, that's what we are right now reserving ourselves to. But in future probably we might extend that indication as well. There are certain relative contraindications like patients who are having acute urinary retention and patients who are having sizable medial lobe, they don't respond as well as the other patient. But it's only a matter of time that we are coming with 2nd and 3rd generation of Urolift where we'll be able to even treat the large median lobe. Now this is the armamentrum. On the left side we have a routine cystoscopy assembly. On the right side of your slide, that's the Urolift assembly. Now, if you have a closer look at this cystoscope which we use conventionally, that's 4 French, but here we are using 2.9 mm cystoscope, and it's an extra long. It's a slender cystoscope, it's an extra long cystoscope. We use the same 19 sheath which we use for our diagnostic scopies, and the extra length is because to accommodate this particular implant. Now, this implant is a disposable one, and that occupies the space for which we need a longer cystoscope. This is the device. We have to, it's a new device, so we need to be a little bit knowing about it in details. So it has got several components. It has got sheath lock, where the sheath fits. It has got a scope lock through which the scope goes. It has got needle trigger, retraction lever, needle safety lock, and there are urethral and release buttons. So these are all new things, but once we get into that, we get a demo device, and then we can get ourselves acquainted to the demo device, and then when we do actually, we can do that without any problem. There are two kinds of components of the implant. One is the capsular tab, which grows out of the prostate and stays in the subcapsular zone. The other one is in the urethra, which is stainless steel, and between these two components there is a polyethylene suture which keeps both the implant in tension, and that compresses the prostatic lobe. So this is in nutshell about the implant. The length of the implant is 13 millimeter. Be careful about this length, because that's when we need to address how much length we have to stay away from the bladder neck. And this is a small video which shows how the different steps of this. First of all, we need to unlock the safety device. Until we do that, we will not be able to put anything. So then we do this, push this blue button, so the needle gets traversed. Then we have to push both the blue and gray button, so the retraction lever comes out, and then at the end we have to push this urethral release button. So the suture gets cut, and both the urethral as well as the capsular tab, they get implanted in the patient's prostate. So this is about all the implant delivery. Now, once again, coming to the procedure, first of all, we need to do a cystoscopy. Many times we might need to do it at a staged fashion, because at times we don't know how big the prostate is, how much length of the prostate urethra is. So we need to do it in a staged manner, because then only we can come to know how many implants, because the cost is a big hindrance in this particular procedure. So how many implants we might require, that depends not just on the ultrasonography, but that depends actually in the cystoscopic assessment of the prostatic lobe configuration and the length of the prostatic urethra. So we might have to do it prior hand. Most importantly, we need to ascertain the prostatic urethral length. Typically, one set of implant on the right and left, it deals 2 to 2.5 centimeter of prostatic urethral length. So if the length is say about 4 to 5 centimeter, we mentally are ready that we will need 2 sets of implant, that's 4 implant. If the length is more than say 6 centimeter, we might need 3 sets of implant. And besides this, we also need to understand the actual anatomy of the prostatic lobes, because whatsoever in sonography, even in the truss, they say the size of the prostate, the configuration of both the lateral lobe, that is the most relevant information we need to seek from the cystoscopy, because more the configuration encroaching in the midline, more the compression we'll have to deliver. So if the prostatic lobes are just touching, we don't need to do any compression, but if they are overhanging, we need to compress it, because the needle length is 21 millimeter. So until unless we compress it, the needle will not traverse across the prostatic capsule. So that measurement of that prostatic lobe is equally important. Coming back, again re-emphasizing that we are going to deal only the anterior compartment. We are not going to do anything in the posterior compartment, because at 4 and 8 o'clock we all know that there are important neurovascular structures are there. So by piercing that needle, we don't want to injure them and give any unnecessary ejaculatory problems or incontinence. So we are reserving ourselves only to the anterior 1/3 compartment. Now the angle of the device is equally important. See, in the first picture, the needle length is 12 millimeter and the trajectory is forward. It's not parallel. So it's forward. So that's why when we deviate 10 degree from midline, that is, decreasing that trajectory to 7 millimeter. Then we go 20 degree, that is when it is practically parallel. So this angle of compression is very, very relevant, because if we do it just keeping in the midline, and we just keep ourselves 1 centimeter away from the bladder neck, this needle might traverse the bladder neck and then come back. And if the moment it traverses the bladder neck, there are 2 complications. Number 1, patient might not get the integrated ejaculation, and the needle get encrusted with the subsequent stone formation. So this angle is very, very relevant. And the compression is equally important. As I said earlier, it depends on the prosthetic lobe configuration. How big are the lobes? Bigger the lobes, more is the compression. The smaller the lobe, the compression needs to be minimal, because if next to the prostate there is a pubic bone, so if you do too much of compression, the needle will hit the bone and come back, it will lead to implant failure. So we need to be very, very rigid about the compression degree. This is the procedure on the left side of your screen. This is a kind of animated version of the whole procedure. We all do this cystoscopy, then we ascertain the prostatic urethral length. We come back 1.5 centimeter from the bladder neck. The reason is the length of that needle is 12 millimeters. So if we keep ourselves just at the bladder neck, we might go through the bladder and come back. So we always have to recede at least 1.5 centimeter from the bladder neck, and then we apply implant on both the sides. So this is what we get, pre-implant appearance and the post-implant appearance. There is an immediate creation of a groove. Same thing we could recapitulate when we did the actual procedure. So this is the view what we see with the implant and the scope going through it. And this is, I am treating the left lobe of the patient. What we are doing is we are simulating this to the wall clock. So what we are firing it at the 3 o'clock or 2 o'clock position. The moment we do that at 3 and 2 o'clock position, then we switch over ourselves to the right lobe of the patient. There we do it at 9 or 10 o'clock. So we never go below 3 o'clock or 9 o'clock. So we always keep ourselves in the entry compartment, 3 o'clock for the left lobe and 10 o'clock for the right lobe. And look at the channel which has been created. And these are both the implant which are in place. But mind well, whenever we do this, now this is the post-procedure appearance when we do a urolift. But a person like me or Manohar who have been doing HoLEPs or MoLEPs for years together, I request all of you not to match, not to imagine comparing what fossa you get after the HoLEP, because you all can get a huge fossa and we can get a super flow. But mind well, it is not just the flow. There are several other components which are equally important. So what we are getting is a reasonably good flow without any other problem, which I'll come in a little while from now. So there are very good results, the IPSS and QMAX improvement is there. Most importantly, there is no erectile dysfunction, there is no ejaculatory dysfunction, there is no de novo incontinence, and the quality of recovery and quality of life is fantastic. Yes, there are few complications, but they are minimal, 3.4%, and 99% of these 3.4% are Clavin grade 1. Retention, hematuria, dysuria infection, they settle down in no time. Literature evidence, without the evidence of literature, we cannot adopt any new technology. We need to see the sustainability of the procedure and reproducibility of that particular procedure in different parts of the globe. So we have a literature for more than now 12 years, starting from 2011 to 2019. And I have handpicked these 3-4 articles for you. These are 1,413 urolith procedures performed across North America and Australia. It was a real world evidence, and it re-emphasized that results are there. The same thing came from the UK, 80 centers, all of them offering the urolith under NHS, 2,000, close to 3,000 urolith procedures. And they also had very good results. One more studies this was actually an encompassment of 15 studies, and it was done by Bhaskar Soman. It was a systematic review, and all the 15 studies re-emphasized that the improvement in the urolift arm was equivalent to the TURP. But this one particular article, which I consider as a breakthrough article, we need to go into little bit of details. There were 80 patients enrolled and studied for BPH6 components across 10 centers in Europe. Now what is this BPH6 study? So there are 6 validated instruments were used to assess different components of the BPH, not just the urine flow. And they were followed up at 2 weeks, 1, 3, 6, 12, and 24 months. Let's look at all the components. First is very, very important, LUTS. Second is erectile function. Third is ejaculatory function, incontinence, and the resumption of the normal activity. So this was the landmark study which I always refer to whenever we compare TURP or HoLEP with urolith. But mind well, we are not going to get that super flow when we do HoLEPs or TURP. We should not have that kind of expectation from the urolith. Yes, and that's why it has found its place in AUA BPH guidelines. It has been make much of sense in our patient population, but when you cater to the population who are executive class who want to resume their activities fast, for them this quality of recovery is excellent. And I had one patient who was seen by one USI president, and whose urodynamic study was done by another USI president, and then that patient came to me and I did a urolift with a very, very caution, because I will have to be answerable to 2 of my lesions, and then that patient was on CIC. He was an executive class. He was flying here and there every month. And at the 3 months, I can proudly say that patient is off CIC and he is doing really well. And both of my seniors, they ultimately felt good about it. The patient did well. Yes, there are a few concerns. Suboptimal improvement. If we compare only the urinary flow, it is suboptimal. Long-term data is still not validated. Still, we are waiting for the 15 and 20-year data. The retreatment rate is quite high. I am very honestly telling this, 13.6% at 5 years. But even in the TURP whole arms, when we see the retreatment rate, 5% for the regrowth of adenoma, 4% for the bladder neck contracture, and 4% for the stricture, ultimately it amounts to the same 13 or 15%. And many times, I personally now have started offering my patient urolift as a bridge therapy. If somebody comes to you and is 50 to 55 years of age, he is equally sensitive about his urinary problem as his sexual problem. So let us give him, give him this option as a bridge therapy. If he does well for next 5 to 7 years, by the time he is reaching 60, the HOLEP or TURP is never gone out of window. We can still offer them that thing, but for that 5-7 years, that quality life will merit to him more than having the superflow with bit of incontinence and failure for any antegrade ejaculation. The biggest constraint in our country is cost. It's a huge constraint, and with some deliberation, we could control it in a way, and now we are planning to get it, somehow the rates of these implants sealed, and we look forward that the company also, does consider that and help us in promoting this technology. So my take-home message would be urolift is a most physiological and most minimally invasive approach for BPH patient. Having said that, let us remind ourselves it's not a substitute for laser prostatectomy or TURP. The selection of patient needs to be extremely stringent. If you do not select your patient properly, this is not going to give you good results. It can be offered to moderate side of prostatomegaly between 30 to 80 grams, at least in the early part of our career. Active UTI and prostatic cancer needs to be ruled out before we venture into the urolift. It is free of bothersome side effects of BPH. So now there are another class of patients where we can give it as an upfront option, take all these compliance issues and all these side effects of the alpha blockers. So we can give them an option as an upfront therapy. It's very patient friendly, and it is equally urology friendly, because if the day I do a urolift, I don't have to look at any irrigation, nothing else. I can have a absolutely peaceful night of sleep. And the downtime is very less. The patient can get back to their day-to-day routine in no time. My friends, that's why whenever all of you go back home today and you start practicing, you start seeing your patient, please broaden your mind, please broaden your perspectives about the BPH patient. He has not come only for his urinary problem, because I tell this example many times in my talk. One time, one typical patient, he was 67, 68 years, he came with his wife, he was a morbidine patient, and then he came, all his bother was about his urinary problem. I offered him HOLEP, I never considered anything other than that. He started doing very well. Next week he came, we did a uroflow, excellent uroflowmetry. After 1 more month, he kept coming, and every time I asked, urine mein kuch problem hai baba? Kuch problem nahi hai. At 3 months, he came with a different lady. And then I asked him, Baba, aap itne baar kyun aate ho? Everything is fine at your end. Why are you coming? What is bothering you? What is your problem? तब उसने बोला कि problem मुझे नहीं है, इनको है. मैंने बोला, who is she? She is my wife. I said the earlier जो आई थी चाची, वो तो बड़ी बुजुर्ग थी. She is my third wife. So she had a problem. So on a lighter note, we can have this kind of this joke cracking. But on a serious note, at times, we do not offer them. Because we take them for granted that at 60 years, who will have erection problem? Let me tell you, many times even I have patients, when they say that at least 3 to 4 times they still have that thing, even we get disappointed and we get depressed. So we need to broaden our perspective. So whenever you see any young and sexually active patients, you can offer this an alternative to medicines for non-compliant patients, very, very high-risk patients, and for patients who are not willing to undergo surgery because of their experience of side effects and complications. Thank you so much for patient listening. I am open to any questions, sir.
Thank you, Rohit. Excellent presentation. So, what is the cost to the patient?
Sir, the cost when it came, it used to be 1,02,000 per implant. So, roughly say about treating a moderate side prostate will fetch him 4 lakh for implant and 1 lakh. So, it will be 5 lakhs. Now, with significant efforts, we could bring it down to 75,000 rupees per implant, sir.
Do they have any pain
because of the compression of the prostatic tissue?
No, sir. The transient dysuria is there, but it settles down with only 5 days of anti-inflammatory and antibiotic. That's done, sir. Yes, sir.
Yeah, Mahesh.
Rohit, very nice presentation.
Thank you, sir.
And it's a really innovation, minimal invasive, and it has real indication in our practice. There was one paper which was published where the size of the BPH was very large, and they commented, looking at the thing, that peripheral zone get compressed and the cells get atrophy, and when you large prostate, chances of cancer prostate occurring is less.
Less, yeah.
Now in this patient, you create a compression and increases the pressure, and you mentioned the cells get atrophy and the thing. So do you find in the literature survey or anything that those patients who had a urolift, did they had a less incidence of prostate cancer?
That's a very stimulating thought, sir. That's the project which we are taking up now, because we need to follow this patient in long term. And yes, that's a very logical kind of question. I'll get back to you once I get some information with meaningful results, sir. Sure, sir.
What is the duration that generally average duration this works for?
Sir, my first case was on 11th April, so I have been practically 10 months, and most of the patients, sir, we follow it 1 week, 1 month and 3 months, and after 3 months we just call them if at all there is any problem. Literature wise, sir, I said the longest data which is published with a reasonable multicentric experience is 8 years, sir, and that 8 years data showed that 13.6% was the retreatment rate, sir. So we have an 8 years data.
Retreatment in the form of HOLEP or?
Sir, there are 3 options. There are patients who have been offered re-implant. There are patients who are offered TURP and HOLEP, sir.
Any difficulty in doing a TURP or?
I had an opportunity to do, sir, one HOLEP in a patient who had undergone implant at the US, and then he came back to me. So the only problem is, sir, there is no problem in the enucleation, but when we enucleate it, and when the question comes for the morcellation, during the morcellation, there is a likelihood that, that tough tissue will fail to morcellate, and it can injure your morcellator blade. So that was the only concern I had. Otherwise, enucleation was straightforward, sir.
In all your patients, you don't use catheter?
Not all, sir. Now, there are 2 sets of patients. The patients who were on AUR, the patient who had a retention, they were already on catheter. We keep catheter for 3 days. The patient who were not on catheter, they were not having retention. We don't keep catheter in them, sir.
Local anesthesia is only in the form of surface anesthesia?
To be very honest, sir, now it has been claimed to be have done under local, but I always prefer to do it in pseudoanalgesia. It's at 10 to 12 minutes. So the patient's comfort is, because it is equally like what we do in trust-guided biopsy. So same thing of that pricking sensation will be there. So I still do it in a short pseudoanalgesia, sir.
What is the cost of equipment?
Equipment cost is not, sir, there is no capital investment. The equipment cost is the scope and the obturator, that's it, sir. Hardly say about 2.5 to 3 lakh rupees, that's it, sir. The cost is the recurrent.
Tax,
sir,
what I mean, not tax, this device.
I'm sorry, sir.
The needles that you use.
Yeah, the implant cost I said, initially it was 1,02,000, now we have brought it down 75,000. We look forward to have
1.2 multiplied by the number.
Yeah, number, sir, yep. Yeah. Yes, sir.
Rohit, isn't there a modification, you did mention it, but where do you exactly fit the median lobe onto? That is my...
Yeah, there are 2 ways to tag the median lobe. If the median lobe is too much projecting in the intravesical kind of thing, then usually we do not take that. But if there is a not too much of intravesical extension, there are 2 ways. Either we can tack it at 5 and 7 o'clock, or there is one more technique which I have developed is we incise the median lobe, we split it into 2, and then we take it on the right side, we take it with the right lobe, on the left side we take it with the left lobe. So that's a jugaad which we have done, sir.
Thank you very much. I have the pleasure of inviting...
One question, sir. So when you are placing an implant, if there is bleeding, how will you?
Yes. So there is a possibility of bleeding because, even slightest of bleeding, even the mucosal abrasion, because the tip of that device is very rough. So when we do compression, even the slightest mucosal abrasion leads to any bleeding, it can lead to havoc, because there is a white line maneuver. Once you start doing, you will understand about white line, because white line maneuver is, we have to see a particular dot. Whenever the white line comes, we have to cut it. So that will adjust the tension. So if slightest of bleeding is there, we cannot appreciate that white line, it will be a big problem. So despite of people recommending that it can be done, the patients who are on antiplatelet, we still don't do it. We always make it a point to stop clopidogrel, because even a slightest bleeding, we can get lost. And one serious complication has been reported in the world was a pelvic hematoma. Because of that needle, some pelvic vessel got ruptured and it led to pelvic hematoma. That patient, they didn't stop the blood thinner, and then subsequently they needed evacuating that hematoma. So be very careful. Let's not take it lightly, because it's a blind procedure, sir.
Thank you.
Sir, as I told you, we have to start from the bladder neck.
Yeah, that he has detailed in the.
In a brief, I'll tell you, sir. I understand your concern. In a brief, I'll tell you, there are two ways. You start at the bladder neck, withdraw 1.5 centimeter, and then you consider 2 centimeter to 2.5 centimeter per set of implants. So if the length is 5 centimeter, 1.5 centimeter you deduct. So now there is 3.5 centimeter. So that will have 2 sets of implant, one on each. If it's more than that, so every 2 centimeter you have to increase your set of implants on both the sides. Thank you so much.
Very much.
Thank you
Thank
so
you
much.
very much. So I have great pleasure in inviting Sir Mahesh Desai for delivering his talk on midline prostatic cysts and ejaculatory duct calcifications, a semi-live presentation and management.
Hello? Hello? Okay. Thank you very much for this kind invitation. Chandrasekhar Rao from Karnataka Association, Urological Association, and of course Manohar. I didn't know you had this plan of felicitating me, but I'm overwhelmed with your gesture. And I'm also proud that whatever you have done and achieved, even in Karnataka, I have been, Bangalore I have been very often, and it has been always the innovative sessions which has been done. So today I'm going to speak on the obstruction to the ejective duct, and that leading to okay. This is press. It's not coming here. Okay. So title is midline prostatic cyst, ejective duct calcification, and the presentation and management. Very often we do the transrectal sonography whenever patients have the symptoms of BPH. You do PR, and then whatever you feel you like to see it, and the best way to do is a transrectal probe. And I've been doing that since 1986, and then many things we have discovered which can relate to the symptoms. And this is one of the common presentation. If you have a ejective duct obstruction, then this is a pointer. So you can have the dilated ejective duct, and sometimes you see calcification. And then that's where you make a diagnosis and do it. Now recapitulating the basic anatomy, posterior to the bladder neck, the bladder neck ampulla of the vas deferens joins the seminal vesicle to form a ejective duct, which opens at verumentanum on either side of the midline. So if you see this anatomy, causes of classification of ejective duct obstruction, causes are congenital or acquired. And acquired may be because of the infection, fibrosis, stone, etc., or malignancy. Types: extrinsic or intrinsic, cystic or fibrous. Now location, if the obstruction is near the verumentanum or in the prostate, verumentanum is level 1, in the prostate is level 2, and if it is outside the prostate under the trigon, it is level 3. And then you can plan your treatment accordingly. So when do you suspect that he has got a ejector duct obstruction, especially during infertility? If patient has azoospermia or the ejaculatory volume is less or fructose is negative, then you do of course transrectal sonography to see presence or absence of the seminal vesicle or obstruction. And the hematospermia or a pyospermia. Hematospermia is most important, and then the painful ejaculation. So these are the 3 common, but usually we find that any prostatic symptoms we do, we examine. And then we examine and see what is the size of BPH or ejector duct and seminal vesicle diagnosis, especially in cancer prostate. All this thing is very important. So transrectal sonography itself is a screening procedure to see anything. Now we have done now 58 cases, and the majority had a hematospermia. We had 6 had a very classical stone and painful ejaculation in 8 patients, severe perineal discomfort in 10 patients. And then when you do the transrectal sonography, you do the transverse section. And when you do the transverse section, you see that the dilated vas deferens or the seminal vesicle is dilated. Sometimes it's convoluted, seminal vesicle gets large, and sometimes you can see as a midline cyst also, which is the ejector duct is dilated and is coming down, and then you can see that. So like this, you can see that the good modality of delineating location and the nature of block. In the fibrous block, truss is essentially normal. So this is the one, and then here is the second one where there is a stone. If ejector duct is dilated more than 2 to 3 millimeter, you consider as a dilated ejector duct. Otherwise, normally you see just a dark line with fat, because what happens, the ejector duct is invaginate the prostate and opens at veru. So along with it, it brings the prostate, along with it brings the fat, and that fat is, you see that, and that's why you can see that. And that fat is very important, especially in cancer prostate. If the prostate cancer invades the ejector duct, that time that fat disappears, the white line disappears. So that is important. Sometimes it's known as a big sign, to do that. But so if it's dilated to 2 to 3 millimeter, then you can see that there is a little stone there, and the seminal vesicle, if it's more than 1.5 diameter, suggests obstruction. The intraprostatic dilatation seen on the truss strongly suggests successful outcome with the TUID or TURAD. Now this is on truss, you can see that the central portion is dilated, but if you go out, you can see the peripheral, there is a calcification, sometimes there is a painful ejaculation, or this may be a hematospermia, and you may see you have a clot inside, and you can see that picture. And this is a very classical picture. This is extending outside. So he has got obstruction, and if you do a sagittal picture, you can see the extent of the obstruction. Here is going up to the mid level of the prostate, verumentanum, you can make it out, and then you can. This is very, very important, because you are going to do the surgery, and that time, what is the level, how far you are going to go, you can measure it. And when you are doing it, you just see how much you are cutting and where you should expect that dilated portion to be there. So ejector duct obstruction is seen in the sagittal view. Another picture, again it is under the trigon. You can see the dilatation on the transverse view. So transverse view and a sagittal view, both are important. First, the transverse view will tell you how much is the dilatation, and the sagittal view, the level of obstruction. So both the things are important. And here you have a verumentanum way back, and then whole thing is long. It is almost a 2 to 3 level obstruction, and here the ejector duct is very long. Sometimes here you have to be very, very careful, because the way you go all the way, you should be not damaging anything. You should be stick to ejector duct. Again, now if you see the seminal vesicle, now look at so much dilatation, because seminal vesicles are convoluted tubes, and you can see the multiple cystic dilatation. And here you can see the right side is dilated, left side is not there. So you can stick your surgical plane in the right side, and then you can see that you'll have to go right outside. If you find the ejaculatory duct dilated before, you will be able to do that. So again, you see the midline cyst with calcification. That calcification is multiple small stones, and you can very well see why he is having a hematospermia or an obstructed seminal fluid. So I feel personally, look at this. Here also you see a dilated seminal vesicle with a calcification. And since I do transrectal sonography as a part of my clinical examination, every patient who has a prostatic lower tract symptoms, I do a transrectal sonography. I have ultrasound in every outpatient department, in outpatient procedure. So this is why you can see and this may be asymptomatic, and still you can see, and then you can decide what you would like to do. So a treatment option, now we have seen the disease is there, obstruction is there. What do you do? Transurethral resection of ejaculatory duct or an incision of ejaculatory duct. So traditionally it's been managed by a transurethral resection of the ejaculatory duct. Problem was is uncontrolled resection, high chance of epididymitis, either chemical or infective, or probability of damage to the sphincter or a bladder neck when you resect that. While a truss-assisted transurethral incision of ejaculatory duct, that's what we developed while we are treating it. We never did a resection, and problem solving the approach to a non-malignant hematospermia due to ejaculatory duct obstruction. So, for example, first we do the transrectal sonography, we evaluate, and then when we see that this is a dilated portion, now you can see the dilated portion with some calcification. You can close the light if possible, and then here we want to puncture it and aspirate. So first what we do, we take a dye and a methylene blue, keep it ready. Right? Methylene blue, I'll tell you why we do it, but dye because we want to see it in fluoroscopy. But first we puncture, and the needle, you can see that it is punctured, it is given way. And you might be sealed that needle there, and that tip of the needle is seen there, and then you aspirate. When you aspirate, whatever fluid you are getting, you put it on the slide and give it to pathologist to read, and then rest you send it for a culture and the cytology. And here you can see the sperms are doing, so probably obstructive type or a low amount of semen, but it got a semen. Now we have injected the dye and a methylene blue. So in the fluoroscopy you will be able to see. Now I am doing a scoping. When I am going to go to scopy, I am going to look for a dye, whether it is, there is a little bluish appearance, and here is the dye. Methylene blue is there. Methylene blue is there, it means it has no complete obstruction. So I know that. Now initially I was using the Collins knife, and then just going on the side of that ejaculatory duct, on the ejaculatory duct, going little deeper because the obstruction was in the prostate, and then suddenly I found that it is opened up. It is opened up. Then you can just either dilate it, use a scissor, or use continue with that. And also you can see that small gravels are there, and then once you have done it, you can see that probably the stone is moving around. You just dilate it enough, and then you little wash out, and you are washing out. The clots are there, and there's the old clots, and then this is the stone. There's another stone embedded in the clot, and then once you see the stone, now you have found the cause. You have dilated the thing, and now you have to pick up the stone and take it out. So it is just an incision, and then once they heal, it makes a flap. So and you are, I mean, beyond the thing, you have not cut anything except tissue above the ejaculatory duct. Outside sphincter is normal. So when he ejaculates, the whole sphincter will contract. So he would not have a retrograde ejaculation. Here either you can use a dormia or you can use a forceps and pick up the stone. All right? So this is the one. So what we did little modification because that Colin's knife was very right angle, you know. So we made it little oblique, say 5-10 degrees obliquity. Now here you can see the ejector duct on the right side, which is dilated. The left side is the other side, which is not inflamed at all, normal looking. Here there is no methylene blue in the bladder. Now here you pass, this is a small probe. You just opened up. There is some debris are there, and then you just first try to open up. It is only close at the bladder neck. So this is another way of doing it. We were just innovating it, how we can develop the thing. And that's how you open up. Now here you can see the cavity, and then there are some tissue which has been adherent to the thing. Now you use a little scissor because you want to make sure that everything is cleaned completely. The methylene blue leaks out. And then of course you can see by fluoroscopy. By seeing fluoroscopy and by looking at the methylene blue, you know where you are going. So you've been directed by this thing. Now here is a patient with a stone, you know, and then is just above the this thing, and then here again your watch. You are again. Now here what you can do, because stone is very near to the ejector duct, you can put a scissor. You can just dilate it. You can just stretch the thing, you know. So if there is a small stricture, it can come out. Now you can see that dilated passage there. You can see that. Now you can see the stone. So we just wanted to dilate and pick up the stone. But we could not pick up the stone, so we just dilated more, so I can pass my endoscope inside and then look at it. And then here is the thing. Whole thing looks clear, but stone has disappeared, you know. So because here fluid is going, you know, so it can be pushed in or pushed out, you know. So after doing that, we didn't find, so we went into the bladder. This is in the cavity. This is the dilated seminal vesicle or ejector duct, which is so. We just washed it up, and then we went into the bladder, and then there was a stone there. So that stone had washed out into the bladder, and then you can pick it up and then do it. All right, so you can pick it up and then do it. Now this is another patient. Again, it is dilated, grossly dilated, you know. And then again, you put a needle. This is the bladder, and you put a needle, and this is just below the trigon, and you aspirate. Of course, before pre-operative preparation is enema, and then give them a ciprofloxacin for a few days before, 3 days before. Now here we are dilated with contrast, and you can see that it's grossly dilated. And again, when you do the scopy, you go inside and then look inside whether the methylene blue is there. Well, we didn't see any methylene blue, so we have to divide this, and we open up. The moment we open up, we can see that dilated portion. So, I mean, there is no need to do a resection. Here it is so easy to do an incision, and you open up, and then methylene blue comes out, and then you wash it up and try to see it. Now, this patient probably had a hematospermia, and then here you can see the whole large cavity of seminal vesicle, you know, and there is a little opening probably of ejector duct, and then there was we just thought of dilating it, and because there was some blood coming out, and then we just enlarged it, and then made sure that it is cauterized. So you can try to find out what is the cause of hematospermia, and then do it. When you have such a large thing, you may have lots of debris and infection or a low-grade infection. Very often we did not find infective complication, but we only found a hematospermia and painful ejaculation or a low grade thing. Now here we have just opened up the opening so that it can do that. After operation, completion of the procedure at 16 French, Foley catheter is kept for 24 hours, patient is discharged on oral antibiotic, analgesic for 7 days. So salient feature is incision under truss and fluoro monitoring, precise and less invasive, cold cutting ejector duct, less chance of fibrosis, lead open ejector duct, heals with a flap mechanism, less chemical epidermitis, and this is the picture. If there is a time, I can show a couple of cases. This is a 29 males, blood in the semen for 3 months, not associated with anybody, bilateral seminal vesicle dilated, thick wall, and this is almost normal. And we did a MRI. MRI came later on. We did. Here, a bilateral seminal vesicle is dilated, and on one side there is a stone. And usually I don't do MRI. This was done elsewhere and came. Now you can see that there's a dilated and there is a stone there, and you can see a dilated procedure. Here we have punctured, aspirated, and sent for culture and thing. This is a truss, and then this is a fluoroscopy, and we injected. And look at that, it's going into the all convoluted. Very often we are doing a radical prostatectomy, you see a quite dilated seminal vesicle, maybe because of malignancy, and sometimes it opens and lots of fluid comes out. So this is the similar thing, except this is a low grade. Very often we can see some tissue coming. Once you do this, and this is we have opened up, and inside you can see. Here what we did is we put a catheter and put a guide wire because it was all dilated, and we just wanted to see if we can put a guide wire and catheter and then go inside, and then you can divide it because dilatation was outside the prostate. So we wanted to be safe. So you can always do all this endourological maneuvering, and then we did a catheter, and then you can see that there was lots of muck around, and the small debris of the stone, and then all dilated, convoluted this thing. Now, you have done this, and then if you have post-operative problem and thing like that, this case I might think now of doing the laparoscopic or a robotic seminal vesiculectomy, and then you can do it. And a couple of cases we have done where a very perineal pain was intractable. In that case, we have done, and then we had a result. Similarly, here we have done, and we have cleared out all the stone debris. We took out with a dormia, and then we have done that. So this is another patient. I'll just go a little faster, and this is the Okay, and so this is the a seminal vesicle dilated, and this is a bilateral seminal vesicle dilated, and then we put a contrast, and then you can see that it is gone. It is outside, and here the multiple fluid levels inside. You can see the whole bladder is going, and then we have to drain everything, and that time we tried to do from the ejector duct. It was not successful. So we tried to put again catheter and a guide wire, but it was not going. We tried few attempts so that we can get into the seminal vesicle. So over the guide wire we can divide either with this thing or with a laser. We can do that, And again that thing got we could fill up again, and so we can distend it quite a bit so that when you do it. Now we changed the technique, and here what we have done, we knew that it was just below the prostate. This is after we have done many radical prostatectomies. We know how much it is adherent to the so if you go anteriorly, there should not be, this guide wire has gone and dilated in the track. We try to open up, but dilated the track, and then again it came out.
So, so now here what we did, it will just come in a minute. Now, I don't recommend this procedure to anybody. This is after doing all attempt, what I did was just above the verumentanum, I made a laser cut in the posterior wall, because this was too big. But I think this was a case where I could have gone and done robotic seminal vasectomy. It was too big to have any use, because this is not going to regress completely. And then probably if the opening becomes small, again he will have a problem. And it was difficult. So here what we did, we just made a small incision, and then we looked at a fluoroscopy. So how far we are away. So fluoroscopy cutting, and then eventually we made incision. And now once we have gone into that, we just open up that area. This is, you can now see that something spacious space is now methylene blue is coming. We made it open a little bit more. Now methylene blue comes. So we have entered the thing. But then no, till that time you are a little bit worried because you are checking on fluoroscopy and you are going. And I just made a little bit more incision. Now anatomically you have opened up the thing. But functionally what will happen next, we have to observe that patient. And here if you see that thing, you go inside, you are inside, you are cleaning up all the methylene blue, and then you see lots of debris and the thing. Now look at that, how far you have gone inside, under the trigone. I left a guide wire just to make sure that. So complication, transient epidoorchitis in 3 patients. 1 patient had a perineal pain, did not get relief with the TUID. None of the patients had an incontinence or a retrograde ejaculation. That was fine. And now we have done 52 cases. We have done totally 58 cases. This is the first 25 cases which we have 24% had a 96% improvement. Hematospermia pre-op 40 and post-op 40 all got better. Painful ejaculation all got better. Severe perineal discomfort 8 got better after thing. So TUID is a variable minimal invasive option for EJDU with a hematospermia. Fluoroscopy and truss assisted cold cutting of the ejaculate duct without disturbing the vital anatomical structure nearby appears to be least invasive and with minimal morbidity. I don't know why he called me here, because he is the one, first paper was published by him, Manor, and this was in 2008, transurethral ultrasound fluoroscopic assisted transfer incision of ejaculate duct, a problem solving approach to non-malignant hematospermia due to ejaculate duct operation, and result the same thing. So paper, you remember that or not? So this is the first paper. This paper was done. Thank you very much.
Sir, honestly speaking, till today, I didn't know this ejaculatory duct and its opening can create so much of problem.
Sorry, I didn't.
Honestly speaking, till today, I didn't know this ejaculatory duct and its opening can create so much of problem. I think key to success of your diagnosis is you yourself doing ultrasound.
Yeah. But that's the habit. You are also doing that, no? I think I teach all my students that in OPD we have ultrasound, and then after doing examination, we look at the kidney, we look at the bladder, after doing PR, we put a probe and see. It doesn't take even more time. If normal thing, you just check normal.
Thousands of such cases have missed because we are dependent on others.
Yeah, I think ultrasound is the 5th dimension.
Yes.
In clinical examination, I think ultrasound, whatever you palpate, whatever you examine, you can see gives you the excellent opportunity for a correct diagnosis. I think nowadays you want to see a small tumor in the kidney is excellently found. I think now we have a treatment for that. So
Very true. Very true. And you have convincingly documented the endoscopically the
Yeah.
problem. Otherwise, it is difficult to accept that so much of problems are there with ejaculated and it's
58 cases we have done.
Congratulations, sir.
Thank you for the wonderful presentation. It is considered as a very, very small subject in the whole of urology, and you have so much of documentation and wonderful demonstration about
Oh,
such
yes.
a small segment of urology, so meticulously recorded, demonstrated, and one picture they say is worth 1,000 words, and one video is equal to more than 1,000 words.
Yes.
So it has demonstrated so well. I appreciate very much. A good applause from the
comments?
audience.
Any comments?
Any questions or comments? So thank you very much, sir.
Thank you.
Shall I call upon the next speaker, none other than Dr. Manohar, to speak about HOLAP, MOLAP in a similar fashion.
ಇಲ್ಲ ಇಲ್ಲ ಇಲ್ಲೇ ಮಾಡ್ತೀನಿ. Thanks the chairperson, respected chairpersons. And hand-to posterior technique, and we have a complete end block also, and end block HOLAP with early apical release. So there are a lot of various techniques which are not able to move the. So this, I mean, there are a lot of variations are there, man, depending upon the technique and the presence of lasers. So mostly the Japanese have come up with the end block techniques as a complete end block enucleation technique. But I think we modified over the period of time. In my experience of about 15 years, I found that prevention of sphincter damage is the goal for success of any enucleation. So this is the sphincter picture in the embryology, which shows that the sphincter in an infant. So this so wide sphincter is there, and then urethra, the verumentum is the red one. So the sphincter in the anterior portion, you can see that portion on the last picture, the sphincter protrudes in anteriorly in the superior portion is much more than inferiorly. So we have to have to preserve that portion. So you have to keep it in your mind when you're doing the enucleation. This slide of this sphincter anatomy is very important. So supra-apical attachment and the apical lateral tissue preserving pillars. So these lateral pillars and the anterior pillars is the anatomical landmarks. And of course, the technology-wise, there is a MOSOS technology which shows that we all know that it is a bubble-in-bubble technology. The upper one is the regular holmium laser. And if you see that the bubble-in-bubble technology is that the energy transmitted is far off. So even if you are staying here, the energy transmitted up to this level. So the same technology utilized in the MOSOS. This is a bubble-in-bubble technology. Whereas the regular holmium laser, you need to go near. Whereas in a holmium MOSOS technology, you can go far away. What does it mean? The MOSOS basically it's the bubble-in-bubble which has the capability of separation. A good separation so that you will land up in an anatomical plane very early and easy. So this is my technique. We have repeatedly modified our technique. Wherein these are the steps. These are the 6 steps which I'm going to show it in the video. Initial follow inverted V incision, and the second step is joining the deeper cleavage of the bladder neck using an inverted. Third step is to second inverted V incision at the 12 o'clock. So first is down, and then in the upper portion and joining the 2 bladder neck inverted V creating 12 o'clock lambda incision, and joining at the 5th step is joining the 6 o'clock and 12 o'clock incision with apical preserving resection. So finally the enucleation of the prostate lobes with the horseshoe maneuvers. So this is the standard steps which we follow regularly, and this has given us a good results. So this is just right away going to the video of the 72-year-old. He presented with failed medical management with recurrent UTI and hematuria. Ultrasound shows another 9-gram prostate and bladder polyp mass, which we resected earlier, about 3 months later, and then PSA is 4.1, and prostate is grade 3, and he came with the retention and recurrent UTI. We have to go on to this is the complete endoscopic. This is just a complete procedure. Cystoscopic view. I think the manipulation of the urethra is also very important when you're doing the enucleation. Respect to the urethra is very utmost important, because in the sake of doing enucleation, we tend to do a lot of manual, and then probably we just try to, this is the scar post TU RBT, and this is the Moses laser, this is a tip. And of course, always identify the ureteric orifice, and then come back and assess the verumontanum. And the incision starts. It's an inverted V incision in front of the verumontanum, the first incision. So this is the kind of separation. You can see that what I'm talking about, the separation, is that the tissue is getting elevated, and you land up in a enucleating zone easy and early. This is the kind of hemostasis effect. The earlier lasers, about 100 watt and P100 and low watt energy with a variable pulse width, has some kind of tissue burning, and it used to possess some kind of charring, and you feel that elastic. It's a gummy feeling. So you don't feel that here. In the Moses technology, you can see that once you get into the plane, then you have to see, you come back and check. There is the anterior pillars. This is the prostate again. When you do a lambda incision in front of the vero, now join the first incision from the bladder neck. You have to choose the proper cleavage. Whichever the cleavage, if you have a median lobe, choose the cleavage which is a deep cleavage. You can do a bilobar or a trilobar if both the cleavage. And that incision to the lambda incision which you have done, V-shaped incision, to make a inverted vertical, and V-shaped incision to make it as a lambda incision. So once we deepen that, you will land up into the sphincter area laterally. So to assess that, now you go to the muscle fibers, capsular fibers here, and the bladder neck fibers. Bladder neck, little bit of muscle fibers will be seen, and then after that, when you come back, the prostate is like a deep incision at the center, so that the incision is like this actually. So keep on deepening till you see the bladder at the same level, or you see a crisscross fibers. And if you can see the come back and see the pillars, and then assess the superior portion. This has to be very gently assessed, because when you try to put it, it's like you can incise this area. So inside just in front of the veru, make a small incision there, and then come back and see that. So that is the sphincter pillar. You come back and assess where is the sphincter zone. There is a sphincter zone, and then go in front, make a shallow incision, little shallow incisions, and then you extend that on either side as a V incision, again superiorly V incision. So you have to be stable at this portion. You should not come back and incise the sphincter. So once you do the incision there in front of wherever the superior line, then incise this, again the V lambda incision is created, joining the vertical incision to the V incision. You can see that technology-wise, the separation is excellent. Once you put an incision, then the prostate starts getting separated into 0.5 to 1 centimeters on either side. So the procedure basically it becomes quicker by 50%. So our timing of surgery has become less by, in fact, 50%. Initially, if you are doing about 60 minutes, the procedure takes about 30 minutes for the same gland. So just have to keep in touch. The superior portion is very important, because we saw that the sphincter area and the superior portion is very wide, and then so leave behind some kind of prostatic tissue at this level. So I'm just going laterally now. You can see a little bit of tissue in the roof at 12 o'clock. So without touching that, because the sphincter may get stretched, even if you don't cut it, it may get stretched. So we are going on either side to assess this. But this thing is possible. But suppose if you have a laser where you tend to have more bleeding or more charring, then you won't be able to identify this. So the superior incision is very important. These two are these are the actually the crucial part of the procedure in the superiorly, assessing the come back and assessing the sphincter and stay very close to the in front of the sphincter at the level of the vero, and then keep on assessing the sphincteric pillars. In fact, this is not much edited. In fact, this is 110 gram prostate. Lateral lobe was more in this case. I'll just fast forward the. When you make the incision, then you have to widen that. So you have to come laterally. So start incision now, horseshoe-shaped incision. This is a hockey stick incision starting from bladder neck. You have to come back into the midline. I'm just doing come back to the midline and see the summit of the prostate, lateral. So come back in the midline, see the summit of the prostate. Again, come back in the midline, summit of the prostate. So you will get into that. Otherwise, you will get into the prostate. You will just cut through the prostate when the prostate is much bigger. So that's why that maneuver, I'm doing that. When come back to the midline, assess and don't cut it. Come back to the midline and then cut it. Then when you come to near to the sphincter, then you will just dip down. So this is the area where semicircular incision towards the sphincter. So once you're in the plane, then automatically the prostate starts giving away with a enucleation effect. Now then start joining from the bladder neck again. So try to preserve the bladder neck as much as possible because you tend to cut it laterally than medially, so that it's better to cut medially so that you have a better control of the bladder neck mucosa, which will prevent further complications like bladder neck contracture if you tend to try to do the more of blood. Now, this is again important. You see superiorly the sphincter is seen there in front of the sphincter, in front of the, where you just make small incisions over the mucosa so that you get a guideline to where to incise that in front of. This is the sphincteric pillars. I'm just doing the incision in front of the sphincteric pillars. See that even if you have small incision, the tissue is getting separated and giving the way there. Not only the technology, but of course the technique is also important. And join these two areas. This is actually the climax of the procedure, is that joining the superior and inferior without even stretching the sphincteric pillars. So once you do that, then you can incise that portion particularly, completely incise and join the complete area. So that this will, the lateral lobes get released, apical release, this is called as. Some people will do this earlier also, very early apical release. But I think it's anatomically easy to do it, easy to learn, and easy to perform when you do a superior two incisions. So to join the, in front of the apex, the sphincteric pillar incisions, which I was mentioning in my technique. This year we have to, little patience here to see that there is no extra manual movements, because this can stretch the sphincter again. Probably when you see in the workshop, you might have seen that we don't move the hand at all. It's just cutting. The laser is doing the work here. It's not the mechanical movement. If you try to do the mechanical movement, then again the urethra get damaged, urethral superior pillars will get damaged, and even the sphincter will get demonstrated. So no manual movements. It's only the laser which is doing the cutting, and automatically the flow itself, that is the sphincter. That's the sphincteric pillars, the superior sphincter, and then sphincteric pillars. So this is procedure, and after that you do the horseshoe-shaped incision, and then the procedure is, I think this one lobe I show, and then I move forward because we are lagging with the time. So then you just have to start from the bladder neck and then come back. So because once the sphincteric pillars are released, then there won't be any. Now you can do a little bit of manual movements if somebody wants to do it, but it is not required. So again, see that. There is the sphincteric pillars, and then there is the superior portion of that 6 o'clock. Now going to the opposite side. This is the, I'll just fast forward this. So just go on doing the horseshoe-shaped incision so that you reach the bladder neck below, and then come back from bladder neck from above. Come back and encircle the prostate, which is enucleated, and then go all the way around there, and then towards the, so it automatically it lifts up the prostate because of the weight itself, it falls forward and gets auto-enucleated. So that is the, same procedure has been done here on the opposite side, and I think I'll not take too much onto this. Same principle, whatever I showed that, and I show you the portion of the prostate which has been removed and how does it looks. The same principle has been carried out here. And once the prostate is been, this is the fossa, how it looks. And you have to assess that, and you will come back and just observe, make it upside down, see for any hemostatic effect. Then come back and see this is the verumontanum, and that is how the sphincter pillars appears. And that's this patient wired well without having any bleeding or catheterization time. We remove the catheter usually within 24 hours, the next day morning. So this is one more patient, just to show you that dual antiplatelets. This patient had a cardiac PTCA 3 weeks back, but they wanted to stop the medicine because he had a recurrent arthritis and a urinary tract infection. We had to go on to the procedure because the cardiologist was not very willing, but then this is again showing the same principle of that. We used a Moses laser here, and there's the sphincter pillar. I just don't want to go into that. I want to show the fossa, but what I was trying to tell is that this can be done very effectively because of its kind of hemostasis, and once you all land up into the proper plane, the hemostasis is excellent and the separation of the tissue is faster, and our procedure is also become very faster. You can see that this is the Moses laser, which actually the patient is on dual antiplatelets. We tell them that if the bleeding occurs, we are going to stop it, but if you stop it and you have a cardiac problem, then it's a different issue. So this is the end portion, how it looks. I just fast forward this. So that is how it looks, and this patient didn't have any bleeding at all after that. So this is the kind of fossa you get it in ultrasound always. So this is what the fossa you get in post-HOLEP, and this is the kind of flow one can get it. And we have done quite 3,000, more than 3,800 cases, and we have done even on patients on antiplatelets and dual antiplatelets and anticoagulants. And of course, age range is up to 97 years, oldest patient. Size of the prostate, 27 to 375 gram prostate. Whether we extended ourselves, we have done even up to 475 gram prostate. This is the second stage, 575 gram prostate. And the final last one, I can blow my trumpet that I've done this single stage, 687 gram prostate. So size is not a limit. And this is the complete operative time, enucleation time, catheterization time has completely decreased, especially when we started using the modulated lasers. It becomes half the time. Instead of 92 minutes in the first photograph, you can see that at 54 minutes, statistically significant with this kind of modulated lasers. So we can try and reduce the hospital stay, catheterization time, enucleation time, and operation time. So the complications of dysuria is very minimal, especially with the Moses modulated laser. It's absolutely nil. The patient immediately after that, earlier lasers used to produce some kind of dysuria, but then with pulse modulated lasers, dysuria is drastically reduced, and interventions like recurrence rate is 0.08%. I have not come across any recurrence so far, and recently. And then of course stress incontinence, we may not say that it is due to some technology role at play, but I think technique is one important thing. Conventional robot technique, when we started, we had a 26% stress incontinence. When we modified into conventional place, apical lateral tissue preserving resection in the middle, then it dropped down to 4.5%. When we started doing the apical roof and lateral tissue preservation, then it became 1.5% immediate. So of course, they all recover within 3 weeks, and this is the status what we are having at 3 months in the 0.1%. And then this actually minimizes the mechanical stretch of the sphincter, this technique, and minimizes the stricture rate because there's no movement. Minimal stress incontinence technique can be easily adopted, and you can do, we have done even the mini MOLEPs using a 22 French scopes, and it's a size independent and easy learning curve. And advantages of Moses technology is 25 minutes. In fact, I would rather say 50%, 44% high enucleation efficacy, 50% more hemostasis. I would rather say 70% more hemostasis. This is the literature which says there, and effective on patients with antiplatelets. So in conclude, apical roof and lateral apical prostate tissue preserving resection technique using a pulse holmium laser seems to be the best technique for early continence. Holmium laser, high pulse lasers and pulse modulated lasers helps in good hemostasis, less operative time, and no or minimal dysuria, and least recurrence among all the procedures mentioned in the literature. Learning the technique and expertise makes the procedure a new gold standard for BPH of any size and effective in patients with antiplatelets. Thank you.
Thank you very much. As always, you have a wide experience in HOLAP, and having zero experience in handling prostate with lasers, I have always relied on the person who does the laser rather than laser itself. So if there is any comment or question from the audience, I would invite.
Manor,
Sir.
After putting the laser, wouldn't you use a pushing technique so that when you get the plane, so the adenoma will enucleate it faster? Only using the laser and enucleating. How do you feel about that technique?
Yeah, that's what I said. I was mentioning mechanical movement usually produces some kind of mechanical stretch to the sphincter. So in fact, when you go into the urethra, I mean, my main aim is to just mishandle the urethra, no manipulation. Because even when you're moving the urethra all around mechanically, the superior portion, the 12 o'clock, just opens up. When you come back and see, the superior portion was intact because it just has splattered. You can see a wide fibers kind of thing. So I think respect to the urethra is also important if you don't do the manipulation. In TURP, you don't do so much of manipulation. In TURP, you don't do so much of manipulation. In HOLAP, you tend to manually go this side, that side, you will be moving around. That is the one main reason for stress incontinence according to in my books, if you ask me. Second, all those things, I think probably that is the one, respect to the urethra, and then little of modification of the technique, we are in there.
Thank you.
That's why I don't do the mechanical.
Sir, taking that further, sir, it's very inviting when you first do that V incision, just distal to the Veru, it's a very clear plane. So it's a very kind invitation that you keep on just pushing the lobe and it gets automatically reflected. It's very inviting, but one should not do it because the reason, once you do that, the entire prostate lobe moves toward the bladder, and you are working at 5 and 7 o'clock, while the stretch happens at the 12 o'clock, which you rightly pointed out. So once you do it by enthusiasm, you keep on doing it, and by the time you realize there is all fluffy fibers happening at the 12 o'clock. So that's why if you are not doing early apical release, you don't do too much of dislocation of the lateral lobes. Otherwise, it's very inviting because that's a plane which is automatically available to each and everyone.
Stretching, talking about, I was trained from 67 onward, and then at that time the majority of the prostate we used to do by millions prostatectomy. In that, we just make an incision and then put a finger and stretch it out. But we never had any problem with the thing. We used to take it out, and actually I feel that millions was an excellent operation where under vision you could do and take it out and then suture it and then do it. But Manohar, you have done TURP and you have done laser now, So from your technical point of view and a patient point of view, which one you think better, or is it both similar?
I feel HOLAP is the best.
Because of the less bleeding and...
less bleeding and faster and nil recurrence and no bleeding. Catheterization time is only in hours actually. TURP also have been doing that, but then the recurrence rate was little high, and we cannot do on all range of patients what we are getting it here. Most of the patients now, I think in metros, they're all on, when everybody after 50 years are on ecosprin or clopidogrel, and so I think we are forced to do the laser when I came here and then start venturing, and I found this is, technically speaking, I don't do TURP at all.
Okay, thank you.
Thank you. Do you discharge the trial ward the same day and discharge the patients, or you keep
next
them
day, next day morning?
Because with this MOLEP technology, they say they
daycare, by default we had about 4 or 5 patients where catheter came out on itself and they went. See, even if it's a single clot, they produces some kind of...
I think you can discuss with them because...
Yeah. Thank you. Sure. Thank you.
I request Dr. Prashant Ganesh to present his thing on ESWL in pelvic pain.
Good afternoon, everyone. So, the topic of discussion is utility of shock wave lithotripsy, low intensity in chronic pelvic pain syndrome. Chronic pelvic pain is not just a pain to the patient. I think in the advent of treating the patient, in the process, even the doctors feel the pain because the patient keeps on coming again and again, and after all the modalities and all the treatments fail, still what next comes to mind? I think we just wanted to highlight this, that this is one of the non-pharmacological modalities of treatment, and it's just upcoming, and our experience and other advantages of this technique. So, just a brief introduction of the physics of this. These are the energy sources where we can generate, that is spark discharge, piezoelectric method, and electromagnetic, which produces focused hard waves to a particular point where the therapeutic area of therapeutic interest. And radial shock waves, as you know, pneumatic, we use in URS. So, what to see, the physical parameters are important here. The focal volume, the amount of space over which the shock wave induces the therapeutic effects. The total energy is the amount of acoustic energy delivered in one shock pulse. And energy flux is important because measure of the peak pulse energy within a focal volume. And mainly we talk in terms of energy flux density. This is the actual terminology where we use while delivering the shock waves to the patients. That is a measure of energy flux per square area, that is in square millimeter. So, as we see in this slide, the low and medium, that is from 0.08 to 0.28, is the area where the maximum benefits of cell repair and regeneration and pain therapy was happening. And if you extend the energy flux density per square millimeter, it is more of a use in musculoskeletal and physiotherapy in other orthopedic treatment, and still more flux density is used in lithotripsy. So, what are the biological effects? How does it benefit to the patient? So, basically it is a complex reaction, complex interactions of interleukins, chemokines activation, and other growth factors leading to anti-inflammation, neovascularization, cell proliferation, cell membrane and tissue permeability, and nerve regeneration. These are the proposed biological effects which may lead to decrease in pain of the patient. To summarize, basically what technique we are going to discuss is a non-invasive technique by targeted waves, which produces direct mechanical stress and growth and violent of the cavity, collapse of the cavitation bubble, microbubbles implosion, which cause in terms of neoangiogenesis by resident stem cells activation and chemokine attraction and growth factors. And finally, shockwave also enhances the Schwann cell mediated nitrogen nerve repair, and still further studies are required. Exact mechanism is still not understood. These are the contraindications where should not use this shockwave in lung FYCs, hemophilic therapy, patients on malignancy, metal implants, and infection, where we are not using this shockwave in these patients. The adverse effects are very minimal. It's maybe a transient pain, subcutaneous hematoma, and we are not discussing the radial shock waves here. So, coming to the topic of interest, extracorporeal low intensity shock wave therapy in pelvic pain. I think my friend Vinay Kandurge has already discussed this. Symptomatic patients, most of the 90% of the symptomatic patients of CPPFs are type 3B, and which are diagnosed of exclusion when all the modalities and the fails to determine the cause of the disease, and pelvic pain at least for more than 6 months, lower abdominal pain, genital pain, painful ejaculation, lower urinary tract symptoms, psychosocial impairments, erectile dysfunctions in those patients. These are the diagnoses we are going to exclude. And treatment discussed in the morning. Mainly monotherapy has failed, multimodal therapy 3As, that is alpha blockers, antibiotics, and anti-inflammatory. There is some benefit according to viewpoints only when we phenotypically strategy and give patients, only few patients are benefited. And phytotherapy, not exactly, it will become a second choice. And second line is PD5 inhibitors, muscle relaxants. Everything has been tried. At last comes non-pharmacological therapies like acupuncture and extracorporeal shockwave therapy. So extracorporeal shockwave therapy has already also been used in, apart from pain, in Peyronie's and erectile dysfunction in urology. This is the first study, Zimmerman et al. In 2009. He demonstrated the ease and safety of this technique and telling no complications, follow-up was uneventful, marked decrease in pain, improved quality of life, better voiding conditions as compared to the no treatment group, probably because of the reduced passive muscle tone, hyperstimulating nociceptor, interruption of flow of the nerve impulses and influencing the neuroplasticity of the pain memory. So the treatment protocol which is usually followed for this modality is usually we apply 3000 shockwave pulses, change and move the position of the handpiece during the treatment after every 500. That is the energy we use, 0.1 to 0.25 millijoules per square millimeter, that is the energy flux density. We slowly start increasing in incremental doses of energy, starting from 0.1, slowly up to 0.25, and at the same time we can increase the frequency from 3 to 6 hertz as the patient tolerates. So normally 4 to 6 treatments weekly, weekly one schedule, one session for 6 weeks or 4 weeks we can give. So how to start? First we do an ultrasound to determine the depth of ultrasound of the perineum, basically to determine the depth of the prostate, and there is an attachment. This is the handpiece delivery for the shockwave therapy. That the handpiece looks without standoff as like that, and with standoff 1 and 2. Why standoff 1 and 2? Because when we measure the depth of the prostate in the ultrasound, if the standoff measurement is anything more than 5 centimeters, then we give the therapy without standoff. And if it is 1.5 to 3, then we use standoff 1. And most of the ESWT in our setting, we are delivering with standoff 1 because it is about 3 centimeters when we do an ultrasound measurement. And standoff 2 is mainly used for Peyronie's and erectile dysfunction. So usually when we attach the standoff, we drop there is a silicone oil provided with that for the better energy transmission, and also ultrasound gel has to be used on the patient for optimal transmission. So how do we position the patient? It's very simple. It's an OPD procedure. Patient walks to the OPD. You make the patient lie comfortably and just lift flex the knees in semi-flex position. Carefully lift the scrotum and ask the patient to hold like this. And do an ultrasound. Just measure the distance from the skin to the prostate area. So in this case, it was about 4 centimeters to standoff 1. So then start activating the shockwave therapy on the perineum. Usually we start on one side of the perineal body and try to move slightly, focusing the prostate and periprostatic tissues. This is after every 500 shock waves, we try to divide into 6 areas and give towards the prostate, covering the entire prostate and slowly increasing. As we are giving for every 500, we start from 0.1 millijoules to 0.25 and starting from 3 to 5 hertz. As the patient tolerates, we keep observing the patient's face. If as per tolerability, some patients tolerate even up to 0.25 and 5 hertz comfortably, but some patients will tell they have some mild discomfort. So we try to maintain that energy density in those patients. So this is just a demo video which we have made. This is how the apparatus looks like. The patient has just been made to lie down with a semi-flex position. This patient had tried medical therapy, everything has failed. He has been suffering this for more than 3 years. So that is initially we do an ultrasound to determine the depth of the prostate, to choose the standoff. Frequency, it doesn't matter. Frequency can be from 3 to 5. But frequency, it doesn't matter. Frequency can be from 3 to 5. But what we are seeing is the energy really matters. The more the energy, the patients are responding better. So once the 3000 shocks are over, the treatment is complete. So this is how the standoff looks like. This is the standoff 1. We place a silicone oil and place it to the main piece and attach to it. And delivery. So post procedure, it is quite uneventful. The patient immediately sits comfortably, and it's very easy to perform. It's a non-invasive technique. Hardly it takes about 15 minutes OPD procedure. No anesthesia is also required. So what we have seen is we started from July 2022 actually, this to December. We have given to about 30 patients in the OPD setting after screening out all the other treatable modalities, and these are the inclusion in this study what we are trying so far. So 18 and above, diagnosed with chronic pelvic pain, more than 6 months with no identified causables, refractory to all the other medical therapies, exclude all the anatomical abnormalities, infection, cancer and surgery. So weekly we are giving 6 weeks. Every week we give 3000 shocks. So as we discussed already, as increasing as tolerated from 0.1 to 0.25. And the reason for changing the position, these are the 6 areas where we try to give shockwave lithotripsy, mainly to broaden the therapy effect and the reperfusion of prostate, and to improve the hemodynamic profile of the prostatic artery by neoangiogenesis, and forestall the side effects, superficial. So basically we are following with NIH CPIC and alerts by prostatic scoring system, and quality of life by American Urological Society Association, quality of life due to urinary symptoms. And the secondary outcome will be sexual function assessed by IIF-5 and erection hardness score. So we do ask these questions to a patient before starting the treatment and at the end of the treatment, that we keep it as a baseline, and follow-up we are doing with after 1 month and 3 months. That is our 4th and 12th week. So far, this is the data. So the total score, actually it has shown a great improvement of CPSS total score from 27 to 17. And secondary outcome is there is improved erectile function also, which is an added benefit from IIF-5 from 15 to 20 and 3.11 to 3.42 in EHS. And alternately, LUTS also improves. So these are the previous studies. In all these studies, only 2 studies didn't show any improvement, that which was conducted in 2013 and 14, which was a small study of 19 and 40 people. So this is the latest 2017 and Ryanigi 2020 study, where all are showing good effects of LUTS improvement, pain improvement and erectile dysfunction. So this is a study with a 12 months follow-up. It was still maintained after 6 sessions. This is the article published in 2023. They have tried improving the number of sessions. Here they have tried giving for 12 sessions, weekly for 12 weeks. But there was no comparative difference found in 6 sessions and 12 sessions. Probably we can assume that 4 to 6 sessions is the ideal treatment schedule where the patients are showing significant improvement. And our study showed, already discussed the beneficial effects in pain, erectile dysfunction and quality, which is almost similar to the UN et al. This is a meta-analysis consisted of about 5 RCTs, randomized controlled trials, and 280 patients, which showed improvement in 4 and 12 weeks. But in 24 weeks, there was not much of difference. That effect was maintained. So limitation in what we are trying to study is, it's a single center, ours is single center studies, lack of external validation, still widespread generalization is required and more scientific rigor is required. It's a small size, sample size, long-term benefits are yet to be assessed, statistical constraints are there, multi-cohort studies and larger studies are yet needed to better understand. So I would like to mention one incident like what we experienced is we tried giving for 2 female patients similar way, who accepted it, who had a lot of pain, unexplained pain in the pelvic area for more than 3 or 4 years, and all the modalities have failed. 2 patients so far we have given, and both of them has showed significant improvement in pain. So this is just a concise picture of what we discussed just now. Thank you. So,
just one comment I want to make.
yes, sir.
One comment. Here, the CPPS is mainly a pain, pelvic pain, which the patient comes. The urinary symptoms may not be much. So, how IPSS score we can apply here?
So
we want the pain to go, that's all.
Sir, so if you go through all the CPPS patients, at least 20 to 30% of them will be experiencing some form of irritative LUTs. So this was just an additional finding what we are seeing, that it has multiple advantages. And moreover, this technique has no side effects. It's very easy to do. And in refractory patients, when all the methods have failed, I think we should try to consider this.
Okay.
Yes.
Yes. Does this have any effect on the sphincter? Because you are directing your shock waves on the internal sphincter. So any effects, I'm not sure if you have experienced in your patients, or is there any literature which says there is a incontinence, a mild incontinence?
So far we have not encountered any incontinence. In fact, we have encountered improvement in the lower urinary tract symptoms actually. So that shows some kind of relaxation because of the stimulation of nociceptors. Some kind of mild relaxation happens, and the patient, even with a very obstructed floor or even a lot of irritation, goes away. Even with the ease of pain, he might, maybe the LUTs is improved. Sir, I remember one patient coming with infection. I think when we did a semen and urine culture, it came positive that time. But previous to the study, we have ruled out everything. That time it was negative. But maybe
prostates are well known not to grow.
But in most of the patient, it was showing improvement, and it was very unlikely that to face this situation. But we take a lot of meticulous. We do at least two times semen culture and urine culture in 1 month apart to know that the patient has a clear. And these are the patients who are on long-term follow-up and have been seeking some form of alternative treatment. They have been exposed to multiple antibiotics already. They have tried the modalities already, and still they want something to be done extra. So I think.
So you have a new kid on the block.
Sir?
You have a new kid on the block to treat CPPS.
Yeah, that's the only point of.
Thank you very much for introducing this methodology. Those who wanted, I have reached some dead end to treat CPPS patients have another way of treating them now.
Yes, sir.
Thank you very much.
Thank you, sir.
Thank the association, Karnataka Association, and the organizers to having given the opportunity to chair this session.
Thank you, sir. I request chairpersons to stay back on the dais. I request our speakers, Dr. Rohit Joshi, sir is not here, Dr. Mahesh Desai, sir, Dr. T. Manohar and Dr. Prashant Ganesh. I request our past president of KUA, sir, Kumar Prabhu, sir, to kindly facilitate the speakers and chairpersons.
This morning, baby, with you on my mind. I woke up this morning, baby, laying on the line. baby, with you on my mind.
Thank you, Kumar Prabhu sir. With this, we conclude second session. Lunch is ready. We'll take a quick lunch break. Though it's a half an hour lunch break, we will try to keep it as crisp and short as possible. And we will be resuming back with the next session in another 20 minutes. Kindly have a quick lunch and join us back. Next session will be a symposium on post-prostatectomy incontinence. We have plenty of interesting presentations. Kindly join us back. Thank you. so that we can resume with our session 3. Session 3 will be a symposium on post-prostatectomy incontinence. I would humbly request our chairpersons, Dr. Nagaraj Rao, Dr. Shivlingaya, Dr. Prakash HS, and Dr. Madhusudan to kindly take the dais.
Good afternoon, everybody. Dr. Raghunath is here. Yeah, we had a wonderful day with academic excellence. Hope it will continue in the afternoon. We have got 3 further papers to present in this afternoon. For the first session, I'll call Dr. S.K. Raghunath to present post-prostatectomy incontinence, an overview of prevention and management. Dr. Raghunath.
This one? Or I can change here. Very good afternoon. At the outset, I would like to thank my dear friend Dr. Manohar. We did urology together, and it's my absolute pleasure to be here in front of you, and most importantly in front of my boss and mentor, Professor Mahesh Desai sir. I thought I was a misfit because it's a benign disease conference excellently organized by Dr. Manohar. What role I had to play? So I'm going to play something related to prostate only. This is post-prostatectomy incontinence preservation or prevention. So title of the topic is slightly different. Post-prostatectomy incontinence prevention and management. As the time given for this is only 10 minutes, I'm going to give you overview of this. It's very difficult to cover this vast topic. Management itself takes 2-3 sessions. So I'm just going to highlight the important salient points and how in clinical practice we can prevent incontinence. What are the ways? So we talk about all these parameters, trifecta, pentafecta, but nobody talks about perfecta. Perfecta means there should not be incontinence. If we achieve perfecta, there is no role for us to talk about incontinence. So we have not yet achieved perfecta, hence we are discussing about trifecta, and very important parameter in this trifecta or pentafecta is continence. And it is going to affect quality of life, so we have to pay a lot of attention to this. I am going to talk only the basics, how to prevent incontinence. These are the important salient or points. Facial planes around the prostate, we need to understand the neurovascular anatomy and continence mechanism. Broadly under these 3 headings, we will be addressing my talk is revolving around this. For continence, we need to have intact muscles, intact supporting systems around the sphincter. The bladder should be stable. There should not be any unstable bladder. Of course, this does not contribute directly to stress urinary incontinence, but they can have incontinence. And coordination between the nerves and the sphincteric mechanism. And urethral angle, which is not stressed in the literature, which is also very important. So a brief video is there. I would like to play this video. It is not playing. Yeah. So this is very important for us because 70% of my practice is prostate cancer, and in that more than 50% of the times we will be treating localized and locally advanced prostate cancer. These are the facial planes. If we understand these things, probably we can give better continence. This is self-explanatory. Neurovascular bundle is there, levator fascia, parietal and visceral layers are there, prostatic fascia is there, and lot of muscles which are surrounding the sphincter. that is external sphincter and internal sphincter, which are very important. So if we understand all these things, probably we can give better continence to our patients. So what are the determinants for continence? There are non-surgical and surgical causes open surgery, because the vision with robotic surgery and dexterity of the robotic instruments are very fine. That itself will translate to better outcomes. You can preserve the best nerve preservation with robotic surgery compared to laparoscopic versus open surgery, and surgeons' experience and expertise. Dr. Vipul Patel has done more than 16,000 radical prostatectomy. He does 7 to 8 in a day. Despite of that, he couldn't achieve 100%. So we are still understanding it year by year. He has changed some of his techniques of hitching the sphincter complex to the pubic arch. He stopped that after 12,000 cases. So earlier it was a gospel truth that everybody used to do that. Why we are doing? Just because Vipul Patel was doing that, we also started doing that. He stopped after performing 12,000 radical prostatectomies. So probably that is not contributing to the continence mechanisms. So apart from all these things, important thing is which approach and surgeon's experience, that matters a lot. The principles of continence preservation is do not damage. A person comes to you with a prostate disease, he is totally continent. If you don't do anything, he will remain continent. But when you do some damage by doing radical prostatectomy, by altering the anatomy, he can develop this one. So theoretically, it is not possible to give 100% continence preoperatively, but most of the patients, by understanding all these things, we can give them continence. Decrease the damage. What are the ways of decreasing the damage? There is intrafacial hood technique and nerve sparing Regius technique. These are the two standard techniques people are doing globally to preserve the continence. And in case if already damage has happened, because that is very important, most of the cases in India are locally advanced cases. So you can't do hood technique or you can't do Regius sparing technique. Otherwise, they will end up with positive surgical margins and recurrence will be there. So you have to select the cases properly to give a best continence, not at the cost of surgical margins or outcomes, trifecta or pentafecta, whatever. If it is not possible to do hood technique, if you are widely excising that, in that case, you may have to repair the anatomical structures which contribute to continence. So preservation of Regius space, bladder neck preservation, nerve bundle preservation, periprostatic ligaments. There are so many ligaments are there. You have to preserve those things. Dorsal vein complex, maximum functional length of the urethra. Again, we don't know anatomical length, we know the functional length, we don't know. Ideally, every patient should undergo UPP to understand what is the tone of the muscles. So we don't do that in practice. And detrusor apron, preservation of the detrusor apron. In case of already damage has happened, you have to reconstruct by anterior suspension of the bladder neck, posterior urethral reconstruction, Rocco stitch. Though Rocco stitch helps in anastomosis, but it does not contribute directly to continence. And many people, and where you need to give him good continence, at the same time you are preserving, and where you need to give him good continence, at the same time you are preserving nerves. They should be obviously younger individuals. Only those cases we will be doing this. So all the nerves will be intact, all the periprostatic and around the sphincter mechanism, all the structures will be preserved. Intact angulation between the urethra and the bladder neck, and full functional length of the urethra can be preserved with this technique. These are various mechanisms of reconstruction. I would not go into the details of this. The double layer anastomosis, we did a prospective trial, so that enhances the outcomes in terms of continence, and 360-degree repair around the urethra by doing this and basically restoring all the anatomical structures around the prostate and the sphincter will give the best continence. So preservation of neural hammock, even if you do nerve sparing radical prostatectomy, we should not use thermal injury or even traction injury should be avoided to give the best results in terms of nerve preservation. And risk stratified preservation of the neurovascular bundle depends on the anatomy and depends on the disease. So these are the extrafacial, interfacial and intrafacial. I am going to show you hood technique intrafacial dissection, where you will, at the end of my talk, you will assume, oh, he has done just enucleation of the prostate. It looks exactly the same. This is the, we are dividing the bladder neck, that is the posterior bladder neck. You divide that, this is running at 2x, that is the seminal vesicle. So we have not cut the endopelvic fascia. If you cut the endopelvic fascia, more scarring will happen. To avoid that one, we preserve that. This is the hood technique. The perfect hood will be seen on both the sides. We are going very close to the prostate. Risk of surgical margin positivity is high. Again, in such cases, we always go for NeuroSafe. Remove the prostate and send it for histopathology. Pathologists will tell within 15 minutes whether margins are positive or not. So depending on that one, we preserve the nerves. So it is almost like in an early case, we do this. We don't use any thermal energy or very minimal thermal energy. We go very close to the prostate. And these cases can be done not immediately after biopsy or even 2 to 3 weeks after biopsy. Generally, we better to wait for at least 1 to 2 months after the biopsy to get a proper plane. So we are basically, technically speaking, repairing the dorsal venous complex, that is the urethra. Maximum functional length and anatomical length of the urethra is preserved. Even the denominal fascia is completely intact. Both the sides neurovascular bundle is completely intact, and all the structures around the sphincter is completely intact. You can make out there is no neurovascular structures around the prostate. You see just the prostate capsule, and even rectal fat you cannot see because complete denominal fascia is preserved, and both the sides hood is completely preserved. And what we do if we preserve these nerves, to prevent scarring of the nerves, we keep amniotic membrane. That is the amniotic membrane. By keeping that one, it produces a lot of growth factors which prevent scarring and enhances recovery of the neurovascular bundle. So when it comes to management, just for completion's sake, I have just put this slide because of paucity of time. The Kegel's exercise, both prehabilitation and prehabilitation, that is Kegel's exercise, and post-surgery, they continue that. If they are incontinent, duloxetine is a good tablet, but unfortunately not many people would tolerate this. We start with just 20 milligram 2 to 3 times a day, and TENS, that is nerve stimulation devices are there which are not very expensive. Maybe it's available on Amazon for 4,000 - 5,000.
Prostatectomy in your early experience and now, and how many patients needed surgical management of the
in my early experience, a lot of patients were incontinent. Now we have done more than 600 to 700 radical prostatectomies robotically, and more than 500 open radical prostatectomies we have done. With our present data, we recently analyzed our last 2 years data. Around 35 to 40% of them are not continent from day 0, which is very good, which is according to global data. Again, around 1/3 of patients will have incontinence for 2 to 3 months. Another 1/3 will have incontinence for 5 to 6 months. 2% will have even after 6 months. Beyond 1 year, maybe 0.5% will have. I am not talking in terms of 0 pad, off pad, all those things. They are incontinent. Incontinence means they leak. Whether they are using pads or not, that is a different issue. Whenever they cough, when leakage is there, that is incontinence. So with that definition, these are our results.
Sir.
Raghu, basically prostate size in our Indian population is small, and whenever we have done a radical prostatectomy for say a low grade, means less than 7 PSA and 3+3, we have preserved the nerve. But very often you get capsular.
Exactly, sir.
And then we actually we have seen 82% we have considered as an organ confined, and only 48 turned out to be organ confined. Remaining had some little capsular infiltration or seminal vesical infiltration. So we have to maybe decide between early or salvage radiotherapy. So in your experience, does the size matter when you do
it matters,
how do you select cases for now preservation in 3+3 or early or low grade prostate cancer?
So it should be low risk prostate cancer. Even if it is high risk prostate cancer, the disease should not be in touch with the capsule of the prostate to preserve the neurovascular bundle. If disease is coming in contact with the capsule of the prostate, it is risky to preserve neurovascular bundle on that particular site. In case if the patient is very young and if he wants to preserve, we go for neurosafe, where we preserve the nerves, but send it for frozen section. If frozen is negative, then only we keep that. Otherwise, we don't keep that.
So in your experience, whatever prostatectomy you do, how many percentage will do a now preservation?
Maybe I would say 5 to 7%, less than that, because we don't get that kind of a patient. Most of them are locally advanced prostate cancers. They don't fit into this. And elderly patients, they come with early disease, but they don't require that.
Thanks very much, Raghu. We'll move on to the next presentation.
Thank you.
I call upon the next speaker. Semi-live demonstration of electromagnetic therapy for the treatment of incontinence by Dr. Anand Kumar from Chennai.
Good afternoon, everybody, and thanks for this wonderful opportunity for us to be here. So the topic what I'm going to talk about is the role of deep electromagnetic stimulation energy in particularly incontinence, basically women's health. We also call it as RPMS. What does it mean is repetitive peripheral magnetic stimulation. So basically we'll be making use of deep electromagnetic stimulation to stimulate the pelvic floor muscles. So women, they come across a lot of problems, particularly middle-aged women like menopause, cervix and breast cancer. They have postpartum complications. They have obesity is a problem. Among all these PFD, the pelvic floor dysfunction is one of the main significant and essential issue which they are finding very difficult to address because many of them still they are not aware of it, how they can manage it, still they are trying to suppress it and live with it. So we all know it's just a supportive sling, the pelvic floor muscles, which provides optimal support to the bladder, uterus and the vagina. So as we grow old due to overage, due to some repetitive pelvic surgeries or due to childbirth without improper postpartum rehabilitation, all that could lead to the pelvic floor losing its optimacy and it becomes weak and it pushes the patient to an embarrassing leak which makes really cumbersome and the quality of life becomes a very big question. So we are trying to find out therapeutic treatment methods like very highly innovative simple methods which can really impact these pelvic floor muscles because pelvic floor dysfunction is one of the main chronic problems which leads into isolation and things like that. Because even they are not able to disclose it with their spouse, with their children, with their family, even with their close friends as well. And because of the fear of isolation and discrimination, so they don't speak out and they get into a lot of stress, and the quality of life becomes a very big question. So what we can do, the conventional methods used are like lifestyle modifications, physical therapy exercises, where we treat them to do a lot of pelvic floor exercises, Kegels exercises, medication, biofeedback devices, which definitely help to re-educate and build up the endurance and stamina in the pelvic floor muscles, and definitely surgery also. But the success rate is definitely varied from patient to patient based on the severity also. So, but what we can do here with the state-of-the-art deep electromagnetic stimulation device is that it comes with a UI chair, urinary incontinence chair. All that the patient has to do is they just come and sit on this chair. They do not expose their private parts, and they just come and sit on the chair fully dressed, and a deep electromagnetic stimulation happens, which will stimulate the pelvic floor muscles for the next 20 to 30 minutes based on the protocol we select. And then the 30 minutes protocol, approximately it induces around 12,000 Kegels contractions, which ensures the strength and optimum power of the pelvic floor muscles, thereby preventing incontinence to a greater extent. So it is nothing but we will be inducing a high power supply, which will stimulate the coil which is placed at the base of the chair, and it gets converted into alternating high power electromagnetic field, and it is strong enough because the power is 3 Tesla. The energy what we use in MRIs for diagnostic and imaging purposes, that same energy we are using here for therapeutic and rehabilitation purpose. So it gets converted into high frequency or high power deep electromagnetic field, and the power is so much that it is able to penetrate the skin, bone, and even penetrate deep up to 10 centimeters also, and targetedly it will reach the areas which are exposed with the applicator, and it will induce strong contraction and relaxation in the muscles. So this is how it basically works. The device name is called Salus Talent Pro from a brand called Remed, which is a South Korean based company. It induces deep penetrating electromagnetic stimulation, and it is quite strong. It is somewhere around multiple number of bar magnets put together, that much amount of energy it creates. And the advantage is the patient is fully dressed, and the procedure for such a sensory or a sensual issue is very, very simple, where we can definitely create impulses to the efferent nerve fibers and induce contractions in the muscle structures around the pelvic floor, and with activation of the afferent fibers we can improve the sensitivity of the pelvic floor as well. So we try to cater to both the afferent and efferent counterparts in a more efficient manner when we are trying to treat patients with incontinence. So what are the crucial factors here when we are playing with different types of incontinence or chronic pelvic pain syndrome or post-prostatectomy patients for rehabilitation or postpartum rehab? For all that, it is few parameters like the frequency, the intensity, the duration. Duration means the on time, off time, and what is the interpulse or intertrain interval. So these are the crucial parameters on which we will be targeting different nerve fibers, different muscles in the body, either alpha, beta, C, delta, sensory, motor. All those counterparts can be stimulated by playing with these parameters, and we can induce rehabilitation in incontinence patients. So what we do, this is when the patient is having urge incontinence, let us think. So if it is urge incontinence, it's more to do with the sensory counterpart. So we make use of the low frequencies, that is around 5 to 10 hertz, which results in the excitation of the afferent nerve fibers, and it transmits the impulses to the spinal cord, and it will decrease the tone of the centers of urination, and it will induce indirect inhibition of the parasympathetic efferent pathway activity also, and also the detrusor contraction. When it is with stress incontinence, where coughing, laughing, if they are lifting any weights, if they are into any physical activity, if they are getting into incontinence, then we need to target them with a different set of frequency, which is around 50 to 100 hertz. And it results in the excitation of the sympathetic efferent fibers, and that leads to increasing the tone and the contraction of the pelvic floor muscles, including the external urethral sphincter responsible for urinary retention. So, based on what type of incontinence our patient is presenting in front of us, we need to really play with a few parameters. Significantly, we need to play with the frequency range, what we are going to set when we are planning the rehabilitation for a particular patient. So, the device comes with a dual applicator, and the best part of this device is, particularly if it is a specific uro rehab hospital, then it is fine. Otherwise, if it is a multi-speciality or multidisciplinary hospital, definitely they will look about return of investment and utility of the device as well. And the best part of this device is it comes with a dual applicator. So what I understood as a physical therapist and as a rehabilitation specialist, when we are treating with patients with incontinence, maintaining the abdominal pressure also plays a very, very crucial role. So what it does, when the abdominal cavity, when it is properly maintaining the abdominal pressure, it protects anything inside there by like for example the uterus, bladder and the rectum. If for some reasons there is some disturbances in maintaining the abdominal pressure, definitely the internal organs like the uterus, bladder and rectum, they are in a way impacted by this. So that could lead to less stability, and it could increase the risk of incontinence also. So to overcome that, what we can do, we can definitely improve the intra-abdominal pressure by strengthening the respiratory muscles as well, particularly the diaphragm. So for that, what we can do, we have one more applicator, which is a smaller one, and which can be used dynamically and also fixed to a stand as well. So we will make the patient to lie down in the side-lying position, in a crooked position, and we will approach from the posterolateral aspect of the apex of the rib cage. And then we will try to reach to the diaphragmatic muscles, and we will induce deep contraction in the diaphragmatic muscles, which will help us to ensure pelvic core stability, and the abdominal pressure generated or regularized. It will help us to strengthen or reinforce the position of the pelvic floor muscles as well. And what we can do, so like this, we approach the patient from the posterolateral approach, and we will be targeting the muscles which are responsible for respiration, particularly the diaphragm. It will improve the muscle activation and coordination, and thereby we are able to stimulate the breathing muscles, which improve the strength and guides the patient to breathe normally. Thereby it will help us to maintain the intra-abdominal pressure as well. So when it is come to urogynecology, not only urinary incontinence, we can use this device, this wonderful device which is based on deep electromagnetic stimulation for treating acute and chronic urogynecological pain, sexual dysfunctions. Another benefit of these patients getting exposed to this device is, in women it helps in vaginal lubrication and tightening as well, and in men it helps in erectile dysfunction also, and they are able to achieve better and more efficient erection with after getting exposed to the treatment. And patients with chronic prostatitis, postpartum regeneration and general strengthening of the pelvic floor muscles, and even after rehabilitation after prostatectomy can also be done with this wonderful device. And these are the various protocols on which it has been designed. Like if it is stress incontinence, it should be a frequency of 50 hertz. If it is urge, it should be 10 hertz frequency. If it is incontinence due to radical prostatectomy, the frequency range runs between 10 to 50 hertz. with different on and off durations and with the total time period. Same way with erectile dysfunction, it's around 25 to 50 hertz, and if it is with orgasm problems, it's again 25 to 50 hertz. If it is pelvic pain syndrome, it is around 20 hertz frequency. So all that is necessary is we need to play with a few parameters like the frequency, intensity, the on and off time, and the interpulse interval. We can treat many of the problems with the help of this incontinence chair. And the key benefits from this is it is non-invasive, as we all know. And the second thing is the patient doesn't get embarrassed because of getting treated on this at any stage, because they are fully clothed. They need not expose their private parts, and it's operator free. So all that we need to do is make the patient to sit appropriately on the chair, take a proper position so that the stimulation definitely targets the pelvic floor, and then we set the intensity and leave it for the next 20 to 30 minutes based on the type of incontinence we are going to treat. And the best part is when it comes to the commercial aspect, there are no consumables in this. So there is no refilling, or we are not going to spend again maybe after a few years or a few months based on the utility on some consumables. It is totally consumable free. And the best part is, as I was mentioning, if it is a multidisciplinary hospital, so this device can be used for pain management. It can be used in rehabilitation. It can be used in sports injuries. It can be used in neurological conditions. It can be used for gynecological and urogynecological indications where we feel some other innovative methods, if at all available, we can go for it. So this is a versatile device with a couple of applicators which can cater to different departments when it is a multidisciplinary hospital. And the best part is it's non-invasive. Second thing is patient is totally confident, because at any point of time we ensure that their self-esteem is not getting compromised at all, and it is operator free and consumable free, and with this we can achieve high success rates. So there is significant improvement in the quality of life in around 95% of patients, and significant 75% of the patients, at least from the first session, the number of pads they use to safeguard themselves, it has come down drastically, and many have totally come out of any type of adjustments what they have to do to overcome incontinence. So that is the success rate of this innovative technology called the peripheral magnetic stimulation, repetitive peripheral magnetic stimulation. Thank you.
Dr. Anand,
yes,
treatment appears very attractive. What is your experience, whether you applied this treatment in men with the post-prostatectomy incontinence, and what is your result?
So they have devices and they are using it for incontinence, particularly like post-prostatectomy induced incontinence also. Yes, it definitely works. Mostly I think it is the detrusor muscle inactivity which basically predisposes them to incontinence. So what we can do is we need to really think about what we want to do. If I want to prevent, it's like musculoskeletal indications only. If I'm concentrating on building up the endurance or stamina of the detrusor muscle, I need to set a particular frequency and a different on-off time and interpulse interval on the device. Once you do that, and we position the applicator and we target it. If it is the strength or explosive strength what I am concentrating, it's a different set of frequency, on-off time and the interpulse interval. And the intensity, of course, it's purely subjective, based on patient to patient it will vary. And the success of giving the appropriate intensity, it lies on playing with the frequency on-off time. So like that we need to understand and take a clear history of the patient, what is the origin, and definitely when people like you, when you give inputs to rehabilitation therapists like us, like this is the patient, this is the indication, and this is what we want to overcome, then we can really understand and evaluate and play with the parameters accordingly. And the success rate is good, sir. I won't say 100% we are successful. At least we are marching towards more and more success when it comes to patients with post-prostatectomy. Definitely their quality of life and their self-esteem is improving, and definitely it is giving very good results.
Dr. Anand, how many applications? Yes,
yes.
How many application needs for the post-prostatectomy incontinence?
Sir, we need
Roughly?
we need to do twice a week.
How long?
It should be around 20 to 30 minute session it will be. Twice a week we do. So like that, some 10 to 12 sessions we need to do. So by that, maybe 1.5 month minimum it will take. So from the first session itself, the patient will feel the symptoms are coming down and they are recovering much better, and the quality also improves.
Any side effects?
Side effects, like for example, what these will do, since the muscles have not been put into that much amount of workload, voluntarily or involuntarily, there might be some soreness. Maybe out of 10 patients, 1 or 2, they might feel little sore or mild cramps. So to overcome that, what we tell the patients is take a lot of fluids when you are getting the treatment. Drink a lot of fluids. So in these patients, after taking fluids also, the incontinence will be much under control after they have got treated. Otherwise, no side effects.
FDA, this therapy got approved?
It is approved, sir.
Thank you, Dr. Anand.
Yes.
That's a very wonderful presentation.
Yeah, Dr. Chaub, one more question.
One more.
Still there's time.
Yeah.
Pass on the mic, please. It's on, Chaub.
You have shown the statistics of 95% improvement and 75% reduction in the pads. In what perspectives? Like in overall, or is it true for the post-prostatectomy incontinence?
No, it is for overall, all conditions which predispose to urinary incontinence.
Have you studied regarding in terms of our post-prostatectomy incontinence, that pad, reduction of pad and...
yeah, we do have studies, sir. Maybe we have a stall also outside. So maybe any time before you leave, if you want, you can just come there and experience it personally also. And if you could share me your mail IDs, whoever have any queries, I'll be very much happy to share whatever information you want.
Any more questions? Thank you, Anand, for your refreshing overview of urology. Thank you.
Thank you, sir.
With that, we'll move on to the next speaker. We'll call upon Dr. T. Manor. It's on semi-live on atoms, procedure details. Over to Manor, sir.
Respected chairpersons, as part of the incontinence workshop, I'm going to cover up the procedural part. There are various next speaker. The next speaker from our president is also very interesting. So I'll start with the atoms. I had some brief experience with this. There are various types of suburethral slings. I think you know that transapparatus sling, that is called as advance, and bone anchor sling, which it can be stick to the bone, and quadratic sling, they are also present, and the available adjustable sling, that the corner is the quadratic sling where the 4 goes, but I don't have much experience, but these are all in the literature just about a pad free rate of about 35 to 40%, and in the latest version of adjustable sling, that is the atoms, of course, it has gone into a lot of variations over a period of time. It's first developed in 1970. It's not a very new kit. It basically external compression of the bulbar urethra from the ventral aspect. It has got organic compounds utilized initially, but I think it has produced a lot of corrosion and degradation over time. So now they use a synthetic mesh. At least the organic has been replaced. This portion of the part which I'm showing here, it has been replaced by the synthetic mesh now. So mechanism of action is ventral compression of the bulbar urethra to increase the outlet pressure, reduce the mobility of the urethra, because other slings, they produce some of the mobility. It stabilizes the urethra, that is important, and keep the continence components within the pelvic floor musculature. How does it happen? Because it is an adjustable male obturator atoms, it has got a hydraulic system with no mechanical parts. Anatomical 4-point fixation via TOT arms, suburethral substitute sphincter cushion, there is a cushion here, and it has gently evenly distributed pressure on the bulbospongiosus muscle, that is very important because its distribution is equal because of its length, which I'm going to tell that. And patient-specific adjustment in outpatient post-operatively can be done. Outpatient, if it comes, we can adjust it depending upon the continence. Also allow compression of long-term urethral atrophy, atrophy of the prevention. So I just, because short of time, I am skip off all the literature, but if you look at the key meta-analysis in 2019, is a full data of 1,400 patients from 20 studies, 13 retrospective and 7 prospective. Standard mean follow-up was about 20 months, about around 2 years. Overall drainage was 67%, 90% improvement after adjustment, after you fill it up, complication rate of 16.4%, explantation of 5.75%. But of course, if you look at the heterogeneous data, because this analysis was done from 1980 onwards, there are 4 generations have come. Now the latest generation is 2014. Despite all this heterogeneity, overall data show that objective effectiveness of low rate of complication in the short and medium term, and has got a better best results. In overall, it's a less than 6 pads per day before implantation, which becomes less than after the procedure, and basically useful in non-irradiated patients. Use of 3rd generation device with silicone covered pre-attached portal sport is the main advantage in these cases. These are the parts. You can see that this is the whole total parts. That is the cushion part, suburethral substitute sphincter, and this is the catheter, and this is the scrotal part, and this is the mesh arm, and these are the fixation sutures, and this is the tunneler. This is the tunneler. So this hydraulic system, you can see that in an individual long-term adjustment can be done over a period of time. It is made of entirely components that functionally, hydraulically it functions, and patients therefore spared the difficulties caused by the defects which may occur in the mechanical components months or year later after the procedure. This is how actually the size, the 4 centimeters, and equally distributed. It's shaped like some kind of horseshoe so that it will adjust into the pelvic area, and the maximum cushion onto the bulbospongiosus muscle. And this mesh around the bone has a holding structure, and the macroporous, it's not a microporous, it's a macroporous mesh. It integrates well into the tissues, that's why it is macroporous, and engraftment leads to extra form. It causes extra form, so mobility will be less, and it produces less foreign body reaction, and it also allows the tissue ingrowth and revascularization of the surrounding tissue, hence there is a reduced infection. And the scrotal part, it's very easy, it comes on the left side, it's straight, it is placed exactly on the left side, because after a lot of innovation they put it onto the left side, so that because it can easily go on to the left side of the scrotum. So easy direction, stiff, there's no kinks in that. It can be adjustable via small percutaneous puncture, which is at the tip, and it is permanent. So coming to the overall procedure, I'll just show you the animation and then do the proper procedure. There's a midline incision at the level, not a very deep incision to expose everything. And this is how the urethral sling goes inside out of the inferior pubic rami. And they have to come through that on either side of the bulbospongiosus muscles just above the rectum. And this is how, it's actually a very simple and straightforward procedure. It just fixes there, and then this can be that there is a portal, scrotal port. It just goes straight away there once you fix it, and you make a finger tunnel into the scrotum. And this is showing that it's got a sphincter effect when you started filling the scrotal port. So keep on filling the port where you can have the sphincteric effect.
This is the scrotal port, how the injections can be done. You take out the air and fill it up. You can use a normal distilled water. It can be done in the outpatient procedure. As opposed to when patient comes, you can just, you need not even to put a local, it's just a one injection. So as a procedure starts, we catheterize the patient, and then it's a self-explanatory that, just the incision, little longer incision. I would rather say that it's because we put a small incision, we used to struggle, that's the inferior pubic rami, so I'm showing that. And make quite a lengthy incision, starting from the root, all the way up to just above the anal word there. Just in case, if you want to palpate, because when the sling goes out, you need to have that slate where you can prevent the rectal injury. That's the reason it's a little longer incision. And then as usual, the exposure of the urethral complex and the subcutaneous, and then once you do that, keep on exposing that. And I think that's the one portion of the, we're able to visualize the posterior scrotal nerves. We're just taking it, separating it out. That's the posterior scrotal nerve. So we have a neurovascular bundle. Just go, once you do in the midline, just go little laterally so that small can be buzzed. Then you just have to put your finger and make a arch into the area, cleavage area, where you can feel the superior portion of the inferior pubic ramus. That feel should be there. You should be able to feel that. And that's the area where bulbous spongious muscles can be prevented if you separate it out. We don't want to injure the bulbous spongious muscle, where actually the hydraulic fits into that area. And this is the, actually it comes in a pre-packed sterile one, so you don't need to do anything. And this is the suture part of it, where they sling and go. They advocate to do it from front to back. You can do that, but I usually use a thread to pull it back. It's a reverse direction. This is the how the just after exposure. Just have to place that. It's about 4 centimeters in length. Some of the obese patients, we had some difficulty. So high BMI patients. So that is the feel of the inferior rami, and then you just have to see that you get a puncture that sheath, and then that has to be rotated. It has to be rotated with the patient horizontally. That you have to see the needle should be horizontal. Earlier we used to do like that, and we used to enter almost towards the hitting the rectum. To prevent the rectal injury, it has to go. It has to be, needle should be completely horizontal while rotating, and then lift it up so that my left finger has gone in to prevent injury to the rectum in case if anything. Otherwise, it usually comes out. So this is usually fairly simple, but I think little precaution has to be taken. And then thread first put the needle, or you can actually, when you're doing this, you can hold the thread and put it in thread, and the procedure is done within a few minutes. So here in this case, we are threading the thread and take it back, and then railroad it. It can be done this way also, or you can just straight away hold that thread, which is the atoms, and then you can come once. It will be done over. Probably experienced more than I think probably we can do that. Since we have to do little manipulation. In this case, actually, it is one of the good videos where I was able to take it in one shot. So here, thread it and pull that so that the mesh goes, the porous portion goes behind that, anchoring the pubic rami. So same thing, just palpate that inferior pubic rami. That is to prevent that. Now there, sometimes it get entrapped and cause a lot of pain there. Just put that, puncture that. That how to get that feel. That feel is very important. And then keep on pressing, keeping that horizontally towards that. And once it reaches, once you feel that, when you go inside, you can feel that, and then with the finger in place, then you can slowly rotate it. And this procedure, I think this is the main caveat in this procedure, which makes the rest of the procedure is actually simple, and then you have to fix it back. That's it. So this is how it is been done, and that's the scrotal part. Then we do the 4-point suture, just cut out that, and then you can pass through the mesh, whatever the thread has been given, pass through the mesh, and then you can do a 4-point stitch to stabilize into the hydraulic system with the porous mesh. So just take it out. And just pass through that, just pull it as far as possible, as much as it comes, because the pressure does not mean anything here. Have to tightly stitch, because the main system is hydraulic. When you put fluid only, then it gets compresses. This is actually straight. It is not going to compress. It has to be stretched completely, and then this through the thread has been passed through the mesh, and this is the anchor 4-point fixation to the hydraulic system. One point is fixed, and another point onto the opposite side. One above the other, just to make sure that it won't get slip out, because this 4-point fixation is to make it stabilize, so that initial part of it, when your patient is moving, initially there will be some kind of mobility will be there till the revascularization and ingrowth of the tissue occurs. So this is basically done for that reason, to prevent the movement of the. So on the opposite side, the same thing has been done, the 4-point fixation to the opposite side also. And after doing that, you can mesh has been cut. Then I think, of course, any peritoneal procedure, we have to give a good antiseptic. And this is a scrotal port where we have to inject the fluid, so that like a syringe and take a 10 cc at a point, and no air should go in. That we have to repeatedly do that and inject it, and see that the port has been injected. Before closure, you can just try that and leave it. What is the pressure? So once you leave it, the pressure comes back on its own. Take out the air, whatever the air is there inside first. Air should not be there, because the uniform pressure may not be 100% guaranteed. And also doing ultrasound when doing after the procedure, if the air is there, it will interfere. So make sure that there is no air. Then inject it. You have to release the piston. So it will give you the adequate pressure, how much it comes back, how much you can fill it up. Once 20 cc, it will go. If you release the piston, it has to come back. So to come level, it comes and stops at that level. Probably after that, you can put 1 or 2 cc and then keep quiet. But this can be adjusted. That's the reason. So air has to be taken out, and then finally a little amount of fluid can be put, and just take it out, because the piston has to be released, so that the traction onto the area and the compression onto the urethra will be efficient. Even if it is less, if you injected that, you can do it post-operatively. After that, once we do this is a scrotal port which you are placing. So just we have to go above that port, where this incision also will give you a little bit more, and then go inside, and it has to just one finger, just finger swipe, you can get into the subcutaneous area. And this is a titanium kind of thing, so it easily goes there. And usually, I mean, you can feel that. You should see that post-operatively, one should feel that, because there is the area where we're going to inject. So one should make sure that you have done the proper site at this level. So this is very important, that. and does not go into any of the lateral portion of it, or any hematoma just has to be checked. And then after that, the wound is closed. This is that wound is closed there, and then avoid the nerves which I'm showing that, prevent that, take a stitch and close it off. So this is the overall procedure, that's the main portion of it. There are various publications, and because short of the time, I'm not going to the details of that. And we have a overall report shows that there is a 63% dry, considering the fact that 60 to 65% patient pad-free rate is there. And then recently, I think Foley et al. They did a 7 years experience. They found that they improved the dryness is 76% after the top-up. And they also found that it is more very helpful in case of patients who has insertion for the top-up. This is what the first top-up. After incision, you can see that, and first top-up, second top-up. In fact, I have one patient who had done it up to 12 months top-up. So till you get that, till the patient's condition does not worsen, doesn't cause us pain, you can go on doing that. And radiotherapy, as I mentioned, that no radiotherapy, the continence rate is good. So they have little concern about the post-radiation effects. And then it's usually useful for mild to moderate. I mean, that's what the results said. And then severe, I don't think it is useful practically, but they have good results with severe 5+ plates also. They have got a useful, about 30 to 40% pad-free. So minimal post-operative pain, which decreases over the period of time. And I think by 6 weeks, I think all the pain will go away. And they have found that urinary retention had 2 patients and scrotal pain in another 2 patients. There is an erosion of the inflator mechanism, movement of the balloon mechanism requiring readjustment in 1 patient. And 1 patient had infection, and 1 patient requiring removal because of the malplacement and pain. So of course, 10 years experience shows that erosion rate is about only 0.2% in all these reports. And this is one important study I found that sexuality and erectile function after implantation. So I just thought that I'll mention these items for urinary stress incontinence, a multi-institutional prospective study. They found that this improvement of the IAEF score of 6 months after Artem's implantation with a mean difference of 2.18, confidence interval of 1.2 to 3.14, and statistically significant. So non-sexually active men patients had the greatest benefit. So sexuality and erectile function improves significantly 6 months after Artem's implantation, and they postulated that reduced SUI probably during sexual activity and absence of chronic pain are improving factors. This seems to be a little interesting after this. And we had experience of about 8 patients. We indication only stress incontinence. We very carefully we chosen this. Only nighttime continence. And if a patient has good nighttime continence and only stress daytime continence, we have chosen this patient. Failed trial of medications and Kegel's exercise and persistence of incontinence for more than 1 year, then only we have tried this, most of them. You can see that on that side, we can actually do the ultrasound and measure the balloon part of it when we have increased it, and this patient had completely dry. One patient had a single pad and occasional leak during multiple fills. This patient had post-HOLEP and post-anti-resection of the cea rectum. There was no base there, so we have to go on filling. In fact, I filled it up to 25 cc, so maximum. So that's the photograph which I said that, and he is happy. Somehow I don't know this patient. Usually the fluid used to get reduced, and every year, every 6 months, I'm placing 1 ml, and he is happy. But it's an anecdotal report, so I don't find that in the study. Thank you.
Dr. Manor, good presentation.
Thank you, sir.
Whether you do preoperative urodynamics and cystoscopy before doing this one procedure?
Yeah, one patient had a stricture. In fact, it's a passable stricture, but I think uroflowmetry will give us it's a stress incontinence. It's easy to analyze. If it's a complete incontinence, I think we need to do it. Stress incontinence, usually they would have done a uroflowmetry, would have got that. He just passes it good, but stress is the one bothering. That is the only patient we have chosen. So basically, uroflowmetry and bladder is emptying. Uroflowmetry is the kind of patients. It's a clear-cut, straightforward case of stress incontinence only. Because they have done up to level 3, all those things. I mean, continuous incontinence, they have done it. But the dry rate is around 36%.
So it is mainly used for mild and moderate.
Mild and moderate, and they are not responding. And if it is bothersome, if it is 2-3 drops, some patients, they go for the work, if it's bothersome, so then I think that's kind of patient.
Whether its efficacy comes down over a period of time?
No, I have one patient for 4 years follow-up, it's good. It's a permanent, and it's, once it is within 3 months, we'll come to know it is working or not. And fill-up is required. That's what, 3 months, 6 months. Initially, just I don't know what happens to probably the pressure built up and the sphincter mechanism goes back, or compression of the muscle, but top-up is required. Or the fluid comes out, we are not very sure about it.
Okay, thank you.
Any more questions? Comments and steps on the procedure. Over to Sanjay Kulkarni, sir.
Should speak into this, or here? Huh? Yeah. No, I'll do it here. Presentation first. Good afternoon. I thank the Karnataka Urology Association, Dr. Chandrasekhar Rao, President of KUA, Dr. T. Manohar for organizing today's program. So my father came from Bijapur, and I can just say Kannada Salpa Bartada. If he would not have moved to Pune, I would be practicing in Bangalore. Who knows? So today, in front of my guru, Dr. Mahesh Desai, I'm going to speak about artificial sphincter. I'll tell you a story. I came from England in 1987, and in 1990, there was this super rich industrialist in Pune, had a TURP in Mumbai, and then he was driving a Mercedes car and wearing nappies at the age of 60. So Deepak Kripekar and myself, we inserted an artificial sphincter in 1990, and that being a Parsi guy, that he lived till 90, and the artificial sphincter made him continent for next 30 years of his life. So if you want the patient to have a reasonably good life, then artificial sphincter is the answer. What is the significance of 700? We have 2 GORS fellowships. For GORS fellowship, the requirement is 60 urethroplasties in a year. We complete that in 1 month. So my current fellow, a girl from Argentina, second girl is from Colombia, and then we have student, his name is Brantley Scott. So with his introduction of artificial sphincter and artificial penile processes, we have a new branch of urology called prosthetics. He's the one who developed this Brantley Scott retractor. He was a born legend. He was a urologist working in Houston and was an innovator. So the whole branch of urological prosthetic belongs to one guy. So I just want to tell you about this joke about Professor Mandi. Somebody introduced himself to Professor Mandi that I'm a robotic surgeon. So Mandi said, I'm a Brantley Scott surgeon. Huh? So you use a robot. I use Brantley Scott retractor. What does it mean? You cannot be a robotic urologist, either uro-oncologist or an endo-urologist. You understand? You should never write on your heading that you are a robotic urologist. That's a wrong notion or a wrong motion. So Brantley Scott built his own aeroplane, and at a young age of only how many now? 60. He died in an aircraft crash, his own aircraft. So he's the one who developed AMS. It's called American Medical Systems. Initially, the number was 792, 793, 95, multiple revisions. So I just want to tell you today that suppose one of you want to develop an artificial sphincter, to do clinical trial is almost impossible, because you have to follow the patient for the rest of his life, and whatever complications are there, you will have to treat them free. That's why there are not many companies manufacturing an artificial sphincter today. So there are two varieties. One is the normal one, and on the right you can see one which is coated with antibiotics. It's called inhibizone, which is coated with vancomycin. What are the indications? Moderate to severe SUI. Dr. Manohar told us about the items which is used for mild to moderate symptoms of incontinence. After pelvic surgery, after trauma, we get a lot of patients of fracture pelvis, rupture urethra with bladder neck trauma, and then if the patient is incontinent, we use an artificial sphincter. This is now common post-radiation, then failed conservative treatment, and prior failed male sling. So how do we select the patient? Patient should be intelligent enough, and you should have manual dexterity to be able to handle the pump. Because if he has Parkinson's, it may not be possible for him to operate the unit. Informed consent is very important because the patient is going to spend significant amount of money. Today the cost in India is about 6.5 lakh rupees. So total cost to the patient, you add 1 or 2 lakh more, is about 8 to 10 lakh rupees for the whole procedure. And there are some high risk patients like post radiation, the chance of erosion, complications, diabetic, old age, smoker could be higher. We do cystoscopy to make sure that the urethra is okay. If the patient has concomitant bladder neck obstruction, we have to treat it before you insert an artificial sphincter, because after artificial sphincter, it may not be easy for you to go in with a resectoscope. All patients need urodynamics. During surgery, infection control and prevention is very important. So one must have urine which is completely sterile, no pus cells. And when we take the patient on the table, we scrub for about 10 minutes, and then we use a sterile technique. The number of people moving in and out of the theater has to be reduced to minimum. Once you take the patient inside, you lock the door and don't allow anybody to come inside. And then we use antibiotics. We usually use vancomycin and some kind of cephalosporins, maybe gentamicin also. The surgical procedure is very important. We want to avoid injury to the urethra and causation of a hematoma there. We insert a catheter during surgery, and then we take it out next day. And initially, we leave the device deactivated, and we activate it at the end of 6 weeks. So AU is implanted through surgery. There are 3 parts. Cuff. Cuff is like your blood pressure cuff, like your ring around the finger. It comes in various sizes. It can be inserted around the bulbourethra in majority patients, around the bladder neck in sexually active young male or in women. There is the pump, which is inserted in the subdartas pouch in men and in the labia majora in female. And there is a reservoir, PRB, pressure regulated balloon, which is inserted in the cave of Ridgius. And the 3 components are connected with tubes. So this is the paper in 2020. This paper suggests that evolution or evaluation of some 1,154 patients, mean age of 70, mean follow-up of 5 years. Overall device life was about 72% at the end of 5 years. So what happens over a period of time, there are mechanical problems, there are other problems, and at the end of 20 years, only 33% sphincters are active. So since 1972, more than 100,000 patients have been implanted, and then several studies have shown that 90% of the patients are satisfied, 92% would have it again, and 96% would recommend it to the friend. So what are the complications of this? Non-mechanical complication. What are mechanical complications? There are 3 tubings which join each other, so there could be leak over a period of time. So these are mechanical problems or rupture of the PRB. The non-mechanical complications are urethral atrophy, erosion, and infection. Sean Elliott studied 323 patients. 7.4% had urethral atrophy, 12% had cuff erosion, 4% had infection, 2% had pump displacement, and 1% had connecting tube erosion. On this left side, you can see that after endoscopy, you can see the cuff around the bulbar urethra has eroded, and there are various reasons to it. So George Webster accidentally inserted the cuff around the corpora cavernosa. So on the figure above, you can see normally the cuff goes around the bulbar urethra. What is the figure below, you can see he entered the corpora cavernosa on one side and came out to other. So the covering of the corpora cavernosa which are tough. So this is useful in those patients who have previous radiation. So transcorporal cuff insertion was an accident, but now it's a standard technique. Urethral atrophy usually leads to recurrence of incontinence, 3 to 9% where reoperation rate after urethral atrophy, because if the cuff is too tight, the pressure is too much. So revision surgery will be required for a higher pressure reservoir or a smaller cuff size and more fluid in the system. In men, it is possible to incorporate a second cuff. It's called double cuffing. The most important is quality of life. There is significant improvement in the quality of life, and any patient who is really going to have a long life, we do radical prostatectomy, and the life expectancy is nearly around 10 years. And suppose his incontinence does not improve at the end of 1 year, one should advise for a artificial sphincter. I'm going to show you a video of this technique. Can you take this down? Can you help me? Yeah, show the video now. So the surgery is usually done under spinal anesthesia. We applied steri drape, a perineal incision is made. This is the bulbospongy muscle which is incised in the midline. And then we want to insert the cuff as proximally as possible. When I am looking at surgery, I am looking at the large number of black dots. If there are too many, it's not a good surgeon. So going around the urethra without injuring the urethra is very important. The cuff size is 3.5, 4, 4.5, multiple sizes are available. This is a 4K camera, and then usually we do one artificial sphincter per month. This year we may have done maybe out at 8 or 10, going behind the urethra with scissors there. So this, everybody knows how to go around the urethra circumferentially. This is a mixture. We want to create a space which is about 1.5 centimeter. Then this is a pressure regulating balloon. Usually it comes in 3 pressure settings, and we usually use a 61 to 70. If one has to go around the bladder neck, we use a higher pressure. So one has to introduce saline inside and take all the air bubbles out. This is throughout the procedure. You have to keep on applying various clamps here and not allow air bubble to go inside. Then I'm going to measure the size of the cuff. The commonest size used is about 4.5 centimeter, and then 2 rubber shots applied, and then the cuff is placed around the bulbar urethra as proximal as possible. Now the second step is to make an incision. This is abdominal in the inguinal region on the patient's right side. You make an incision, open the muscles and go into the retroperitoneal space. This can also be done through the perineal incision with the finger inside. So there are two techniques. So this is an open technique, a small incision into the hernia site, and then this is a nasal speculum to create a space. You must make sure that you do not injure the bladder. People have inserted this around inside the bladder also, so that should not happen. So the cuff, this PRB, pressure regulating balloon, is inserted into the cave of Rhegius, and then it's filled with 22 ml of saline. One could also use radiation opaque material so that we can take an X-ray later on. The hole is little larger, so we take sutures so that it does not come out. Sutures with Vicryl here. The camera is in the hand, so it is little wobbly. So we want to make this hole through which the muscle to approximate so it does not come out. Now this is called as the passer. We pass the other tubing. So one tubing is black, the other tubing is white. So from below, the tubing of the cuff is brought into the inguinal region by this passer. This is behind the scrotum, and then pulling it up. This is the white tubing, again applying rubber shots, making sure at every step that there is no air bubble inside the system. There should not be a lot of slack. Now the third part is to have this activation deactivation button. So from the inguinal region, we pass this sponge holder just below the skin and open up a space in a subdartos pouch. The pouch has to be reasonable, about 2.5 to 3 centimeter long and 1.5 centimeter wide. And then this pump is positioned into the subdartos pouch. This level is completely different to your incision. So they are not connected to each other. You can see the pump here. It depends upon whether the patient is right-handed or left-handed, where the pump will go. And it has an activation deactivation button there, and the pump below. And then we apply a Babcock's forceps to the tubing so that the pump doesn't migrate during surgery into the incision. Now our job is to connect the tubes. The black goes to black, the white goes to white. And before we join two ends together, one has to again remove all the air bubbles, because this is a mechanical device. It is handmade. So the balloon is insufflated with 22 ml of saline, and we cut the tubings, and we have to join the tubings together. There are connectors available. So the tube, the instrument which takes the tubing away from the perineum to the inguinal region is called passer. And now we have another tool called crimper, which will help us to join the two ends together. Again, inserting saline inside. You must cut at right angle. This is the connector. The connector could be straight or at right angle. So two connectors are joined, and with a crimper they are brought together. So this is a straight connector. The other connector could be right angle, because one tubing is coming from below, one is coming from other side, inguinal region. The total operating time usually is about 45 minutes. And we actually autoclave the surgeon's dress before starting the procedure. A lot of care is taken to avoid infection. So all these rubber shots are removed. The tubings could be filled postoperatively in the inguinal region, but over a period of time, they all settle down. We initially cycle the device to check that the inflation, deflation is taking place correctly. And then deactivate the system. And then the wound is closed in layers. We use a catheter, 14 or 16 French catheter during surgery, but we take it out next day morning. And the system is deactivated, the patient goes home with a nappy, and then 6 weeks later he comes back, and we have to activate the button and he becomes continent. Occasionally there could be difficulty, so we may have to train this person carefully. This is an additional stitch which is taken, but it's actually not required. This allows this cuff to stay at the correct space, it doesn't migrate. Actually, any patient after radical prostatectomy has incontinence. This should be advisable, because this is the only device which makes the patient what we call bone dry. The other device, atoms and other things, suppose the patient is wearing 4 pads, from 4 pads he goes to 1 pad, and that is not useful for the patient. If the patient is active in his life, wants to enjoy his life, then this is the one which he has to use. I think we have been using for 30 years. Now, compared to what initially all my patients were post-URP incontinence. Now we are getting increasing number of patients post-radical prostatectomy and post-radiation. Post-radiations are tricky. I did one patient in Bahama. It was a orthopedic surgeon's father, and it eroded because it was a post-radiation case. So next time I had to go in and take it out and insert another one. So patients will travel, or you have to travel around the world. So today I have a patient who has come from Somalia for resume. Patients will travel around the world. So thank you very much. Any questions on the artificial sphincter? So most important, Brantley Scott. Never say I am a robotic surgeon. I am an oncologist. I am an endourologist. So there is a problem in America. Robotic surgery is done by oncosurgeons, because America has 800 fellowship-trained oncosurgeons, and they have endourologists. So there is a fight going on. So you should introduce yourself. I am a oncosurgeon or a endourologist.
Yes, sir.
My job is to tease you. Okay?
Thank you very much for the wonderful.
So my usual teasers, can I ask them usual teasers? What's the meaning of a doctor? Any of you? Huh? Yeah, meaning of a doctor is a teacher. How do you measure size of your glove? He knows the answer because I told him long time ago. Apart from sir, who invented a urologist in India today makes a lot of money using one instrument. That's a rigid ureteroscope. So who invented rigid ureteroscope? Don't you think it's important for you to know? You are making so much of money buying Mercedes car by using an instrument which somebody else developed. So Dr. Mahesh Desai invited Perez Castro from Spain, and in his name the invention goes. Who invented the laser for stone surgery? Everybody is using laser. Graham Watson, my co-registrar at the Middlesex Hospital. He invented, the first laser was called for stone surgery. Anybody? It should be like a notebook. Then you can absorb knowledge. If your mind is like a book, if you think you know everything, I cannot put anything inside. So to tease you that you have to learn from Sir Mahesh Bhai. What happened with his life? He came from England, he knew only TURP. Then came ureteroscope, PCNL, ultrasound. Then he became a laparoscope, then single port laparoscope, robotics. So he learned laparoscopy at the age of 60. Hats off to my guru. Thank you.
Thank you, sir, for the wonderful presentation on artificial uterine sphincter.
1 minute, Ravi. So we come to the end of this session. I thank all the presenters for sharing this wonderful session. We thank KUA and Apollo Hospitals for this wonderful opportunity. Thank you.
Thank you, sir. So, chairpersons, kindly stay back on dais. Meanwhile, thank you, Sanjay Kulkarni sir, for wonderful presentation on artificial uterine sphincter and your session of teasing us, and we carry forward your message and try to learn new things. Sir, we kindly request you to come on dais, sir, please. And I also request Honorable President of KUA, Dr. Chandrasekhar sir, and Secretary of KUA, Narendra sir, to be on the dais. Thank you.
So your job is to tease, our job is to felicitate you. So to accept your meeting in itself, the way you come itself is a testament to the fact that you are so committed to urology and its growth in USA. And I remember, I'm just indebted to you both. You said that you were in a meeting that time when I called you, Manor, where is the venue? You didn't ask me anything. You just asked me where is the venue, let me know, you messaged me the venue. You didn't ask me the brochure, you didn't ask me the invite. I think that's how this has been happened. I'm just grateful to you, hats off to you for unwavering support you have given to us. So please, you can decorate the seats, sir. We are really indebted to you, and your presence will enrich the knowledge of the younger colleagues. Dear sir, we would like to facilitate and honor you and accept our facilitation. Dr. Sanjay Balwant Kulkarni, Doyens of Surgeons, and your work on erythroplasty is very well spread worldwide, and you just mentioned that 700 surgeries being done and 60 students have been trained, and you stand tall among the surgeons and of great repute. So you authored a textbook on art of urethral reconstruction and have more than 100 publications. As a BCRI awardee and president of USA and many more accolades to your name, we are happy to felicitate you with lots of joy and respect. I request our president to
the first photo studio in Bijapur was a Kulkarni photo studio of my grandfather. My father was a photographer too, and in his office, his surname was Bidarkundi. Bidarkundi is a place which is near Mudde Bihar, and then he never used his original surname, which is the Kulkarni. So I am Sanjay Badavanta Bidarkundi, that means a proper Kannada name. But my father had, because he was in ammunition factory, he had lot of promotions, but because education was fantastic in Pune, we three brothers, my parents never moved out of Pune. He refused all his promotions and remained at the same grade for 30 or 40 years, and then because of education. So I'm a urologist, my brother is an engineer, third brother is a lawyer, and we still stay together in the same house, single kitchen, single television screen. So we are lucky to have Kannada background. Dr. Shyam Joshi again was from this part. Dr. Baliga, the most important surgeon in Mumbai, was again from Karnataka. So this is significant contribution of Kannadiga. Thank you very much.
Thank you, sir. Sir, I request Chandrasekhar sir to stay back and felicitate our chairpersons and speakers. May I request all the speakers of the current session to please come forward. Raghunath sir, Dr. Anand Kumar, please come forward. Meanwhile, we can felicitate the chairpersons. I invite speakers, Dr. Anand Kumar. Dr. S.K. Raghunath. Thank you, sir. With this, we conclude session 3. We will be next heading for session 4, which will be lectures on complications of medical and surgical treatment of PH and TURP. I now invite the chairpersons, Dr. Nishchit D'Souza, Dr. Chobe, Dr. Suresh Kagalkar, Dr. Kumar Prabhu. Sir, kindly take the dais, sir.
Welcome to the evening session, post-lunch session, that is session 4. I must say congratulations to Dr. Sanjay Kulkarni sir. Sir remembered Bijapur. So I am from Bijapur. Whenever in India, wherever I go urology, the first name comes Bijapur means Dr. Sanjay Kulkarni. We are proud and whenever you meet sir, the word is always Patil and myself. So that's what we remember, and thank you once again, sir. With this, today I welcome all the delegates for this session 4, and also I welcome all the speakers. Myself and along with me, Dr. Nishchit D'Souza, Dr. Chobe sir, and Dr. Kumar Prabhu, we are here chairperson, and let us start the session. The first lecture, please. Chobe sir.
Yeah.
Yeah. Yeah, you can, Dr.
Thank you
Rohit
so much.
Joshi,
Thank you
you
so
can
much.
start.
Once again, thank you so much, KUA. Thank you, Manohar, and thank you, chairpersons. This is a very relevant session. Like, we don't frequently have this kind of session, Manohar, and then I think we need more of this kind of session when we talk not about our successes, but more about our failures, because success goes to the head, but the failure goes to the heart. And it's our failures that teach us and make us better surgeons. So I think we should be speaking more on our complications, and we have a complication galore. I have been doing HAWLEP for last 13 years, more than 2,000 cases. So I have seen many nightmares in urology, especially in the relevance to the current thing is holmium or thulmium prostate enucleation. I have certain disclosures, but nothing is more important than the science, because science prevails over commerce on any day. I do believe TURP is the gold standard, HAWLEP is the size independent gold standard. And having done so many cases, I still, when operate a new case, I still go back to where I started. This is the Hippocratic oath we all took: first, do no harm. That is the primum non nocere. But the one who has not done any mistake or complication might not have operated any. And good surgeons learn from their own complications like me, but the great surgeons learn from others' mistakes. And today my job is to make sure to convert all of you into great surgeons. So with this, let's go to the nightmares one can have from the HAWLEP. But there are several categories of thing. One first can be the surprises, intraoperative. Second can be the untoward events of enucleation. Then we have untoward events during morcellation. And lastly, we'll have some unwanted sequelae. These are the four kind of headings I have in a fragment in my talk. Let's see what we mean by intraoperative surprises. These are not complications. These are physiological things. But still, they surprise you a lot. And if you do not recognize that surprises, you might end up in getting something complicated. So first thing is unfriendly urethra. Now this unfriendly urethra is not a strictured urethra. It's a normal urethra. Now you see, I am trying to negotiate that particular curve with my 22 French mini HAWLEP assembly. And what I have done is, I am not able to negotiate it. And the moment I exert a little bit of pressure, what I see, I damage that particular site. And I'm sure this is the site which is going to get strictured later on. So this was not even a 26 French assembly. So I was pretty confident. And even then with my 22 French, I could not negotiate that now. And what I ultimately had to put was, I passed in a terumo wire, put in a catheter, and then staged the enucleation for the later stage. So these are the intraoperative surprise in form of unfriendly urethra. So we need to respect and anticipate and accept these kind of urethra and stay away from causing an iatrogenic stricture. Same thing is, I call this a dual veru. Now you see, when there is a huge prostatomegaly, at times the veru is so much stretched that you can see there is a one veru, then you come across there is a second veru. Now what significance we have is, we always start our V incision just proximal to the veru. So if you do not correctly identify the actual veru, you might end up doing an inadequate or incomplete enucleation, and there will be a residual lobe left behind. So this is the importance of this kind of anatomical variation which one needs to be aware about. Now there are several untoward events in form of complication that can happen during the course of enucleation. We all must have come across this once or other times. Arterial bleeding. So this is the arterial bleeding. The enucleation is happening very nicely. I am on the capsular fiber, and then there is a severe arterial bleeding. Now the problem when you do with the laser enucleation as compared to the TURP is, in the TURP we have that metallic loop. So we can actually use this as a compression, and we can compress it proximally and control that arterial bleeding. But when we are doing with the laser, even if you try to exert little bit of pressure, you go deeper and deeper. So that's the problem when you are trying to achieve this coagulation of arterial bleeding with the help of laser fiber. So one has to differentiate the source, whether it is arterial or venous, and always try to search for a ricochet bleeder. You might be seeing on this wall, but the bleeder might have been on the opposite wall. So if not controlled, there is no shame, no embarrassment in switching over to the loop or roller ball and securing that particular bleeder. And again, going back to the enucleation, there is no shame. Having said that, with experience, we can actually stay away from the bleeder, find out the source, find out the base of that bleeder, and then you can do distance kind of laser coagulation, and then we can secure it. But you are not always confident about it, then you can easily switch over to the cauterization. Venous sinus bleeding, we all have seen this sinus bleeding in the TURP. The difference between the sinus bleeding in TURP and holmium or thulium enucleation is, in TURP usually it happens at the very end, but in the enucleation it happens quite early in the course of your procedure, because you are going first in the deep, and then you see now there is completely clear vision of all the adenoma in the bladder, the vision is complete, but the moment I come back within the prosthetic fossa, there I see all this kind of diffuse oozing. And mind well, in TURP, by this time you have finished the resection. What you have to do is evacuate those chips and put catheter and give a traction. But in enucleation, a new procedure, a morcellation is altogether remaining. So with this kind of vision, if you are trying to go for the morcellation, you are bound to injure and bound to get one more complication. So remember, you have to again differentiate the source. Never try to coagulate the sinus. I have seen somebody chasing that sinus right up to the IVC. One of the workshops, I told, please spare IVC. Do not go chasing that. So you can actually leave a catheter, give it traction for 7 minutes, stay there, and again go back with your morcelloscope, and you can morcellate the lobe. Or in a bad day, when you cannot get away doing that, you can always stage the procedure and do the morcellation at the second step. There is no harm. However, in this case, we could manage by keeping the catheter and traction given for 7 minutes, and then it was a crystal clear vision. We could successfully morcellate the tissue. But you have to always give it a thought, because if the sinus is open quite early in the course of your enucleation, even the hemodynamic instability can happen to the patient, which your anesthetist can tell you. Capsular perforation, now there are two kinds of perforation. One of them is the covered perforation. Now this, in morning we talked about not giving too much of physical pressure. Now here I am incising with my laser fiber. So the moment I realize, I stopped there. So this was a covered perforation. Now many of us must have seen, people doing mechanical push. Especially Mallikarjun does this a lot of time. And this, look at this. Now this is a full thickness overt perforation. And this can never be converted into a covered perforation. So that is why we don't intend to push or use mechanical force too much in enucleation. Now how do we get away? Never use the blunt force. Recognize early, and whenever you recognize it, you have to leave one level superficial. You have to come one level superficial and leave a tissue over that perforation, so that you can convert an overt perforation into a covered perforation. And always keep an eye on the hemodynamics. Ask your anesthetist, because such perforation can lead to tremendous amount of fluid absorption, though it is normal saline. But still, if you are contemplating a patient who is having a poor renal reserve or poor cardiac reserve, that small amount of fluid absorption can lead to so many disturbances to that patient's hemodynamics. So keep an eye on that. So this is what I was telling. One more thing is trigonal dissection. Now this classically happens when you are encountering a very huge median lobe. What happens is you are doing it conventionally, so your laser fiber is at 6 o'clock. So you intend to go deeper and deeper, because the median lobe is not flat, it's like a scaphoid. So median lobe is going down and then coming up at the bladder neck. So you accidentally, once you are doing it 6 o'clock, you always are bound to go in the deep. So this again, we need to reorient yourself. We have to again go one level superficial. See, I am leaving one layer of tissue over that dissected part, so it gets covered, and there is a minimal fluid absorption. And leave a sleeve of tissue over that dissected area. The lessons learned is, you have to anticipate this in a very large median lobe. Identify the capsular fibers at the bladder neck level right at the outset. And at times, you have to do a reverse enucleation. Rather than, enucleating a median lobe by keeping your fiber at 6 o'clock, you reverse it and start working from the 12 o'clock. If you start working at 12 o'clock, your fiber will come from 12 o'clock. So rather than going into the depth, you will work on the median lobe. So whenever you have a large median lobe, always try to do a reverse enucleation. Now, not just enucleation, the morcellation is equally painful, because you have done the enucleation, you have used all your adrenaline, you have consumed all your adrenaline, and then there is a new procedure which you have to learn and finish. So the morcellation is really testing your patience. And these are the 4 things which can actually bother you when you are doing morcellation. This is the classic thing. Many of you who are doing HOLEP must have come across this. These are the last few pieces or balls, which I call it. These are the snooker balls. The moment you go and try to chase, they slip away. They slip away, they resist to be caught by your morcellated blade, and then you get frustrated. So what do? We stop chasing those kind of cheesy balls, use a mechanical retrieval forceps and catch hold of them and take it out. If they are small enough, you will be able to take it out, but if they are large enough, you will not be able to take it out, so you have to resort to something else. So it's a frustrating event after an adrenaline consuming enucleation. Do never chase them, let them come to you. And you can always use a retrieval forceps or a TURP loop for that matter, and we can take it entirely. The second thing is blade re-injury. It's an extension of chasing these kind of cheesy balls. Once you go and chase them, and the moment you feel I'm lucky, the piece is clugged to your marsupial blade, and you start marsupiating, accidentally you pull the bladder mucosa, and what you end up is getting a perforation in the bladder wall. So this is an extension of these cheesy balls. So whenever this happens, you got hold of a bladder mucosa, first of all you have to identify it, recognize it that I have done this. The moment you've done that, you immediately switch off your marsupial console so that there is no constant suction. But even if you have switched it off, there is some amount of suction which remains in the tubing. So next thing is you have to remove the tubing from your handle of the marsupial blade. So that will eliminate the suction. The moment you do that, and then you have to gently detach and take it out, and most of the cases it is inconsequential. These are superficial perforations, and they heal within 48 hours by keeping a catheter. Morcellation failure, you have done huge lobes, and somehow or other, either because of your equipment is not functioning, your blades are getting older and they are losing their sharpness. CA prostate, I have recently operated 2 CA prostate, known carcinoma prostate. This prostatic tissue is very tough and they are really difficult to morcellate. And then lastly, like 600 grams prostate, Manohar told, if these huge kind of prostates are there, the entire bladder is getting filled with those 2 lobes, and in this kind of huge lobes, it's very difficult to morcellate at times. So in such cases, you can actually switch over to a new set of blades, or you can stage the procedure. Many times in a bigger glands, we stage the procedure. We do complete enucleation, keep those huge lobes inside, and when you contemplate morcellation 48 hours later, they get very easily, because all the water gets sucked out and the tissue becomes so fragile, within no time you can morcellate the entire thing. Lastly, it's very difficult, but you can do the TUR of the floating lobes in the bladder. But mind well, this is a very difficult to use instrument for n number of times. We keep on using the same instrument. Actually, this is the blade piece which has got broken, because we keep on sharpening it, because we don't want to invest too much in the new sets of blade. And there it happens, the morcellate blade gets broken. It happened once during a case of a Eurolift enucleation, and now this is the case where I had been using the same set of blade. And so what I have to do is, I have to understand, I have to anticipate that this is the blade piece there. So what you have to do is identify the event, you change the blade and finish the morcellation first. Don't chase that piece of the blade first, you finish the morcellation, you retrieve all these floating tissues, and lastly, you have to catch hold of that piece of the blade and make sure you remove them under vision and through the sheath, and do not take it out entirely with the assembly, otherwise it will lead to urethral erosion. So these are the things which can happen during morcellation. Lastly, there are unwanted sequelae. Now, I was supposed to speak on TUR as well as holmium. So these are the unwanted sequelae of TUR as well. So we can have strictured urethra. So we all know strictured urethra, and this is a very unpleasant sign for any one of us, and we all come across this. And this is what we do, that we pass a terumo guide wire, and then we have an option either to do a cold knife or a laser to incise that stricture. Why I am showing everybody of us is doing it, but why I am showing is, look at the cold knife incision of the urethra stricture. It is very much uncontrolled, and it cuts not at the site where it is supposed to cut, but it cuts at entire length. Now if you can compare this with laser assisted VIU, you can appreciate that your cut is very, very precise, and what you need to do is, you do not cut at single place, you have to put multiple radial superficial incisions so that it doesn't lead to too much of spongiofibrosis, and we can actually, if not prevent, delay the occurrence or recurrence of the stricture. And with this kind of precision, you can actually make an Indian map out of your stricturotomy using laser. So this is the classical Indian map which I could create with my laser. That is the precision which we can have with the help of laser. We can do this. I presented that in Kuwait and they really liked it. So this is the precise cut we can have with the laser. Now lessons learned, we have to go mini. We are going from standard PCNL to mini PCNL. Same thing, even in the whole lab, we have to reduce our size, because the size which we are importing from the West doesn't fit our urethra. So we have to reduce. So now we are using mini whole lab 22 French assembly. And this assembly is, after using it for last 9 months, my stricture rate have gone significantly down. So this is how we can prevent stricture happening. Second most bothering complication is bladder neck contracture. We all know, we all come across this thing, and after a satisfactory enucleation or TUR, what we do is again poor flow, and there is a jet sign of thing. This is not PBNO, this is the secondary bladder neck contracture, and now again there are two options. We can have either cold knife incision, or we can have laser incision. Again, when you use cold knife, the cuts are not that precise, not that controlled, so you can actually do multiple 3, 6, 9 and 12 o'clock. But when you use the laser, you can actually use the laser fiber as a guide wire and poke that small hole and identify that hole, and you can have a very precise incision. But not every time you are so fortunate. Many a times you don't get any opening which can lead you into the bladder. So that is the time when even incision is not possible. So this is the same case, where I could not see the finding, the opening into the bladder. So what I have to done was, I had to resect the entire scar. The way we enucleate an adenoma, the same thing I enucleated and resected the entire bladder neck scar, and ultimately had the same opening which I created initially. So these are different complications and different ways to manage them. And lessons learned is, whenever you have a small prostate, prefer incisions over enucleation. It is a small gland that frequently culminates into bladder neck contracture. You can preserve 1 minute more, a small mucosal strip at 12 or 6 o'clock, and at the end you can incise the bladder neck. This doesn't have much of literature support, but this is the practice which we are following, and we are encountering less and less contracture. Now this is a new complication, this is the last complication, or it's an unwanted event. People are now doing right and left enucleation since the TFL has come, and this is
Sir,
what I
time
am
is up,
saying
sir.
frequently.
One more. Time is up.
This is the last slide,
Yes.
my friend.
Yeah, please continue.
Okay, so this is the residual adenoma, which I'm frequently seeing now, because because of this kind of TFL laser which cuts everywhere. It's a de novo complication of TFL. It cuts anywhere. Holmium fiber will allow you to cut only if you are in a correct plane, but with TFL you can cut anywhere. Even if you are cutting through the adenoma, you'll be able to cut, but with holmium you will not be able to do that. And that is precisely why the papers have come that TFL has a lesser learning curve, but the job is not completely done. This is my personal experience, and that's why we are coming across so many incomplete enucleation. So what we do is, here the right lobe was entirely enucleated, but the entire left lobe was there. So we have to enucleate the entire left lobe and complete the enucleation. So coming to the last few slides, the take home message is, anybody and everybody is bound to make complication, but you have to remember this acronym DPT. You need to be able to detect it early, and you need to know how could we have prevented it. And lastly, it depends on how best you could tackle it, both the patient as well as the complication. That defines the urologist in you, that defines the human being in you, that defines the person in the you. Because my friend, the only person who never makes mistake is the one who has never done anything. And we learn from failure, not from the success. The only real mistake is the one from which we learn nothing. So we keep forming mistake and we keep learning for the betterment of our own selves and our own patients. Thank you so much for patient listening, friends. I'm happy to answer any questions.
Thank you, Dr. Rohit Joshi, for nice presentation. I would like to just add to your presentation that if you are in the correct plane of this capsule and adenoma, hardly will come across any venous sinusoidals. So I think if you are in a plane, the bleeding and chance of bleeding will be less and all. Second thing, if there is enlarged median lobe, what I would to do, that I just inside the excessive median lobe, plus with the bladder, then I make incision at 5 and 7 lobe. Doing that, I get a nice plane, good and my experience I'm sharing with you. So I have very lot of complications of bleeding during the surgery.
So this is the compilation of last 13 years and not all complications of mine. I have been, attending so many my fellows who are doing that, so they also send me videos. These are the experiences of, people who are doing in early part of their career. But yes, you are right, your point is well taken, sir. Yeah.
Here many postgraduate PGs are there. For the benefit of that, what tips you want to give for the arterial bleed in case of TURP?
Arterial bleeding during TURP or holmium?
What
during,
arterial bleed.
I'll tell you, arterial bleeding, first thing is you need to differentiate the source, whether it is an arterial or a venous bleeding. And once you identify it's an arterial bleeding, you have to look at whether it is coming from the same wall or it's a ricochet bleeding. And thirdly, you have to always come distally, and you have to go to the base of that particular thing. In TURP, what happens many times, we cut and then we see an arterial bleeder, we try to coagulate, then again we cut deeper, again the same bleeder will come again and again. But in holmium, what we do is we reach right up to the capsule, so the base of the bleeder is coming first. So in holmium or in thulmium enucleation, we have to identify the base and coagulate. But in TURP, do not coagulate that bleeder unless you have reached to the fiber, because every time you coagulate, once you are cutting one more level deep, again that bleeder is going to bleed. But one thing is, never allow that bleeder to get retracted into the capsule. So always stay away from the bleeder site, find out the base and coagulate it. Don't lace it right on pinpoint. You always lace it from the side. Otherwise, if you do it from pinpoint, that bleeder is likely to get retracted deep, and then you will be searching all around.
Congratulations, excellent compilation, sir. Just one question to Dr. Sanjay, sir. Sir, he showed that initial procedure where he could not, we could forcefully pass the scope inside the bladder during the TRP. What would you suggest for such a situation?
But sir, that, yeah, I agree.
If there is a difficulty, it usually starts with the meatus. So what Dr. Mahesh Desai is saying, balloon dilatation, I would do non-otis ureterotomy or pass a large dilator. Passing a large dilator and otis is basically blind procedure. But in England, we used to pass a dilator, large prostates, dilator inside the bladder and not dilator, the otis, and have a full cut through the sphincter. In India, we pass it into the bulbar urethra and make a cut into the penile portion. Usually, there is no problem with the bulbar urethra because it's 30 French. But if it happens, otis cut.
Up till the sphincter?
Yeah, no problem. No problem. You can actually pass it inside the bladder and make a full cut because it's a mucosal incision.
So, if there is no questions, any question from audience? No, we are running short of time. Thank you, sir. Thank you, Rohit, sir.
Thank you.
The next speaker we call upon Dr. Altaf Khan from Bengaluru. The topic is complications of medical management of BPH and real world scenario. Real world scenario.
Good afternoon. Respected chairpersons, distinguished faculty and guests. At the outset, I would like to thank Dr. Manohar and KUA for giving me an opportunity to talk on complications of medical management of BPH. When Dr. Manohar called me to give a lecture on medical complications of medical line of management, I was just wondering what are the complications, because most of the time we really tell the patients that okay, these are safe drugs, you can take it lifelong without any complications, except for one orthostatic hypotension or something, or erectile dysfunction. We never caution them of other side effects. But when I went through the literature, I was also surprised to see so many complications associated with the medical line of management. So being a general urologist, our BPH is bread and butter of each of us. So it comprises almost 30 to 40% of our medical practice. And BPH affects more than around 80% of men in their lifetime. Initially, we give a lifestyle modification and pharmacotherapy. These are the first line therapies for management of such patients. Normally, the medications include the alpha blockers and 5-alpha reductase inhibitors. Nowadays, we have phosphodiesterase inhibitors also, and anticholinergics and beta-3 agonists for LUTs of storage LUTs. Now, this MTOPS and COMBAT study showed that medical management decreased progression of the disease, and this was a big breakthrough in the BPH management. While often well tolerated, most of these pharmacotherapies definitely have a significant side effects. The traditional, like one size fits all, like initially we start with medications and later we go on for invasive therapy, doesn't fit for all the patients because of so many complications that can arise. So once we are we don't know about the complications, and the mind doesn't know what then the eyes cannot see. That is the famous quotation. So similarly, most of us will not be aware of other complications associated with medical line, and we just keep on putting a medical line of continuing with the medical therapies. And unless we come to know that there is such a complication exists. So coming to, I would like to just talk on few complications of alpha blockers and 5-alpha reductase inhibitors. So this is a case scenario, like a regular case of a 66-year-old male who came with the voiding LUTs and increased frequencies in 6 months. A known case of diabetes and hypertension since 10 years. A small gland on prostate on DRE, and ultrasound was just 28 cc. So normally we start on alpha blocker, single alpha blocker, either tamsulosin or. So, but since it was a busy OPD, I think that doctor didn't have any time caution to explain to the patient that such a complication like orthostatic hypotension can arise. The patient took the medication just before sleeping as advised by the doctor. Then night he had a nocturia also. He woke up at 4 p.m. or 4 hours later to micturate. All alone he went to the bathroom and he had a fall, developed a fracture. Now whose fault is this? We as the surgeons, we hardly take time to communicate to the patient that this can be one of the complications. So this first dose hypotension is very notorious, seen in tamsulosin, and it at an incidence of around 4.2%. Coming to just a recap of the adrenoceptors, there are two types of adrenoceptors, alpha and beta. Beta are most commonly seen in the cardiovascular system and the heart, and alpha is seen in the prostate, seminal vesicles, urethra, bladder neck, lower ureter, and also alpha B, 2B, 1B is seen in the vascular blood vessels. These are the distribution of alpha-1 adrenoreceptors at the level of prostate and bladder neck. So alpha-1B receptors mediate vascular tone, and alpha-1 are usually present in the genitourinary tract, which help in the inhibition. When the blockade of alpha receptors will cause a relaxation of the bladder neck. Now, which is the most common like selective alpha blockers like tamsulosin and silodosin will have less side effects compared to a non-selective like terazosin and doxazine, which now we have given away with those medications. And alpha blocker also can cause dizziness and asthenia. Now, this complication is not because of effect on the bladder, but this is because of the alpha-1 receptors in the brain also, which can cause asthenia and dizziness when it is blocked. This is one more scenario. 45-year-old married hypertensive. He presented with difficulty in voiding pure stream. On DR, it was grade 1 prostate. And cystoscopy was done, it was found to have a high bladder neck. So he was initiated on alpha blocker, silodosin, since he was a young, ISD and hypertensive, he was started on silodosin. 6 weeks after therapy, the symptoms improved. But he developed anejaculation, and he was looking out for a second child, and he was not able to conceive. Then he went for semen analysis, and it showed that he was azoospermia. Even post-ejaculate urine sample didn't contain sperm. Now, what has happened here? Apart from the alpha blockers in the bladder neck and the urethra, the alpha blockers are also act on the seminal vesicles and the ejaculated duct. And this the reason they cause anejaculation because of the result of smooth metal inhibition, which prevents propulsion of the seminal fluid from the semen. Almost 10% of the alpha blockers can cause ejaculatory dysfunction in 10%, except for alfuzosin, which has the least ejaculatory dysfunction. And as a result, we ask them in young individuals, we propose the alfuzosin. And one more case scenario, 52-year-old with LUTs and prostate size of 56, no other comorbidities. He was started on silodosin with dutasteride combination. On follow-up of 3 months, his urinary symptoms definitely improved, but complained of erectile dysfunction and also loss of sensation. Now we know that erectile dysfunction is definitely a complication of 5-alpha reductase inhibitors. Now the 5-alpha reductase inhibitors like finasteride and dutasteride, they inhibit conversion of testosterone to dihydrotestosterone. This dihydrotestosterone is very vital in physiological erection as it activates nitric oxide synthesis and increases blood flow in cavernous tissues. This also leads to decreased autophagy and increased apoptosis in the cavernous smooth muscles. Patients on finasteride are more likely to have loss of libido and ejaculatory disorder and ED compared to durastride. And we will be surprised to know that the percentage of ED adverse events reported by medication class, 5-alpha reductors have the maximum incidence of erectile dysfunction, even when compared to neuropsychiatric drugs like citalopram or sertraline or quetiapine. Even more than that, this finasteride and durastride have got adverse effects of erectile dysfunction. The fourth scenario, this is a 65-year-old patient who was initiated with tamsulosin and finasteride for voiding LUTs. On 6 weeks of follow-up, there definitely was improvement, but he had gone for a routine executive checkup. He noticed that his liver enzymes were elevated. Then he got scared and he went to a gastroenterologist where he did all sorts of investigations and also including a liver biopsy. And it showed that it was a cholestatic injury. Then later when he took the history, he came to know that he was only on this 5-alpha reductase inhibitors. This inhibition of 5-alpha reductase, they impede glucocorticoid and androgen metabolism, and this contributes to the pathogenesis of non-alcoholic fatty liver disease. Inhibition of 5-alpha reductase type 1 activity also induces insulin resistance and hepatic steatosis, which predisposes to hepatic fibrosis. This is the last scenario in a 66-year-old male with voiding LUTs, a large gain fairly with the Qmax of 6 ml per second. He was started on again tamsulosin and finasteride. After 3 months, he was okay. IPSS score also improved and Qmax also improved. He was asked to continue with the same drug. But 6 months later, he had severe developed depression and also had suicidal thoughts. Now what is this? He went for the psychiatric evaluation. He was prescribed antidepressants, but nothing worked. This what is called as the post-finasteride syndrome. This was first discovered, in 2012. It is basically a syndrome which is used to describe persistent sexual, neuropsychiatric and physical adverse reactions. Even after discovering the medications, you get all these symptoms. The main cause is the reduction in the neurosteroids. This allopregnanolone is a neurosteroid which is produced by 5-alpha reductase. It is altered by 5-alpha reductase inhibitors, and this leads to the depression in such patients. There are also other neuroactive steroids like pregnenolone, dihyperandrosterone, progesterone, which have important physiological regulatory actions, which also help in controlling endocrine control and also in sexual behavior. One of the important symptoms of post-finasteride syndrome includes the loss of libido, erectile dysfunction, shrinkage of penis, an abnormal curvature of penis, testicular pain, chronic fatigue, muscle weakness, and main thing is the depression, including suicidal thoughts. So we should be very careful when we are prescribing it for elderly people who are all alone, and most of the time they will be staying alone with their kids away. So the main thing is to recognize such a complications. Other complications do include the intraoperative floppy iris syndrome that is seen during cataract surgery. There is progressive miosis, then billowing of iris and also iris prolapse. Though we can't do much, the ophthalmologist should be told about that he is on such drug so that they can take precautionary measure. Also, there is fetal risk when the female partner is exposed with the dutasteride drugs. They can chances of animal studies that have shown that external genital abnormalities can occur in male fetus. And also, blood donation. So, a patient on the dutasteride is should not donate 2 more slides. Blood for at least for 6 months, so that if this transferred to a female pregnant lady, then they can have also problem with the fetal problem. And other symptoms include new onset diabetes mellitus, gynecomastia, and even high risk prostate cancers. Other complications for other drugs like cholinergics, most common is the xerostomia and also acute urinary retention and constipation. Whereas of recently we have started using phosphorus inhibitor, which can cause severe backache and headache and flushing. And also beta-3 agonist, which can cause hypertension. So to conclude, medical line of management can be very effective in elevating symptoms. But however, we have to discuss the potential adverse effects of this pharmacotherapy in BPH patients. Thank you.
Yeah, thank you, Dr. Alpha. The commonest problem we see day to day is that the patients stop the medicines because they will say you prescribed for 2 weeks and then come back. So we will come after 1 month, 1.5 months, so the medicine is off. Anyhow, any questions from the floor?
Yes, nasal stuffiness.
2-3 times people have discontinued.
Yes, sir. Whenever there is definitely adverse events, we can't continue the drugs. But then we have got so many other minimally invasive therapies we have seen since morning, the Urolift, the Razum. I think we can go for one of those.
Okay. Any more questions on the floor? I thank Dr. Altaf. Yeah. With that, we finished the session 4. And I think next is the tea break. Organizers. Yeah.
Yes, thank you, sir. I would like to request the officers to stay back and we'll have to felicitate him. Sir, please do the needful, sir. Joshi, sir. Dr. Altaf Khan, sir, please. Sir, new stage. Altaf. Dr. Rohit Joshi. We'll go ahead with our 5th session, which is training sessions on prostate MRI and biopsy. I would like to invite our chairpersons, Dr. Nagarajaya, Dr. Dinesh Kumar TP, Dr. Shivarama Krishnan, Dr. Meherwade sir, and Dr. Srinath sir. Please take the dais, sir.
Hello, good evening. We are starting the 5th session of this wonderful program. First, I will invite Mr. Dr. Chaitra. He is a radiologist from Bangalore. She will be speaking on MP-MRI role in prostate. How to read it and how to train urologists regarding this. We are very novices in MP-MRI.
Topics I would be covering is the gross anatomy, which you all know about it, and then the MR imaging, so which has the technique, and you'll have to know the sequences what we usually acquire in MP-MRI. Next comes the anatomy, and the case is based on PIRATS version 2.1. I'll be happy to answer your questions if any at the end. The gross anatomy, I'm not going in detail of it because you all know about it. Prostate, it consists of 4 things. That is the anti-fibromuscular stroma, which is anterior most part, and peripherally there is a peripheral zone that constitutes around more than 70% of it. And then next comes the transition zone, which is this portion which is surrounding the urethra, and then there is the central zone which is surrounding the ejaculatory ducts. Moving on to the MRI prostate. So the technique what we use is so we take the sagittal plane, and then there is along the rectal surface of the prostate we take the parallel plane. If we take a parallel plane, we get the coronal section. That is, we are cutting the prostate this way, and then if we take a perpendicular plane which is to the rectal prostate of the rectal surface of the prostate, we get an axial plane. That is, we are cutting the prostate in this section. And one more thing is we don't use the endorectal coil in most of the places. We usually use only the pelvic phase coils, that is only over the abdomen. We don't use any endorectal coils per se. And then to reduce the susceptibility artifacts from the DWI imaging, so few of the centers do use enema to reduce the rectal gas. And coming to the MP-MRI, so when we say MP-MRI, that is multi-parametric, we have to acquire more than 2 sequences. So what are the sequences which we use is the T2-weighted imaging, that is axial, coronal and sagittal. We need in all 3 planes because we need to calculate, the volume of the prostate, and this is also required for the PSA density. And the second sequence what we use is the DWI imaging, and then the dynamic contrast enhancement. So in the dynamic contrast enhancement, we have again 3 categories. Qualitative method, which is most commonly used, even we use the qualitative method. This is just the visual assessment, whether there is early enhancement of the whatever the peripheral zone, any lesion. So semi-quantitative method, as you know, there is something called type 1, type 2, type 3 curves. You would have heard about it. So that is the semi-quantitative method. Quantitative method, it requires a different software. I'm not going in detail of it. So it has discrete trans and reverse reflex methods. Coming to the T1 weighted image, do we have to take it? Yes, because T1 weighted image is very sensitive for any hemorrhage within the prostate, and then to look for the lymph nodes and also for the bony lesions if any. So of course, apart from T1, we also do something called stir sequence, which we have adopted in our center. We do the stir sequence of the whole spine. And then coming to, have you heard about biparametric MRI? Here we use only 2 sequences, that is DWI and T2. We don't use a contrast, but can we do it in all patients? No, it is only for selected individuals, selected patients where you are clinically very highly, you are suspecting a CA. So that is your PSA is also very high, and then DRE is also you're considering some really cancer in that particular patient. In those cases only you can do the biparametric MRI. Advantages are, one is the cost, one is the time. Next thing is you can also use in the renal risk patient. Renally, if they're impaired, then in those cases also you can use the biparametric MRI. Next thing is the optional thing because it requires an endorectal coil, where most of the centers we are not using the endorectal coil, and also you need a proper, very good expertise technician to do it. You can see these curves which are very nicely seen, but this is not how it will be done. It will have a haphazard curve. It has to be processed properly. So it requires a proper software and also a proper technician to do it. So most of the centers don't do it. That is the reason why in PIRATS version 2.1 they have said that it's an optional thing. It is not mandatory. So just to know the normal prostatic MR spectroscopy. So you see the citrate. This is the normal prostatic parenchyma where the citrate peak is very high. Look at in cancer patients the citrate levels are very low. So look at the choline peak. It's normally it is low, and in cancer patients it will be higher. So you will be looking at the citrate level and the choline peak as well as the choline creat ratio. Coming to the anatomy per se. So anatomy, when I say anatomy, you have to see the T2-weighted images. How do you know it is T2-weighted image? I know that it will be written T2-weighted, but you look at the bladder. So look at the bladder. Bladder is bright or white, so then it is a T2-weighted image. And look at it. This is at the base of the bladder. We have these seminal vesicles on either sides. Okay, so the next section which I've taken is the base of the prostate. So this is the base of the prostate. So can you see this dark structure over here? That is the anterior fibromuscular stroma, which is always dark on T2-weighted images. So this is the transition zone, and here comes the peripheral zone. So can you see some hypointensity? Do you think it's a cancer? So, you're not able to see the cursor? Pointer again. I'm so sorry. Pointer. I don't think they're able to see it. Yeah, I don't think they're able to see. So can you see this particular thing? So do you think it is a cancer? No. I'm at the base of the prostate. This is the central zone which is normally seen in all the patients. This is not the abnormal tissue. It is a central zone. Then coming to the apex. So once we So this is the mid-gland. The mid-gland, this is at the region of the apex. The gland is actually becoming smaller and smaller. So this is the mid-gland where the gland is bigger. It has a bigger chunk of tissue. So coming to the T2-weighted image of the prostate. So when we say peripheral zone, it always should be bright. So it is normal peripheral zone is always bright. So this is the peripheral zone, and this is the transition zone and central zone. See, you see the axial section, central zone and transition zone are almost mixed. You cannot make out very clearly. So for the central zone, I'll show you in my next slide how nicely it will be seen on a coronal section. So, next. So this is the central zone. So you see this is the coronal section. So as I already told you, is the peripheral zone, the periphery. Look at the peripheral zone. This is always bright or white on T2-weighted image. Look at the central zone. This is the central zone. It is like ear, right? It is like an ear shape. So look at this is the transition zone. So the apex of the central zone, it will end at the region of verumentinum. So below that, you will not be able to see the central zone on MRI, axial section, as well as the coronal section. So look at the axial section there. This is the axial sections. You can't actually make out the central zone and transition zone very clearly. So it's better to use the coronar section to look at the central zone. And it is always hypointense on T2-weighted images. So next important thing is the anterior fibromuscular stroma. So this is the anterior fibromuscular stroma. So you see this triangular structure which is seen, and it is well marginated. So this is very well marginated, and look at this, the next image. So the other two images, you see the anterior fibromuscular stroma. So there is something sitting over here, right? Hypointensity, and then here also there is a hypointense ill-defined region. So it should be very well defined like this, and always the stromal structures on T2-weighted image is always dark because it has a fibrous tissue. Any fibrous tissue on T2-weighted image will be darker on all the sequences. Coming to the transition zone, so transition and peripheral zones are actually divided into sectors. So this is at the level of the base of the prostate. So we have 7 sectors, and at the mid gland as well as the apical level, we have 6 sectors. So any lesion, so the radiologist would be reporting it in, if there is a lesion. So any lesion, if there is in the peripheral zone, so you have to report it as whether it is peripheral posteromedial, posterolateral, transition zone anterior, transition zone posterior, and whether it is in the anterior fibromuscular stroma. So you have to mention it in all these sections. So you also see this. So look at the base of the prostate. You have the central there, and in the mid gland you cannot see the central zone. So that is below the level of the verumentanum. You won't be able to see the central zone. And the apical region also, we have only 6 sectors. You can't see the central zone. Then coming to the pathologies, so I'll be I'll be showing few cases of benign prostatic hyperplasia, prostatitis, prostatic abscess, benign ectopic nodule in peripheral zone, and the prostate neoplasm. So any lesion in prostate, we have to score it. So PIRATS 1, 2, 3, 4, 5, whether it is a scar, whether it's benign or malignant, we have to give the score. So what does this mean? So it just tells you, it will give you the likelihood of cancer. It will not tell you whether it's benign or malignant. It will just tell you the chance of malignancy. How much is the percentage chance of malignancy? 1 is 0%, 2 is unlikely, like almost %. Equivocal is around 45 to 50%, and highly likely is more than 80%, 80% and more. So this will tell you the likelihood of cancer in any lesion. So now we are using the PIRATS version 2.1, and based on this, there are few changes which have been made from PIRATS version 2 to 2.1, and they found out that there is higher cancer detection rates in 2.1 version. This is just to know, so when we are taking the peripheral zone, you always look at DWI, don't look at T2. T2, it can be benign or a malignant also, so we don't know whether it's benign or malignant. So we have to look at the DWI, and then to upgrade the lesion, we look at the contrast enhancement. But look at the transition zone, we always look at the T2 weighted image, and then we look at the DWI. We don't consider contrast enhancement in the transition zone because they will always show heterogeneous enhancement. Even the normal parenchyma, normal BPH also shows heterogeneous enhancement. That is the reason why we don't take contrast into consideration here in PIRATS, but it's only in the peripheral zone we take DWI and contrast enhancement. So coming on to the PIRATS 1, so PIRATS 1 normal appearance transition zone, MP-MRI is usually done in older patients, and none of them will have normal transition. So it is a rare thing, normal appearance is a rare one. That is why they found that even typical BPH nodule, they have given a score of 1. So can you see this particular nodule which has very well marginated? But on diffusion weighted imaging, you don't see any brightness. You don't see any brightness here. You don't see any hypointensity here. This is the diffusion weighted image, and this is the ADC. And coming to the peripheral zone PIRATS 1, peripheral zone PIRATS 1, as I already told you, the T2 weighted image will always be bright. And look at the DWI, there is no bright spot. You look at any bright spot, that is abnormal. You don't see any bright spot on DWI, that is the normal scan. And then look at the ADC also. ADC also is not showing any hypointensity or any darkness. Forget about the transition zone, I'm talking about the peripheral zone there. So that is the PIRATS 1. Coming to the PIRATS 2, there is something called, look at this nodule. This is an atypical nodule. See this nodule, so it is not very well marginated. But is it showing diffusion restriction? It is not at all bright on ADC. This is DWI. It is not bright, and there is no hypointensity here. So there is no diffusion restriction, but it is not very well marginated. So, but still you will call it as an atypical nodule. It will come under PIRATS 2, benign one. And coming to the peripheral zone, most of us have come across this band-like structures in the peripheral zone. I think few of the radiologists who are not very well trained, so they will put it across as PIRATS 4 or 3 for this. But this is a normal, this is the wedge-shaped bands which are seen in the peripheral zone, which do not show any diffusion restriction, but just that on the ADC you will have a hypointensity. There is no bright spot on DWI, so this will be still considered as PIRATS 2. This is usually because of the sequelae to prior infection or an inflammation. Coming to the PIRATS 2, we have 2 more things we need to know. That is the prostatitis and then prostatic abscess. This prostatitis is a big headache for even the radiologists because we get confused. If there is a focal involvement, we also get confused whether it is whether it is a malignancy or whether it is a prostatitis. So look at this particular picture. So this is the T2 weighted image. I told you that T2 weighted image, peripheral zone, always it has to be bright. Look at this diffuse hypointensity. Look at it's very dark. So look at the coronal section again, it is very dark. This was a case of prostatitis. So coming to the prostatic abscess, you see the diffusion weighted image. It is so bright. Look at this diffusion weighted image, it is very bright. So there is a bright spot. So do you think it is a cancer? Look at the T2 weighted image also. There is some collection. It is not a hypointensity. Whenever there is any lesion other than an abscess, T2 weighted image will be dark. It will always be dark. And only in case of an abscess where there is a collection within, so it will be brighter on T2 weighted images. So look at the enhancement also. The last image is the enhancement, early enhancement. So on the dynamic contrast imaging, we can see the peripheral enhancement and we don't see any central enhancement. That is the necrotic component. We can also see some tiny micro abscesses which are seen adjacent to it. Then coming to the granulomatous prostatitis, which is the most common one, that is the non-specific granulomatous prostatitis is the most important entity. So it has again 3-4 patterns. So the most importantly, it will be like tumor-like or abscess-like. Abscess-like, which I already showed you. The tumor-like pattern can be like a nodular pattern or a diffuse pattern. Diffuse pattern is again, so this is how it looks like. So diffusely the T2 weighted image will be darker and then it will go on showing the diffusion restriction with enhancement. Then coming to the nodular pattern, it will just mimic a malignancy. Look at this particular image. This case, it was given as Pirates 4. It turned out to be prostatitis on histopathology. So there was a nodular lesion on the left peripheral zone, posterior medial aspect. Then again it showed diffusion restriction with early enhancement. So this was given as Pirates 4. Of course it looks like Pirates 4 on imaging, but histopathology turned out to be malignancy. Coming to the Pirates 3, so we have two things to remember. So Pirates 3 is like, there is a nodule there, but it is partially marginated, but it is showing diffusion restriction. We don't know whether it is CA or not, so we'll put it across as Pirates 3. So it requires a biopsy for this. Then another scenario where the lesion, the nodule in the BPH nodule is very irregular, very hazy, but it is not showing diffusion restriction. In such cases also we will put it across as Pirates 3 and needs a biopsy for further management. Coming to the Pirates 3 peripheral zone, so this was our own case. See this, look at the brightness which is seen according to the, when you compare the background parenchyma, there is brightness more in the right peripheral zone. So there was ADC, we couldn't make out much because a lot of artifacts were coming, and then on DC there was not much of enhancement. We were thinking, clinically there was high suspicion of CA, so they went for a biopsy. This turned out to be a prostatitis. Coming to upgrading from T3 to T4, how do we upgrade? So there is a nodule which is hazy, and that is showing diffusion restriction. Then you will have to consider it to be 4, Pirates 4. If there is no diffusion restriction, it will still remain as 3. Because there is diffusion restriction, it will be upgraded to Pirates 4. Peripheral zone upgrading is very simple. See, this was our own case at Apollo. It was not showing any bright spot. Coming to the ADC, the second image, you can see left peripheral medial aspect, there was some hypointensity. So, and then we looked at whether to give 3 or 2, we were just wondering, looking at this thing, and we also saw the T2 weighted image, peripheral zone, again there was some hypointense band-like structure there, and then we saw the contrast, where we were thinking we'll give it as 3, but look at the contrast, there is bright enhancement. Forget about the enhancement in the transition zone. I'm talking only about the peripheral zone. There's a bright enhancement, bright spot over there in the left posterior medial peripheral zone. So this turned out, this is how we upgrade the lesions. We gave it as 4 and it turned out to be prostatic CA. Then coming to Pirates 4, this you will be knowing. So this is a mass which is sitting over there. It's very easy to find out Pirates 4 and 5. You don't need, in fact, you don't even need an enhancement pattern because a lot of diffusion restriction comes in those two sequences itself. You can make out that it is Pirates 4 lesion. So, but it will be less than 1.5 centimeters and it will not have any extra prostatic extension. Look at the diffusion restriction which is seen in the lower images which I've put it up. And then next thing is the peripheral zone. This is the same thing. So peripheral zone, you can see this particular bright spot there on DWI, and ADC it is low. So there is always a mismatch. One is bright and one is low. And then coming to the T2 weighted image, there will be hypointensity and then look at the contrast enhancement. Look at the right side peripheral zone, it is not at all enhancing. Look at the arrow mark, that is the left side one, peripheral zone, which is enhancing. That is the early dynamic contrast enhancement in the prostate CA, PIRATS 4 lesion. And coming to the PIRATS 5, so the lesion is quite big, going to the anterior fibromuscular stroma and also the transition zone, and it has an extraprostatic extension with diffusion restriction and more than 1.5 centimeters. Give it as PIRATS 5. And peripheral zone again, so this was a huge prostate peripheral zone CA. So with going into the seminal vesicles, look at the lymph nodes. Lymph nodes are also showing diffusion restriction. So this is just 2 words about contrast curves. This, like I told you about semi-quantitative method. Few of the centers are doing it. So what they do is they will calculate the time of peak enhancement. Look at the peak which is seen, the prostate CA, that is the blue line is the peak enhancement which occurs immediately, and then there is a washout. So but then in case of a prostatitis, there is a peak, but it just stay, it doesn't show any washout. Look at the normal prostate, there is a slow raise in the contrast enhancement, but it won't show any washout. So summary, take home points. So for prostate anatomy, it is the T2 weighted image which is very important, and always remember bright. The peripheral zone is the normal peripheral zone on T2 weighted image. It has to be bright. If there is some abnormality, it will be dark. Then peripheral zone PIRATS is always with DWI and contrast, and transition zone PIRATS is always with the T2 and DWI. Don't consider contrast. And then beware of any anterior prostate cancer, especially whenever there is whenever there is a CA near the anterior fibromuscular stroma, a very high chance to miss it. So that is very important. DWI, always look at the higher B values. If you look at lower B values, everything will be bright. So you have to take at the higher B values to look at the bright spot. Then you have to look at the DWI and ADC separately. And then better MR interpretation at high volume centers, because if you see prostate CA and then report it once in a while, it is very easy to miss things. You consider, for everything you start giving PIRATS 3 and PIRATS 4, right? So this is the one, and these are my references. Thank you.
Thank you, Dr. Chaitra, for a very succinct and very, very beautiful presentation. Before I throw it,
show nicely hypoechocardia.
Yes.
But when it is, gleason grade increases, then it starts infiltrating.
Correct.
And then infiltrating ages, they are not seen as a hypoechoic or mixed, and you can't differentiate. Yes. Does it happen similarly? No, the infiltrating ages also show?
No, since all the extraprostatic extension very clearly made out an MRI, so it's more accurate, I can say.
No, that is, I'm not talking about extracapsular pyramid. That is my second question. My first question is, because I am depending on the cancer diagnosis, volume of the cancer, multiplicity of cancer, and the extracapsular spread. On basis of that, I decide the my treatment.
Yeah.
All right?
So the volume what we take here is more accurate. So the ultrasound, if we take the volume, it is more subjective. If I take a volume and if some other takes the volume, there may be a difference. But here it is not so. This is what I see.
So when you have this, and nowadays he is going to talk about the fusion biopsy.
Yeah.
Because the biopsy is not taken by MRI, it is taken by ultrasound.
Correct.
So you got to see that.
Yes.
So do you recommend, what is your lesion? You take center of that lesion a biopsy, which will give you the full length, how much percentage of the biopsy is cancer, and also give you the proper K rate. And you also take a little periphery and take, and see whether that volume is decreasing or it is increasing. Now, in your talk, you are not shown any characteristic of extracapsular spread or a seminal. There are two places it can go. Okay. One is extracapsular and second is seminal vesicle. So how reliable or sensitive it is to do it?
It is reliable, I can say. So, I mean, there is extracapsular, which is very clearly made out. But one thing is that, such big ones, you don't need a targeted biopsies. You can just take a...
No, when you say it is seminal vesicle is involved, what we do, we take a separate biopsy of seminal vesicle, because staging is important.
Yes, staging is important.
In that.
Yes. So, but this is very accurate, that much I can say.
Last question is, no, I mean, like Pirad, which I feel is very sensitive and nice. Similarly, in bladder, the Virad, is it same category?
No, it's not same.
The bladder cancer, so showing the muscle invasion and all.
Yeah, it's a different.
You know, it is giving Virad 1, 2, 3. You know,
yes.
That is
Yes. So
but it is not that sensitive as Virad.
Yes, this is very, very sensitive.
Thank you so much.
Are there any more questions? If there are none, thank you, Dr. Chaitra.
So, next talk is by Dr. T. Manohar, prostate biopsy. How to do it?
Prostate biopsies, and especially so when we are doing the multiparametric MRI fusion prostate biopsies. There is the historical perspective to this since 1922. This is only one slide I'm just going to sum up. The world first biopsy was done actually transperineally way back in 1922. After that, it took about another 15 years for transrectal biopsy to come, and with availability of transrectal ultrasound later, and in 1989, the Hodge et al. Postulated the transrectal ultrasound section biopsy was standardized. So since then, I think it took about almost now 2 decades when MRI started coming to picture, and then biparametric MRI was done, and MP-MRI came into picture, and then both transrectal and transperineal started combining because fusion started happening at that time when the both MRI started coming with the version 2 and version 3, version 1, version 2. And further, I think there is a lot of issue with the antibiotic resistance. I think we have abused the antibiotic like anything the world over, and that has taken the lead. And then again, the transperineal biopsy came into picture, and Barzel et al. So, but still in India, we are doing a lot of transrectal biopsies. With availability of fusion, we started doing the targeted biopsies. So, targeted biopsies, minimal course plus, and you can take the minimal course and then go ahead. Why there is a sudden change? I just told that why there is a sudden change to do a transperineal biopsy. We just moved from transrectal. What is our necessity? There are 3 important reasons. Let us assess one by one. This is a hallmark paper, just like I think you might have heard about Brexit, and Britain exited from the European, and there's an article from British. They named it as Trexit, transrectal exit. In fact, now it started in 2022. They've already succeeded in exiting the transrectal. I think they are not doing at all in the United Kingdom, and it extended into Europe, and possibly now probably another 1 or 2 years, I think in USA also they are going to exit. So why? Post-transrectal biopsy infection is increasing and was recently reported to be alarmingly high at the rate of 10%. And our results are varying from 2 to 27%. So there is definitely infection which is happening. So transrectal biopsy sepsis was also be life-threatening, and its mortality rate is 0.13%. I mean, death is a death. Even if if you done a biopsy 100 patients, even if it's the one death, then it is problematic, even if it is 1,000. So for a biopsy, death is not acceptable. So the death rate and the sepsis rate was the one which made this complete paper is based upon the infection and sepsis. So look at the complications of transperineal versus transrectal. You can see that the transrectal, about nearly 10% of the patient had transrectal bleeding because those are the patients who had hemorrhoids and other things which have been missed out. And the hematuria part of it is more common. Of course, similarly, you have this in 12% and 16% as transperineal versus transrectal, because you may, in transperineal also you may hit the urethra and then bleeding is similar there almost. And in the transrectal route, you have some kind of total number of patients who had a complications or 6% with a fever, present with a fever as compared to the transperineal. So the main concern worldwide is the infection rate following trust biopsy is varying from 1 to 12%. If you look at the recent literature in other unpopularized papers, that's almost up to 27%, with severe sepsis varying from 0.1 to 2%. The sepsis is the one which is bothering, and the development of rapid antibacterial resistance. This is of the major concern. Now we know that there is concern for missing out the cancers earlier. The anterior prostate cancer constitutes about 15 to 20%. And some of the reports, they say, in fact, 27 to 32%. They say that some of the literature reviews say that the anterior prostate cancer, on average, it comes to 15 to 25%. So we can take about 17 to 18% is anterior cancers. And what about, see, that's the cancers here, if you do it, the cancers here transrectally, you would have missed them. So basically, it's the early anterior prostate cancer, and what we have missed is 1/5 of the RP specimens, radical prostate specimens, were anterior prostate cancers. So nearly 1/5 of the patients, 20% of the patients are anterior cancers. I mean, it's a full-blown when you do the prostatectomy. Now here in a situation, we may not be able to pick up this lesion. So this is the second strong region where you might able to not be able to pick up these lesions if you are doing a transrectal biopsies. So comparing the transperineal MR fusion versus transrectal, the only systemic meta-analysis shows that MRI targeted biopsy versus targeted transperineal, analyzing 8 studies, showed higher sensitivity for detection of clinically significant prostate cancer. It's not only cancer, clinically significant cancers. I'm not going to the details. There are various papers that have done it. I've just deleted them because this is very important. We need to know why we are doing it. So the approach is that 86% pickup rate versus 73% as well as TP versus TR. So cancer detection rate, improvement in the cancer detection rate by 13% in transperineal route with MRI targeted biopsies. So these are the 3 classical evidences where the world is moving toward the transperineal biopsies, and also the EU guideline 22 strongly recommends transperineal biopsies over the transrectal biopsy. Now coming to the procedure details, we'll go straight away into the procedure details. So MR fusion or without fusion, or when you do that without fusion or fusion, we have instruments like freehand. This is a transrectal probe, transperineal probe, but this goes to the transrectal. And you have if you do a tracking, because the needle has to be tracked, because freehand means you will be literally hitting the blind spot. So there is a tracker, is the EM tracking, electromagnetic tracking. The needle, you can see the needle going there. And of course, if you want, this is a cognitive kind of thing. And then you have, now recently there is a modification of this, the probe, where the needle can be put. You can fix it onto the ultrasound here, and this probe can go into the area of the biopsy areas. So whereas this is the freehand technique. So in the freehand technique, I'll show you what is the freehand technique. But these are the instruments which are used for the freehand technique. And coming to the stabilized is the patient is, the perineum is fixed, the probe is fixed, or the transrectal probe is fixed, but only thing is you need to go on target. Only the biopsy has been taken. There is no jugularly there inside the prostate. So it requires a stepper device. For that, it requires a stepper device. As usual, different kind of the probe goes into the transrectally. This is the renal area probe. And then through this, there's a grid. This is the stabilizer stepper. This is the ultrasound probe, and this is the stepper. Here, it is called as predictive fusion. You can predict, okay, this is the area, this is the core, and that's why I'm calling it as, it's a predictive fusion. The earlier what I said is cognitive. You see an MRI, okay, and then you see another picture, ultrasound. So you're predicting, you're making assessment that it's a cognitive kind of thing. You memorize yourself and MRI, and then side by side ultrasound, you keep it, and you take a biopsy. Here it is fused, and then you can do a predictive fusion. And transrectal, of course, there is side fire and end fire in the regular. This is fusion biopsies, but since we are concentrating, I'll just concentrate on the transperineal biopsies. So basically, what are the biopsies? How many cores has to be taken? There are various reports depending upon the lesion, whether it is Pirat's 1, Pirat's 2, whether the lesion is 15 millimeter. There are various studies when they have more than 15 millimeter, when they're less than 15 millimeter. But I think the MRI, and also biopsy has been taken anteriorly here. You can see that whereas transsectally it comes from below, transperineally it goes anteriorly. You can take anterior, this is apical, this is the central, this is the basal. So if the prostate is very big, then you have to really put the needle inside and take the basal course. So if the moderate size prostate, you can apex and the basal. You can take the apex and the basal, and you can do the central if the prostate is very huge. So we have a template biopsies, sector biopsies, templateless targeted biopsies, like in the second picture here, targeted biopsies, and then you have a target-only biopsies. So with the MRI, and the madam was, previous speaker was emphasizing upon the how we can do 4 and 5, and I think we are in the era where we can just do a targeted biopsy and do this. So just one more assessment from our radiologists. They said that, for a urologist, T2 weighted images, what is important for a fusion? T2 weighted images, she said that hypoechoic in anterior zone, this is a diffusion weighted image. There's a decrease in the diffusion. There's a white it has become. Diffusion weighted images. And then that's a scar, which is called the restriction of the diffusion, rather. And there's the contrast enhancement, DCE. So these are the three important for assessing the period scoring, because if we get into this and then ultrasound, we can manage it and then assemble it and fuse it. In our mind also, we need to assemble it because we have to see this. Otherwise, it's very difficult to do it. So again, the same thing here, hypoechoic, restriction of the diffusion, contrast enhancement, and this is the functional study. Again here, the same thing. So it is a repetition of that what previously speaker spoken. So we know that it is an anterior lesion, ideal case for doing a transperineal fusion biopsies. Now coming to the after that, so when we do an MRI, MRI has been done, and now we have to fuse it. So there's something called as software, MIM software. So we have to buy the software. This is an MIM software. And after buying the software, you load all the pictures into the software, into the computer. This is just a software in any computer you can put, table. And then started contouring the picture. These are the picture we are studying, ultrasound, the MRI picture. Study the anatomy of the prostate, total. This is the total prostate size contouring is being done. This is all completely software. You can use the color, depending upon the color, you can use the number of lesions, different color can be given to that. This is the contouring of the first contouring of the prostate. And you can erase it, see that it should be little marginally accurate, or you can slightly this one. So the next cut. So different cuts are there. Whatever the 10, 15 cuts, you just go on doing this. The contouring has been done. That's you can see that egg in a cup appearance here. It's a peripheral zone and transitional zone. And this is the second cut which has been done. This is important. Again, so I'm showing the representative films. So that is the hypoechoic area, that is the anterior lesion, that is the lesion. So we have marked it in a different now. The contouring of the lesion has been done second. First contouring of the prostate full size, and then after that contouring of the lesion. So this is a red. This is a one lesion because it is from apex to the base. We are going apex to the base. So sir was asking what is the depth. So this is the depth. In the other picture, here you see that the depth is being assessed. It is coming down. The moment we are keeping it, the lesion. Freehand, you can, if you want to do a freehand, then there's no point in doing multiple punctures. So you can give a local anesthesia straight away here. This is the rectal probe here. You can put a anesthesia into on either side, and one can go and do the probe. So this is the probe where you can. This is the new probe. It is not available. This is the where you can put a needle through that, and then you can do the biopsy. But this is still not available. But after the or you can do with the local anesthesia. If you have a lesion, 3-4 lesion, you can give anesthesia, mark it, 2 or 3 marked lesions, and then you can do the biopsy. This is the mapping anesthesia. This is a locally you have to give all around there. So into the perineal area, market area, you have local anesthesia. But I feel it has become a little cumbersome. The fluid comes there. When you inject in, the air goes in. So the needle lacquer is difficult. But I think this is one of the methods which has been mentioned. And what we do is, this is the actual procedure, the freehand. This is how the freehand has been done. That is the pubic symphysis, that is the inferior pubic ramus. I'm marking the anal superior margin. So that is the prostatic area where we need to go for the prostatic biopsy. If you want to go laterally, you can go laterally. But that is the area of the skin side incision. of injecting the local. 30 cc is required, basically. The Xalocaine or Bupivacaine, you can use it. It's better preferably without adrenaline. This is under local anesthesia, but initially the patient, if the only important problem is that if the patient moves, I think you are trying to do a fusion, the fusion will, it will go away from the contouring. The fusion will not take a problem. So this is a local which is completely given, and then you put the probe and the patient is not feeling anything. And that is the probe. Once you put the probe, then you track. You put a needle there, you tracking the needle there, you have a MRI fuse. That is the depth. That is the depth, whether it is in the basal area or in the apical area. It's almost in the central area. The needle, I'm able to see the needle there, but you have to make little manipulation in free hand. So it's reaching the needle is reaching there. You have gone the apex of the prostate, you're going towards the middle, and from there you are firing. So that is the firing. So this is how the posterior area, if whether the anterior, apical, or a basal course. So you can see that core which has come there. This is a free hand, but you are required to do a multiple adjustment inside the prostate. That's the only difficult part of this. Now, there are local anesthesia, introduction of the ultrasound probe. You can do it like this also because you put a grid. Actually, neurovascular bundles are here at this level. So you have a prostate, you know that your neurovascular bundle, and you deposit 2 to 3 cc with the grid, with the stabilizer. You can use it, and you can go from here, inject it directly into the 2 to 3 cc of lidocaine, 1% around the neurovascular bundle, and 3 to 5 cc deposit, and then all along there you can come back and do that. So this is also can be done. See, this is the needle which is going there into the neurovascular bundle here laterally. You can see both the cross-sectional images, longitudinal image, and then you can deposit the local anesthesia, and then you can proceed with the biopsy. It's a free hand. This is the grid is there. So you can measure the grid wherever the needle is going, then you can put it and do that. Now, last week only we started trying for the pudendal block. This is we started venturing into the pudendal block. Sometimes local anesthesia is very difficult. In this case, ultrasound has been done. Identify where is the ischium, where is the ischial tuberosity, ischial spine. You have to go to the ischial, to hit the ischial tuberosity, come back and get into the ischial spine and deposit. That is a bone which has been seen there. Ischial tuberosity. So initially when I was doing PVP laser, KTP laser prostate, we used to do the under local anesthesia when we started that. So it is not that difficult, but the local anesthesia, this patient, when you were giving in this position, it's a little cumbersome, but we have to explain the patient, counsel them briefly, and then after the ultrasound, identify the ischial tuberosity, hit that, come back, and go medially, you will hit the ischial spine and deposit about 15 to 20 cc of local. So this is ultrasound guided pudendal block. This is very handy for, I think the anesthesia is going to be the way forward for urology. I think there is a lot of advances going to happen, and that in future I think we're going to have this as a main topic in urological conferences. So here the injection has been given, and after identifying, put a finger in the rectum and identify that there's the tuberosity. You identify that where the tuberosity is, make an incision there, hit the tuberosity, come back and go medially and hit the spinous and deposit. And that patient we did completely. And now this instrument is a little complicated, looks also is a stepper, is bigger than the ultrasound machine itself. And this is the stepper which goes in and get fixed into the table area in the lithotomy position. And just get fixed, and there's a lot of multiple attachments because it has to allow for a 6 degree of movements and rotations. And we have to make it neutral. All the movements should be made neutral, because when we are adjusting, it has to be neutral. So all the movements, you can see that XZ, XR, YZ, all has been written there. These are all the movements where you can put the knob and rotate and do it. And then they have a probe covering, so which is a little costlier, and somehow we are used to doing this. If there is, we want a little bit of jelly and the linear area probe and fix that, mount the ultrasound probe. This is the linear array is here. So this mount it on the probe here, fix it, and this is the wire which is coming from here. You can see the wire coming from here, the ultrasound, and that wire of the stepper is synced to the ultrasound. So whatever movements we do, it is transmitted into the ultrasound. The stepper has been synced. So this machine, this stepper has been synced to the ultrasound. Not only the probe, the stepper is also has been synced. And then this jelly goes inside slowly. So you need not have to press. So there should be some space. Slowly go inside. And you can see that the ultrasound evaluation, and then do the movements, and then assess the grid movements, and now fused it. We have fused the MRI with the ultrasound picture, and you can see that there is a contouring of that. And when you are doing the ultrasound, we just have to realign this, go on realigning in a different areas where the lesion is there, so that you are fusing the ultrasound. So this is the image which is almost, see that, this is almost matching that of the ultrasound. This is the MRI image, what we have contoured. It is almost matching that of the probe. This is the basal lesion, this is the peripheral lesion. That's the, and then after that, you have to go for a biopsy. When the alignment has been done, when the contouring has been done, and then fusion has been done, fuse the MRI picture and ultrasound picture has been fused relatively. It's not 100% accurate, but relatively you can do that. And then go to the biopsy. So after that, you will get both longitudinal cross-sectional film. You can see that. So this is the cross-sectional film. This is a sagittal.
Dr. Manohar, you've got 2 minutes more.
Yeah. So this is the target area. And the biopsy has been, you can see the needle. You can target it now. Now it is almost not in the apex, it's not in the base, it's exactly in the mid-zone area here. And this target, we can put the needle there, and I'll show you the, now we know that where exactly the lesion is, that there's a grid is there, 2, and this is, I rotated this probe. So I want to take the biopsy from here. This is a 1.5, and A, small a or what B. So same grid area, you can put your needle there. Same area, put the grid area, and it goes and hits the biopsy. See that the biopsy has been gone there, and you hooked at the capsule, that is the capsule, and hit the lesion there. So this is, in short, total about the transperineal biopsy, and this course will be taken, and these reports will come there. And this is how the report, in the finally, you get, these are the targeted lesions, how it comes, and that is the procedure. And we have done nearly now 720 course, nearly about 60 cases, 70 cases we have done. And then yield is positive, is nearly 56%. Because of the short of the time, I'll just show that this stabilized biopsy you can do even for small lesions. If you have a stabilized biopsy, freehand, I have to use a large lesion, you can do freehand. Whereas stabilized, you can do small lesions. Even with the peripheral lesions, lateral lesions, you can do that. And it's a predictive fusion, and target biopsies are accurate. Right now, it's a general anesthesia as a disadvantage, multiple needle pricks required. But now we are innovating ourselves to get into the pudendal block and other things. And I think there is a lot of scope for the pudendal block started using, and local mapping area as the anesthesia is considered. But retention rate in the initial period is very high, because if you give the spinal anesthesia and perineal hematoma and bleeding, urinary retention is very high with the transperineal as compared to the transectal, but infection rate is nil. So this is the last slide. This is the comparative results. The positivity of the TRUS and MRI. We've done about nearly 2,000 cases, a 47% positivity rate. In a TPMRI, when we did that, it's almost like 72% as against the 47%, which is increased by 25% positivity rate. And when we looked at previous biopsy, this is about one patient we did out of 1 out of 45 patients we did out of 2,000 repeat biopsies. Only 1 was positive, so it's a 2%. When we had 6 patients underwent repeat biopsy, previously was, so 4 out of the 6 were positive, it's about almost 67. So repeat biopsy, previously negative transectal, its positivity is almost 65%. So this is the protocol, and thanks for, so this is how the PIRADS 3 lesion, how to do the target lesion. I do, now if radiologist is good, if you're confident about the radiologist and you know that it's a PIRADS 3 lesion, PIRADS 4 lesion, you can do targeted lesion. PIRADS 4 and 5, target the lesion, take out the biopsy, only target lesion is enough. If you have a period 3, doubtful, even the radiologist is also doubtful, about the 3, then we have to do target plus template biopsies. This is the overall summary, and thanks.
Thank you, Dr. Manohar. Very excellent talk. As a matter of fact, your presentation makes an absolute push that everybody should shift towards transperineal targeted biopsies. Are there any questions from the audience?
Manohar, what is the reason for retention of urine?
Yeah, there's a multiple punctures.
Multiple punctures.
Multiple punctures in the area, and then the urethra is, whereby the prostate is like this. So injury to the periurethral area, especially the peripheral zones, not much. If you are doing the mid-zone area, the retention rate is more, very high. And I think now we are doing only targeted biopsy, then it is reducing. Few of the patients, the anesthesia, they were giving spinal anesthesia, that's a major contributor. General anesthesia patients are little less. So most of them, they were very happy to give spinal. So spinal anesthesia, any perineal surgery, anything, retention, that's one of the reasons, I would rather say.
Question from Dr. Desai.
Sir.
After you started doing fusion biopsy, is the number of biopsies come down?
Biopsies? No.
After, previously we used to take
biopsy
18
course.
biopsy.
Yeah, number of course have come down.
Number of core has come down.
Number of course have come down.
And your positivity, you said 65% increase.
Increase.
That's very good.
At any stage, do you involve radiologist or sonologist here?
Yeah, I involve them while doing
No,
the...
don't look at her, you look at me and answer.
doing the contouring.
Yes.
I mean, just showing the, you just mentioned that. Contouring, MRI contouring, and because they are the experts. Because MRI periods, I can read and I can tell that, but I'm not an expert in my field. Biopsy, I can do it. I've done already the transrectal and transperineal biopsy. Surgically, we can do that, whether if the target is shown. So for MRI reading, we take their help 100%.
So actually it is fusion now.
It's a fusion, yeah, radiology versus urology fusion.
Before we let you go, I have a question. It is directed to you, but also to all the audience, especially the seniors. Nowadays, there is a trend for a transgluteal robot-assisted prostate biopsy trend. And in my recent visit to Command Hospital, Bangalore, I was amazed to see that they have started doing robot-assisted, image-guided transgluteal prostate biopsies. Any comment?
No, because it's in Chandigarh also, they died a few cases with the PSMA PET CT, but I don't have any much experience about the transgluteal. But this, I feel it is easier and...
I think already from transrectal to fusion biopsy, the cost of the biopsy has increased. The transrectal equipment would cost about lakh rupees. Now fusion biopsy, that ultrasound machine itself costs 2.5 lakh. And now plus MRI. But what has happened with fusion biopsy, you have reduced the rate of infection and you have reduced the number of core. So already your biopsy positivity is more. So what, now after you make a positive biopsy, we are going to do a robotic radical prostatectomy. The cost of that is again high. So technology is important to improve your diagnosis, but technology should not be such that patients are discouraged to undergo the surgery because of the cost. Because the surgical cost of robotic surgery may be around 4-5 lakh rupees. Now, our aim is to improve the diagnosis, which is already done. By doing robotic gluteal biopsy, how we are going to increase the...
Apparently, it is more safe and the chances of infection are lesser.
We have done now probably more than 4,000-5,000 biopsies. I'm doing it since 1986 or 87, and I haven't found a single complication which has any mortality. No, that is not. But what is I'm interested? Now he can see MRI and thing, and he saw the small lesion. Now, if the small lesion is detected earlier, this same technology can be used, like next talk is on resume. You can put a needle there, put a vapor and destroy the lesion. So now next, this is the next, after this next step would be a targeted treatment. You know, or an image guided treatment for the prostate cancer once you diagnose it. So what we are at this moment thinking is that are we sufficient? Now here it is done under local. It is, you know, I mean, once you have all the equipment, there is nothing much is needed. But once you start diagnosing and once you have, are you satisfied with the fusion biopsy?
Yes, sir.
So if you are satisfied and the number of take is more, there is no need to, because robotic you put it, you know. So in that case, the urologist is replaced by the robot, or he just manages the. I don't know how.
Not exactly. I think
how it is done. I don't know.
In my case, when I talked about Command Hospital, Bangalore. It has been procured in the Indian Armed Forces. What I understand is they are doing it for lung biopsies, liver biopsies. They have also started doing this as a transgluteal biopsy for the prostate. Now, there is a robot which is fusing the image with a CT image.
No, lungs I understand, because lung is not palpable, but prostate is palpable. You know, with a finger you can palpate, whatever you palpate you can biopsy.
No, but there's literature also to this count, so I just wanted to know what was the opinion.
No, I'm not aware. This is the first time I'm getting, I'll find out.
Dr. Manohar, just one.
Yeah,
Sir, this you said you are getting 45% in a transrectal biopsy and 72% in a transperineal plate. What is the, have you noticed any difference in Gleason score? Are you picking up the low Gleasons or has it been the same?
Yeah, that is the pitfall of the study of MI. It is not a study as such because this has been spread over, transrectal has spread over a period of, from 2007 I am doing it. So 2007, I think MRI, even radiologists were a little confused where the lesion, what is the periods, version 1 was there. So MRI lesion was not ideal. MRI pickup rate was not proper. Now I think with the advent of MP-MRI, we have lost many lesions in MRI. All those things we have done MRI cognitive. It's MRI is done and then we do a transrectal and we do the fusion, biopsies. It's not a fusion. Now I am comparing the transrectal versus fusion targeted. I think the yield is little bit, because it's a technology is improved, everything is different. Coming to the Gleason score, especially the anterior lesion pickup rate is more, and then of course, as such, anterior lesions are prostate evasive anterior tumors, they are very aggressive. Our aim is to find out actually the aggressive tumor in anterior lesions. If I have to do transperineal, ideal indication is the anterior lesion, barring the infection rate. That's the only classical indication for a transperineal biopsy, if you take out the infection rate. When you start fusing it, then you can do only targeted. So only targeted lesion, because MRI has been improved. MRI, we are able to, very good radiologist there, you can watch it's a 3 lesion, it's a 4 lesion, then you are safe. You're going to do only that lesion and come back. That's how the increased rate has been happened.
Thank you, Dr. Manohar.
Thank you.
With this, we come to the end of session 5. Back to organizers. Do we continue with session 6?
Yes, sir. Please continue and moderate the next session as well, sir.
Thank you, sir. We now go to the penultimate session. May I now request Dr. Nandakishore SK to come and make his presentation. Dr. Nandakishore, the podium is yours.
Thank you very much. I am very happy to come over here, and I thank once again Manohar and the organizing committee to give me an opportunity to talk about the newer technology, what has been come into the management of the prostate. So when we are talking about resume, I think the best way to start is, this is the way how it has been spelled, resume. So resume is the thing, what it has been. So in this, the title is current scenario as well as the demonstration of the procedure. I will also add some about my own experience about the procedure, steam therapy, where I work as a specialist urologist. So it's all been mentioned about the evolution of urology. The evolution of urology, doing big open nephrolithotomy and coming back to flexible RIRS for the stone management, or the mini perc or the micro perc, as well as the same thing as the Dr. Manohar's big Moses 2 laser prostate to a minimally invasive steam therapy. So that's the reason what I mentioned, the less is more. So with the less, we will be able to take out, give the patient to void urine. So probably it might not make you to write your name on the sands of the beach with the HOLEP, but this might at least make the patient pass urine very well. So why did I was very interested to start this is a patient of mine who actually is an expat who was in the native, and he was on this medical management. He was not taking medicines on and off, and he was on an intermittent therapy sort of a thing. And he had retention of urine in the airport, and then he stayed there for only for the reason of putting a catheter and doing a trial void. He failed trial void, but because being an expat and he's a laborer, he came back to the country, and when he came to meet me, I did one more trial void for him. After that was almost 10 days. And then he told, no, I would like to do some more weight. So he waited for another 2 weeks. Meanwhile, I had explained about this procedure and I had taken insurance approval. So in UAE, the best thing is the insurance. So it is almost 98% is insurance driven. So not much of a problem for us, but the thing is the approvals, we have to wait for it. So he failed 3 trial voids with a 98 gram prostate. And this was his first uroflow after the 7-day wait period. So this graph, and that after 1 month after the first, or 6 weeks later, that was a uroflow. This gave me the confidence that this procedure has some energy or strength what we can rely upon. So this was the thing what made me to think about doing this for multiple. So in this I mentioned that RAISM 3 plus 3 plus 2, that was 3 for one lobe, 3 for the other lobe, and 2 for the median lobe. So this we have made it as a short form. And this is another patient, 2 years of alpha blockers. He was told, yeah, 2 years of alpha blocker, but I want to change. So this thing, and this was the graph. This was the pre-op uroflow, and that was the post-op uroflow. And another patient, 6 months of medications, but he was not compliant with the medication. And this was the pre-op, and that was the post-op. So this actually told that this system or this therapy works. So it is not that it is a new technique. So this technique FDA has been approved 2015. Now it is 8 years in US, and they have done phenomenal numbers. And this is in UK 2017-18. So once UK, NICE guidelines were given about after doing multiple procedures. In 2020, NICE came with the guidelines with positive recommendations about the cost effectiveness of the procedure, as well as they told you can go ahead and do multiple this thing. More than 8,500 cases are already been performed. This is by I think November 23. They have already performed so many number of patients. So we already have, it has been proven. So when I went into the literature, this is the meta-analysis where they have up to the 80 gram prostate. What had happened, it is 15 studies, 11 retrospective of from 9 different countries. And they found that, and with a follow-up of 3 to 17 months, so they had a good improvement not only in IPSS or quality of life, even with the Qmax. Qmax mean change is 6.5. Like a HOLEP can give you much more than this, but Qmax was 6.5 change and a minimal residual urine and no change in the sexual function. So there was no serious complication about this procedure. This was a thing of the meta-analysis. Once again, this is from November 23 paper. So they concluded that this is statistically significant, clinically important short-term improvement because they did that short this thing. So long-term outcomes, is it only for 80 gram? So the next thing, what has to be done? So I just want to tell what is rhythm. When we talk about rhythm, this is the thing. So what actually happens in resume? This is the way how we put the needle, and we target to the point where we want. That I will be telling you the details where exactly we usually point out and where we puncture. And this has got a very short learning curve, and however in UAE we have to go through a process of getting the certification, and it has to be approved by DOH, and then we are eligible to perform the procedure. So this way, yeah, this is one installation, and we are able to see that amount of So the similar way we are doing it multiple procedures. For the shortage of time, I will not complete with. So how does it actually work? The science behind the reason. So when we are talking about this, this tells that the radio frequency generator, what it does, it works on the water, and it rises the temperature. When the temperature is raised, there is an energy which will be generated from the liquid phase when it gets into the vapor. The vapor has around 540 cals per ml of vapor. But when we inject into the prostate, that phase change happens from the vapor to liquid. So when that happens, this is released into the tissues of the prostate. So when we see this, this is the time. So at 70 degree centigrade, the cell death is immediate and irreversible, and that is with 0.001 seconds. So this is how, so during prostate tissue, once the coagulation happens, then these are enzyme mediated auto. Yeah, this is the infiltration of the vapor. So they have also done while the initial phase of checking what is happening in the MRI as well. This is 1 week post procedure, the prostate. And the other side is already 3 months post procedure. It's already shrunken. I think, hope everyone is able to appreciate in the MRI. And this is the picture after 6 months. So when we see that median lobe, I think Dr. Manohar would have seen this yesterday, the median lobe, what was looking like this, which we did it for with the pudendal block. So this is the prostate after 6 months. So what is the key factor about rhythm is it's a unique heat source, water vapor energy, and the heat transfer is by convection. Steam will not cross beyond. So what about the medications? So can we compare with medications and the rhythm? Yes. So we all know medications. I think Dr. Altaf was mentioning about all the complications of the medications. So not only that, because of that, the drug adherence thing with medications is only around to 65 to 91% of the patients can stop by 1 year of usage of the medicines. So as he has already mentioned about the alpha blocker side effects, and all of us know, and the side effects related to, and once again this brings about a lot of sexual dysfunction, and patient doesn't want sexual dysfunction. So they did one more study on this. They compared these people, the MTOP study people, participants were cohorts of MTOP study who were taking medicines on doxycycline, finasteride or both, and they compared with the randomized control trial with rhythm system. They compared the outcomes, and they found out that thermal therapy resulted in improvement of symptom scores at least 50% more than the medications, and symptom improvement in thermal therapy was greater than a single drug or a combination drug as well. And the peak flow rate also were better even at 2 years or 1 year with the combination, and the clinical progression is 5 times lower. Clinical progression and making them worse is 5 times lower as Qmax and VPH, much better than any of these single or combination medications. So where we stand actually in the treatment, I am not going to tell that rhythm is going to replace OLEP, not going to tell any of the invasive. They have got definite role, but rhythm stands when we want to compare with BPH medications. If somebody comes and tells, I don't want BPH medication, this is the best thing. If somebody tells, I don't want to take a long standing, if you tell the patient, If you want to take for 5 years, 6 years medicine, no, I don't want. One shot therapy, RESM is the best therapy. So RESM stands at this level. So coming on to the device, how does the device look? This is the generator, RF generator, and we are going to put the steam. There is a syringe here, the sterile water is put into that, and there is generation, and that is a delivery system. The generator is a one-time buy. The delivery system will be disposable, and it will be bought every time, once for every patient. And that is the steam what we are showing you. So we will talk about the technique. So first is the cystoscopy and the assessment of the urethra. So basically what the distance between the verumontanum and the bladder neck is the important thing what we usually look at. So what they mentioned, less than 2 centimeter, you can do a treatment of 1 to 2 per lobe, or if it is 3 centimeter on 3, and more than 3, it is more than 3 or 4, you can give. So the primary determining factor is the distance. So in this, there is something called field of view. They have made themselves so that you will be able to assess the field of. This is the device tip, and this is the imaginary line connecting the two. So this is 0.5 centimeters. So we want the injections at least 1 centimeter behind the bladder neck, and also 1 centimeter away or further from the verumontanum. So that is the reason they have made it themselves, and when we are going to the training, this is what they will show us, how it is measured. So you measure the field of view, and then you measure like 1 to 2 centimeter or 2 to 3 centimeter, and decide how many injections you want to give. So when we are doing the treatment, what we do, we position the treatment and rotate the device, and then 1 centimeter behind the bladder neck, stabilize the device, and or target the bulk of the adenoma. Some are very bulky, so we can direct it to that. And this is at 3 o'clock and 9 o'clock. Then activate the button, and the button will be pressed for 9 seconds, and leave the needle there for 2 seconds like cooling, and then retract the needle. And then you once again come back from that particular place 1 centimeter more. So you don't give within 1 centimeter. Make a duration, because that will, one study says it reduces the prostate by 13.2 grams, one injection of the prostate. This I already mentioned. See, 1 centimeter from the bladder neck. See, why I want to tell at 1 centimeter, because the more near to the bladder neck, patients will have more dysuria. So the bladder mucosa get inflamed, they are having a lot of dysuria, and the dysuria will continue. The more you protect the urethral lumen, more the patient will have less side effects. More you do a superficial punctures, not going deeply inside, they will all come out with dysuria, and the dysuria can go for long.
You have 5 more minutes.
And then this is proximal to the verumontanum is basically because to prevent any injury to the ejaculatory ducts. That's the thing what median lobe. So when there is a median lobe, depends on the size, we usually give less than 2 centimeter one treatment, more than 2 centimeter, more than one treatment, and we deploy the syringes in 45-degree angle. This high central lobe, this is one of the reasons why we can have failure. If at all this is not well treated, this is like a ball valve, median lobe. This ball valve might not get very well easily regressed. This we have to carefully tackle, and this has to regress, and this has to be properly injected. So the best practice is 1 centimeter from the bladder neck. Treatment should be 1 centimeter apart, parallel to the natural slope of the urethra. Check the veru prior to the treatment. Every treatment we usually come to the veru and see where we are, and then start doing it. And if there is a steep prostate, you can also start reverse injecting, and don't keep on moving too much, so that we will start bleeding. And these are the pain medications which can be given. If it goes well, you can injure the urethra. The first instillation is very much important. I just want to. This I already shown how to inject. Second. this is the bladder neck. So I am trying to do in that video the field of vision in the next thing. This is a cystoscopy. So here the field 1. So when we come down, this is the point when we will take field of vision 2, and then come down field of vision of 3, and then we come to this point and measure the field of vision. So something like 3 to 4. So when we measure that and then we redirect ourselves. And this is how we puncture and just inject. So it is not a, it's not a big rocket science or something. Any person can do, and this has been promoted to do it in an OPD, and probably future there might be flexible scopes to do it. So I think one can do by themselves by seeing that. Their own urologist doing themselves. Can be a possibility here because it's a small procedure. If anyone can do a catheterization, if I put a flexible and you are able to watch, some hero can do it. So RASM is a minimally invasive treatment. Steam injection of the prostate brings the shrinkage of the prostate to improve the size of the lumen. It is done as a day case surgery, and we have already known there are very less side effects and a good response. More than 5 years now having a good beneficial effect. They tolerate the procedure well. Sedation and local anesthesia, as I already mentioned yesterday, we did it in a pudendal block. It was a wonderful demonstration of the pudendal block as well as we did it. And low side effects and low incontinence rates, sexual side effects. So following the procedure, there is people who are doing in the clinic and they are asking the patient to go pass urine and come back. If a patient passes urine, then there is no need to put a catheter at all. If at all he doesn't put a catheter, he doesn't pass urine, then the possibility, or he can also be trained self-catheterization. As long as you regularly do the urine, till that time you can do self-catheterization at home. That is also a possibility. And some of the people who have also done with warfarin, I don't know, I am not very happy with that. So because we had one patient, one of my colleague had done it. He had anemia following persistent bleeding, and the bleeding stopped after 4 weeks. So he was having bleeding with clots. So I don't advise, PSA can go down, avoided at the first go. And there are some like neurogenic bladder, the case selection was somebody doesn't want to undergo any procedure. They were seriously sick, like this fellow was bedridden. He did not want to remove the catheter. Even he passed it the 7th, but he wanted the catheter back. So that's what, and we did one median lobe dissection for one of those ball valve prostates. So I had to do it after 3 months. So he had a catheter for 3 months. And the another 2 patients, they were very unhappy about the procedure. They underwent URP after 10 months. One underwent a green light laser after 3 months. So the carry-home message for Resume is it's a fast, effective and precise BPH treatment. It ablates the target tissue which is then reabsorbed, treats the enlarged central zones as well as the median lobe. Clinically proven safe and effective. It reduces the risk of bleeding compared to the TURP or HOLEP. Preserves sexual function, reduces chance of incontinence, rapid return to normal activities. So I was happy to speak with the Boston Scientific guys over here. They were telling about, I just wanted to mention about the cost. The cost will come up to, as they told me, it's around 90 lakhs for the generator, and this thing will be around 2 lakhs. Around 2 lakhs for the delivery system for one single patient. So the cost initially might be more, probably over a period of time doing it on a regularly on a multiple patients, probably it will be very beneficial and the cost might come down, as it was for every other newer innovations or inventions which happened in our past. They all were expensive. Even laparoscopy was very expensive to begin with, and then gradually everything has settled. So probably this will also follow the same nature, and I think this thing is going to stay, because we don't have anything as a foreign body inside the urethra, and the retreatment rates are very low and sexual side effects are less. I think this technology is going to stay. Thank you very much.
Thank you, Nandakishore. It looks very promising. Here, Nandakishore.
Yes, sir.
Yeah, I got a couple of questions. One is it has depth of penetration? Is it fixed or you can control it?
No, depth of penetration is fixed. It's only this thing. It comes into a particular size.
That is the reason they have restricted the grams of the prostate. But even if it is 25 grams, we have done one for 23, 24 gram prostate, who had a very good bulge inside. Not much outside probably, it was a bulge inside. That patient voided well with 2 injections on either side.
Second thing you mentioned catheter, indwelling catheter for 1 day to the 3 months. How do you decide about that?
First trial void is after 7 days. So if he is not voiding, is very unhappy or having very high residue, then we will actually counsel the patient. There is little bit of inflammation still sitting there in the prostate, which is not, the edema is not settling. So try holding the catheter for 1 more week. Like that 1 more week will go up, and then that's the reason. This guy who kept it for 3 months, he wanted to marry 3rd time, and he wanted a baby from the thigh. When I told the other procedures, he told he did not want. So waited all the way for 3 months. Even at 3 months, he was not able to pass. Then I gave repeat resume and I resected the median lobe. Then he has ejaculation as well as he is able to pass a good urinary flow.
Okay. Sir.
Can I come on the stage? I will have my take on this. So I bought the first machine in India and I did the first resume case, and the young 45-year-old male, his flow rate was 8. We had given him medication, nothing happened. So I advised him bladder neck incision, and I told him about retrograde ejaculation, and then he said, I want resume. So we did resume about 3 weeks ago, first time, and after catheter removal, flow rate improved from 8 to 12. Not much, but the patient is better. Now, I'm a urethra surgeon. I'm talking to endourologist.
Yeah.
How many of you know what is Madigan prostatectomy? Everybody's quiet. One guy. Sir, go ahead. Madigan? No. So I'm talking about Madigan prostatectomy. Madigan was a urologist in Romford, in England.
Medical is...
And in 1970, he published a paper. You have to imagine now, this is called urethra preserving prostatectomy. This is for you. So you have to imagine that you are doing a Millin's prostatectomy. You have made an incision on the capsule, transverse incision. You pass a dilator inside. You remove the prostate lobe, each lobe, and the urethra is intact. Just imagine, urethra is intact. It's possible, okay? Urethra is intact. So what happens? Will there be hematuria? No. Do you have to close the prostatic capsule? No. Bladder neck stenosis, stricture, transverse incision, and with harmonics in the ureter. In the prostatic urethra, we have a stone, okay? In the wall, in the ureter, we could have the stricture. Here we have bladder neck stenosis and prostatomembranous stricture. In ureter, we have RPF, retroperitoneal fibrosis. Do you open the ureter? No. In prostate, we have urethra surrounded by prostate. So as a urethra surgeon, I'm telling you, you have no right to destroy patient's urethra, okay? So my friend wants to invent a new operation. First principle is, if you are going to destroy urethra, forget about it. You understand? This is my thinking. You are hearing for the first time. This is not published anywhere. This is my thinking. So, resume was invented by called Michael Hohe in Minnesota. He sold the company for this product for $400 million.
Next
then
era.
Eurolift, 10 people sat together once a week, half urologists and half technicians or engineers. 1 year later, they have Eurolift. They sold the company for $1 billion, 8,000 crore. A new disease, new equipment, it does not, you understand? So we have to sit together and invent. Now, my take about this resume is very interesting. If I inject resume into the BPH zone, it does not go to the peripheral zone, okay? So what I'm requesting, suppose you understand? It's very interesting the way the water vapor goes inside. And after procedure, if you do transrectal ultrasound, the whole architecture of the prostate is completely destroyed. So, resume. This was fantastic talk by Nand Kishore. He had done many cases. So I was there when Dean Elterman from Toronto is a world expert on different types of minimally invasive treatments for BPH, installed a machine in Jeddah a few years ago. I was there. So I knew exactly what is going to happen. He's coming to UCCon in Patna. He's going to conduct a workshop in Bangalore also. He will travel around the country. He will teach us how to do this. It is very easy for us to do this. I'm not saying this is the answer for everything. My next question is, everybody knows hundreds of urologists. How many urologists have undergone TURP?
Enough number would have undergone.
Many urologists. One. So, how many urologists have undergone PCNL? Are we free of stones? Our prostate stones enlarge.
Is the best slide because we knew about resume, but last slide is the best because that is learning. Because what has happened, he is learning from his shortcoming of this procedure, the 2 median lobe he has they resect and things like that, and that will teach him what to be done. Only thing is he is going to succeed. Resume is going to succeed because this is not first time this idea has been used. As I said, the tuna was the first one. In 1999, in 2000, tuna came first time where you used to put a needle into the prostate and use a radio frequency. And I used to do under the ultrasound guidance, the needle. And then it worked. We did about more than 130-40 cases. And it worked. And only thing is, again, finance. Probably that time, that fellow did not find somebody who could pay him $1 billion. So that thing it collapsed. So that thing was withdrawn, though it was successful. Second one came as an intraprostatic injection of ethanol. And Gopal Badla, now the ultrasound is improving. I have just seen the micro ultrasound. Normal probe you get is 3, 5 and 7. Now this is 27. And I did a trial on that and I was tremendously impressed because peripheral zone, which is so small, can be enlarged up to 20. And if there is a hypoechoic area, you can always take a biopsy. And if it's there, you can put a needle and put a resume and destroy that area so that early cancer can be treated with a targeted therapy. So it can be, so I think technology changes the life, changes the way of treatment. It changes the life also. And I think I'm a true believer. And I see they have learned ultrasound when they were student, but now they see how they are utilizing it with the innovative ideas, which I must congratulate you, both of you, for your excellent presentation. I'm very proud of it. Thank you.
Thank you, sir.
Thank you, sir.
That's already late. We are ending. Thank you, Nand Kishore.
Yeah, thank you very much.
With this, we come to the end of session 6. We, the chairpersons, thank KUA and the organizers for giving us an opportunity to chair this session. And thank you, Dr. Nandakishore.
Thank you very much.
Thank you, sir. I request chairpersons to kindly stay back and I invite the speakers. I invite Dr. Amar to kindly felicitate speakers and chairperson. Thank you, sir. Dr. Chaitra, ma'am, please.
Ma'am,
Kishore.
Thank you, boss. Thank you. Thank you.
Before we go on to our last session, which will be a panel discussion, I have a couple of announcements to make. First is after this panel discussion, it will be followed with a dinner and a fellowship. I request all delegates and faculty to kindly stay back and so we all can have a good time with dinner and fellowship. Second thing is there is a stall of Toyota being put up in front of the main entrance. There are a few interesting cars on display and they have a good exciting offer for the delegates and faculty. Please drop in and you can check those cars as well. So let's go ahead with final session of the day. It's a panel discussion on various case scenarios led by our moderator, Dr. Manish Sinha sir. Sir, kindly take over the stage. And I would like to request our panelist, Mahesh Desai sir, Dr. Sanjay Kulkarni, sir.
Thank you, sir. Thank you.
Dr. Sanjay Kulkarni sir, can you kindly join us for the panel discussion sir? I request Dr. Rohit Joshi to kindly join us as a panel member for discussion.
Marriott, Gujarat, we are all from the same place.
Dr. Atkal, can you please come over as the chairperson? As the moderator.
Again, formal thank you to KUA for allowing me to do this, and a very special thank you to Manohar, because at least some of these gentlemen would have been my anyway, the cases are all clinical. So I will quickly, some of these points have been discussed, and we do have time. We have only 2 cases and a short video in between. So I would request especially the residents to interact and ask questions. The panelists will be happy to answer. So this first case is a 48-year-old. I put the diagnosis because the diagnosis is not an issue in this case. I'm going to talk about management. He had undergone a URS recently, and following that he went into acute acute retention. He was catheterized and started on ofloxacin. He reported the next day to us with severe urethral bleeding, no fever. There was a tender prostate with no bogginess. So my first question is, I'll continue. Total counts were elevated. His renal function was borderline. He was not a diabetic, but his sugars were elevated, and we diagnosed him as a diabetic. Abdominal ultrasound reported no hydronephrosis, and we are not as convincing as you, sir, so he refused a truss. And we managed him on clinical grounds. We placed as acute prostatitis. We removed the urethral foley and started him on broad spectrum antibiotics. So till this point, would anybody have any disagreements?
Well, whenever you do a ureteroscopy and there is a flow going into the kidney, and he is a diabetic. Now, he was not diagnosed before, but his sugar is 182.
Yes, sir.
So probably it was
we have diagnosed him as diabetic now, after this presentation. Yes.
But he should have been diagnosed before the surgery.
Yes, sir. Yes, sir.
And then when you do the ureteroscopy, there is the irrigation going on. And then that irrigation, when you break the stone, the fragment goes up, and then there is an increase in intrarenal pressure. And there is a intravasation of fluid into the kidney. and the kidney function come down. If there is an infection, it will go into the kidney. And now you see his creatinine is gone to 1.5. So there must be infection because of diabetes obstruction. There must be infection. Now this infection is flared up. He's passing, instrumentation is done. He's got a catheter, and that must have, and plus he had a bleeding. Now that bleeding, was it from the kidney or was it from injury? Because when you have a prostate, and if you do ureteroscopy, and if ureteroscopy need a dilatation, as he says, the urethra, you are trespassing so many times, because you have to dilate up to 12 or 14 before you pass. That time rigid ureteroscope was used probably, or flexible?
Semi-rigid.
Huh?
Semi-rigid.
So must be 9 French or thing. So when you pass that, so many times it's gone. So if there is an infection, did he have a phimosis? Because since if with diabetes, there is a chance that he may have a little
no phimosis.
Phimosis. So if somehow he got an infection, and that probably. But why did he have a bleeding? So bleeding shows.
No bleeding, sir.
Huh?
No bleeding.
No, you said in the first one. No? Go to first.
Did I?
Severe urethral burning. Oh, you said burning.
Burning. So he came to us with severe burning, sir.
Burning. So that must be. So there must be inflammation around the trigone and the prostate. That's why he has a burning of the micturition. So probably some trauma and infection superadded, diabetic. So he must have developed an inflammation.
Yes.
And then
I'm going to, so in the same line, I'm going to ask a rather provocative question as to how many of us believe that Sidex sterilization is inadequate, at least the way it is practiced without bioindicators, without adequate timers being in place. How many of us would believe that Sidex should be given up from the audience, if any hands can be? Oh, very good. Thank you, sir. Yes, sir.
I tell you, we
Yes,
have
sir.
given up Sidex from 1985. No, not
Okay.
so 2005. And at that time, we used the plasma sterilizer.
Yes, sir.
Because we have many stone cases, and same instrument, can be put to Sidex and used to use, and we used to get the infection. Actually, in one patient, we got a Pseudomonas infection. So we took out the instrument from the Sidex, and then we flush it, and that we culture it, it came out Pseudomonas.
Yes. Yes.
Can I say something about, like Dr. Mahedesa suggested, I did a ureteroscopy on an anesthetist, a friend of mine. He had a tiny means about 8-9 millimeter stone in the lower ureter. I did ureteroscopy, and 2 days later he had slight fever and his creatinine jumped. So the son is a cardiologist, asked me what happened. I said he had bacteremia, septicemia, creatinine jumped. I bought steroid next day. I said this is not acceptable. And last 10 or 12 years we have a steroid for all instruments. Most important, what's the concept? Anything that kills anything is bad for you. So Sidex should not be kept in the theater because the fumes are bad for you. Sidex should be abandoned. All right. And then my wife is a laparoscopic surgeon. So long time ago we had Mycobacterium chilona infection. All ports were infected, and we had to give treatment to the patient. So Sidex is out. Full stop.
Thank you, sir.
Like to beg to differ, Manish. I'm sorry. I'm from a private practice kind of thing. We do 10-12 cases a day. We cannot get away without this disinfectants. These are not sterilizing solution.
Yes,
we might get away without Sidex. We are using peracetic acid. We are using now Corsolex Plus. There are timers available. So let's be rational. Let's not be radical. It's not possible for all of us to just throw away our rapid disinfectant materials, because we cannot have steroid and ETO. I'm sorry to
No,
differ you, sir.
Paracef is okay.
Yeah, sir. So that's what I'm telling you. The message should go like, you can get away without Sidex, but there are better solutions available, and there are solutions which are having a kind of bioindicators. So use it rationally. Let's not be radical.
Yes. So I will stick to a problem with Sidex, since we don't use it. I have never used Paracef either. But with Sidex, the problem is your instrument is going in and out. Every time it is getting diluted beyond 0.5%, it doesn't work. And then you have put in one instrument, you go 15 days later, 15 minutes later, but you have 3 OTs. Somebody else has already dipped in something in that time. And unless there is adequate coordination, which may not be possible in large departments, there is a danger. That is all I wanted to point out, and I'm happy you brought out the controversy. Dr. Atkal, can I ask you the next question, sir?
Yes.
So,
Can you go back?
Sorry, sir. Sorry.
You said refuse trust.
Yes, sir.
Now, let me, his habit I've got.
Ah, yes, sir.
So,
Refuse trust.
what I do, because I have ultrasound in every consulting room, and what I do is, okay, patient, I do the ultrasound of the kidney and the bladder, and then I say, okay, I'm going to examine your prostate with my finger, and then you just lie back. I'm putting a jelly, Xylocaine, and then it will give you anesthesia. I put the Xylocaine and put lots of Xylocaine. I examine the prostate. I never show him the probe. never I show him the probe. Yeah, I just kidney. He has seen the ultrasound. He has felt the kidney. Then I show him, look at your kidney, because that time he's fine. I said, look at this kidney, normal. There is a stone there. Whatever it is, I tell them. And then when I put him, he's looking other side. I'm on the back side. And then I put a finger, put a lot of jelly, and then let me feel it. And then I discuss with my students there. See, this is how you feel. If it is soft, it is soft. Then firm, this is like this. And this is hard, this is hard. And then you have to make sure you also do PSA. I go on talking to them. That fellow is comfortably sitting. I'm putting the jelly, and then I took out the jelly. I say, open your mouth and slowly take a breath, and I put a rectal. I never. And the second thing. Whatever ultrasound done in the consulting room is not charged. That comes into the consulting fee only, and there is not extra. So that is fine, because this is a part of my examination. So what I felt, I'm going to see it. So here is absolutely important, because he's got a symptoms: burning, micturition, he had instrumentation, fever. You have to check the kidney and make sure. Now what happens if you have done a ureteroscopy and if you have got intravasation of the kidney? Well, when you look at the kidney, the fat around the kidney gives you the idea that is outside the capsule. But when there is an intravasation, there is a fluid also seeping out, and then may go from around the what you call hilar fat, and then go around it. So when you do the sonography, the kidney outside, it looks hypoechoic. Or any time you see a hypoechoic cortex and hypoechoic fat outside, you understand this has got an inflammation. Whether it is a fluid inflammation or infection, might happen later on. So ultrasound is, plus there will be tenderness. So here, if you have done a ureteroscopy, and we always check the kidney, whether there is a dilatation, whether there is a thing. But after that, stent was kept?
Stent was removed the day, stent was removed before the retention happened itself.
Stent was removed.
Yes.
Otherwise, you got to check the dilatation of the kidney. So when you do the trust on a clinical examination, always because not doing a trust, because he will be thinking, oh, I got so much, now I'm staying in the hospital for so many days, my bill is going to be more, and now they are going to do the examination, and still they're going to charge me more, and they say, please give me medicine and I'll be all right. So use the psychology of the patient, because you want him to get better. Then money is not a question. Question is, he should get better. So then put it and then do the transplant.
But Manish, let me ask you one thing from my side. Since you have written it as a prostatic abscess, everybody is focused on trus and prostate. But how many of us, wherein patient was undergone URS and stent removal and came back with fever or retention, how many of us will think about prostatic abscess? We will think more about something happening to the kidneys, some perinephric collection and all that.
The pointer here was a normal, two things. One was a definitely tender prostate.
Correct.
And the second was no flank tenderness and a normal kidney on ultrasound.
Otherwise, with the fever, I would rather go ahead and do a CT scan to look at the perinephric collection.
I would now ask another question. This is from my clinical practice. I believe that a diabetic presenting with acute retention and fever is a prostatic abscess unless proven otherwise. Dr. Ratkal, can I have your opinion on that?
Yeah, I agree with that.
So I would insist on a trust rather than...
Newly detected diabetics, and definitely that is the cause for his prostatitis.
Okay.
I don't think anything to do with the URS, this procedure.
Okay. So now, sir, you can continue.
Before that, there is the inflammation. Now, inflammation, prostate may have a cyst, calcification, and in that, the infection will go into that cyst around the calcification between the transitional zone and peripheral zone and start acting up. And there are multiple areas of inflammation. Slowly, it is destroying the cell, and that liquefaction will become a pus or infected fluid, and then that will start spreading, and then end result would be because prostate, your normal antibiotic does not penetrate. If there is an inflammation and edema, your antibiotic is not going to penetrate. So, and what are the drugs which can penetrate? Doxycycline, erythromycin and Bactrim. That is the 3 drugs which can penetrate. Remaining all the other drugs, they protect the surrounding tissue.
Fluoroquinolones? Fluoroquinolones? Ciprofloxacin?
Ciprofloxacin doesn't, it is down the line. Okay. My thing is is the doxycycline, which works better. And usually doxycycline also sensitive because it is not used much, So for a chronic prostate, if you see, if done by the cell, but when cell wall get destroyed, that PSA get liberated, and then it comes into the fluid. So the infection is one of the cause of the thing. But why it happens? Because there is destruction of cell. So this is an ongoing process. It is aggravated. Aggravating factors would be diabetes. Then second would be a organism which is more virulent, and then the antibiotic which is not very effective, or there are some predisposing factor in the prostate which is a large size, or there is a cyst, because a large prostate has more cellular, but a small prostate is fibrous. And then there is a calcification between the peripheral zone and the central zone. It is very common. Yes. And that becomes a nidus, and once that gets infected, then what happens sometimes, when they get infected, there is a membrane occurs on that. And membrane has a bacteria, and the antibiotic does not penetrate the membrane. So you got to drain that, and then otherwise.
I ask one question to
this
sir.
is ongoing process. The speed with which this happens depends upon so many variables.
Yes. Sir, I ask you one question, sir, to you, sir. Once we suspect inflammatory pathology, should you do PSA or not, sir, in these cases? Because most of the times it gets...
You can do PSA because it will say very high. But once your infection is controlled, you do PSA, it will come down. So you know it is going down.
And another question is, my favorite is amikacin. This only thing in this case,
works.
1.5 is the creatinine value. But once you start within a day, that 1.5, even with 1.5, we can give amikacin.
What I will do with 1.5 is I will start a drip, make him more fluid, and let him pass more urine. I'll observe him, and then give amikacin, and then local. 2 drug regime you can give. You can give anti-inflammatory also. That will.
So with our suprapubic catheter and cefporazone sulbactam, on 3 days later, first 2 days he showed very good clinical improvement, and on the 3rd day he complained of perineal pain, which we were not sure whether it is due to the SPC causing irritation or it is actual pain. But rather than ignore it, we decided, Rohit, you wanted a CT, so finally we did a CT. But my question to Rohit, does this look like a prostate abscess to you? We could only do a non-contrast CT. Creatinine was just recently recovering, and I report to my medical director, who's a nephrologist, so I can't do a contrast CT here. I don't have access directly to an MRI, I have to refer elsewhere, so we did a non-contrast CT.
So what is the hypoechoic area?
Yes, so we saw a hypoechoic area. We could not comment anything more than that on the CT scan. And on that ground, we decided to treat this patient. To treat this patient further. Now, the options would have been all this, sir. So you have made your preference very clear, sir.
No, hypoechoic urea in a hypoechoic. So
Yes.
actually the fluid which is still clear.
Yes,
And
sir.
it may be in peripheral zone or a BPH and this area, either this may be end result of the infection or it may be present beforehand.
Prior.
You
Just
don't know.
earlier, any
if there was a
hypoechoic.
pus there, it would have been hyperechoic.
Yes.
Not hypoechoic. Because hypoechoic means there is a fluid and your ultrasound waves passing through it. So
hypodense
ultrasound
here, sir.
wave
On the
passing
CT,
is not
hypodense here.
reflected.
Hypodense on the CT.
It was on a CT scan.
See, if you see that, you see the margin.
Yes, sir.
You can imagine. You have to concentrate that, on that hypoechoic area. How do you get hypoechoic or hyperechoic or a normal? Normal, so ultrasound comes, or this is CT scan, but suppose you do, there is a layers which is reflected back and you get an image.
Yes, yes.
Now here, the image, the waves passes through and then it is reflected outside. So in this area, the thing comes out. So that's why that is a hypoechoic area,
Agreed, yes,
in
sir.
CT, I would not be able to speak unless that our lady will be able to see. But in ultrasound, what I know is the reflection.
Okay.
That's why suppose if you do kidney and you see a hydronephrosis, and is it clear? Why do you see a hydronephrosis? Because it is a fluid collection and then the ultrasound waves passes through it and is reflected from the other side. The other side will be more brighter if you do that because it's the reflection is there. So clear fluid means either it may be there, it may be slightly infected, but that size does not look like something
Typical
which
abscess.
will go and give lots of pain.
Manish, see the kind of significant perineal pain which the patient has, I would rather go ahead and do a transrectal ultrasound and look at whether there is a liquefaction happened or not, whether that area looks inflamed or not, and probably we need to correlate his symptoms with this particular finding. And I think TRUS is the most sensitive way, at least in our practice, that we can do it ourselves and see. And if there is no liquefaction, we can still go ahead and treat him without any intervention. If there is an evidence of liquefaction, even 1 ml of pus you drain, there will be significant improvement in his clinical scenario.
Now if you see, this is a clear-cut hypoechoic area. But if you see here, can you see that little, compared to the surrounding tissue,
Irregularity.
so there may be a little focus there.
Yes.
So initially,
Antibiotics and just wait.
Okay. So now, here the point is, the patient has shown clinical recovery for 2 days, and on the 3rd day, he has perineal pain requiring analgesia, injectable analgesia. So now, our conservative management is not working. So of these, we decided to go ahead with transurethral drainage. And while that was our decision, I will come to the actual picture later. Now, suppose we do a truss-guided drainage or a perineal drainage of these abscesses. I have 2 questions. Would you place an SPC? If yes, for how long? And is there any role for, especially if I'm putting a perineal needle, is there any role of putting in a drain and leaving it behind? Say a feeding tube into the abscess cavity.
well, in an extreme situation where there is a very large abscess and thing like that, and then the principle of surgery is such a large place, it is not going to collapse easily. In that case, you can perineally you can puncture and put a small drain which will done it. It has been, this one case was shown by Professor Stemi, where he had drained. See, ultrasound become popular with urologists after 1984-85, and then we had one conference on transrectal ultrasonography in 1987 in Germany. And at that time, Stemi was the chief. Stemi is the one who invented the PSA. So that time he has shown which is coming perineally.
So
but
when you,
so far in my practice for last 40 years,
we have put it in, sir. We have put it in.
Already
After that, he's worsened.
So it's all right.
Okay. Okay.
So I mean, at surgical point of view, if you leave that, then this is a good way because you are bypassing. Otherwise, that infection comes into urethra, he gets a urethritis, then he might be forming the stricture.
Yes.
As Sanjay said, you must respect the urethra.
The clarity is, Manish, whenever there is an abscess, even a suspicion of abscess, SPC is desirable.
Needed.
And we wait for at least 2 to 3 weeks until we have a trust confirmation of resolution of that abscess. No second thought.
I was told I'll have very little time, so I didn't put the full video here. I have just put an image here. But this is very obviously an abscess. Actually, we did not find any single abscess. The on the CT, it appeared to be anterior. There was no abscess anteriorly. The tissue appeared normal. The infected tissue was towards the veru and the apex. So my next question is, this is especially for the residents, if we are doing a transurethral drainage, all these questions, would you do a complete TUR drainage or would you drain only one large abscess? Assuming the patient is stable and fit, of course.
I just make a nick at the apex of the prostate.
Okay.
And most of the time I drain the pus. That is more than sufficient. No need to do any formal TRP, and they do very well.
Okay. Where would you most likely be to find the abscess cavity? I'm doing a TURP.
Yeah.
Now I've taken the patient and your heart is beating because you've taken one cut, no abscess, 2 cuts, no abscess. So where should I actually look for an abscess in the absence of truss availability and all that?
No, most of the times apex,
At the apex
just adjacent to the veru.
Yes.
You must go till you get the abscess. Okay. And you are very clinically very sure, no, doesn't matter, you can go any deep, nothing will happen.
Now, have you ever found an abscess distal to the veru?
It can extend, but
How
once
would you
put
tackle
it
it?
will drain.
How would you tackle it?
I just put distal rectal, I do rectal, then I'll press it and drain it.
Okay. So, in my experience, I have found multiple abscesses in one patient, one of them being reasonably distal to the veru for me to be worried. And so for that particular one, finger-guided aspiration was done. I am told we have only 10 minutes and Dr. Mahesh Desai has, okay, so for this patient.
One point I would like to say, in prostate BPH, there is a called as the glands of there is a sometime collection, normal, and cyst,
The
and
discharge,
then it's
secretions.
amnesia.
Yes, yes.
And when you do very often you have done a TURP and suddenly the inspissated fluid comes out. So this is inspissated. And then if this was inspissated on an ultrasound, you would have seen as a hyperechoic.
So the final proof of the pudding is in the outcome. Complete resolution of symptoms, histopathology reported as acute prostatitis, but multiple abscesses all over. I will not be discussing the second case because Dr. Mahesh Desai has a video to present, so I'll be.
It's a 2-minute video.
Yes, sir. Go ahead, sir. We have only 10 minutes, so you can show your
So
video related to the abscess.
This probably this patient is a diabetic patient and he had symptoms of urinary obstruction, and then on a truss we found multiple area which was hypoechoic, and then we thought it was infected, but we didn't. It was not inspissated like that. It was not white, but there was a tenderness and the thing. So I'll just show you what we did with the transrectal sonography. First, you have to confirm that cyst is a clear fluid or it is infected. Sometimes it's infected, you can, now you see, for urethral catheter, you can see that seminal vesicle is dilated, and there is in the prostate, there is you see the reflection, there is a fluid is not clear, there is lots of reflection is there. Can you see that? The reflection in the thing. Now this reflection, it is not clearly hypoechoic. It is got reflection, so there must be some infected fluid. And here are symptoms. So what we did, so here is a bilateral picture, and then we did a needle puncture, and then just take it off. And then we did needle puncture, and then it goes into that. You can see that clarity in the center, but there is a lots of area of sediments and infected material like thing, which is not, it may be blood, it may be anything, So what we did, we put a needle and then we aspirated. Now here in aspiration, we found the pus. Sorry, we didn't see that. Now again, we will go to the other area because there are multiple areas. So here on this side, you have a look. Here putting the needle. And look at it, how much is the area? And then you can see that there are reflection inside. And there is a reflection which suggests that it is infected, and there is a quite bit liquefaction. So we want to put a needle there. Especially I wanted to go to the distal part. So once they have a connection from wherever I puncture, I will be able to aspirate and descend. Now look at that on the screen. There I am putting a needle, and needle is going inside, and the tip is seen and the distally. Now I will take out the stillet and put if it is thick, the fluid will not come out. So I put a syringe and now I'm aspirating. Now you see the aspiration. All pus. Can you see that? All white. Can you see that? Because it is difficult. So I am adjusting a needle, pushing it down. Now it is draining. Now you can see that quite a bit has come out. Here it is collapsing. I have to wait till it completely collapses. It stopped. Now you can see that pus. Can you see that? So that pus is taken out. So that is the thing collapsed. But I just took out the pus, and then I did try a couple of times. Then I put saline and then little washed. So that comes out. And then what I did, I put a betadine. And then I sent this for a culture. Now his pressure is gone. I punctured 2-3 places and aspirated. So his pain is gone. And then he was feeling better. And in 3 days the culture came. He started the antibiotic as per the culture. And then again, before removing the catheter, I did a transrectal sonography again. Surely there was again little bit filled up because the destruction is going on. So it is filled up. So again I punctured, I aspirated little less. And then that time I put a appropriate antibiotic inside, which was, I got this thing. And then I left it. But he was symptomless. So we removed a catheter and he was passing urine. And then again, after 3 weeks, again I did a scopy. That time thing was resolving. So I didn't aspirate, but antibiotic was going on. He was symptom free. So what I feel, drainage is important, but at the same time, I don't want to do the TURP or something, because the TURP is a procedure where the fluid goes in and out, and it may do it. So best thing is putting a needle there. And here you can see very well that in the FLIR, like that previous case, there was a totally hypoechoic area. Here you can see lots of sediments are there. So you should suspect. And then you can aspirate. Best thing is to aspirate. You got a pus. Now you got a pus, you can, principle is same. So I have done this probably more than 30-40 times, aspirated. But always, I done once de-roofing, But because that patient had a lot of symptoms of urination, and that pus was quite a bit. So I did a de-roofing so that he could pass the urine. But he became a symptomless because I had aspirated and put an antibiotic inside it. So this is one way of doing it.
I just want to say that MRD, Mahesh Desai sir, at the age of 80 is so enthusiastic. This is a message for my 30-year-olds that 50 years from now you have to still come on the dais and give a talk. Thank you. So hats off to sir.
Hat on to sir. Sir does not have a...
Thank you all the
No, but I tell you, when you do all this thing is exciting. And when I do and remove the abscess and the patient is better, there is nothing like having a satisfaction that you have done a minimal invasive and you have done appropriate. But I convince the patient and do it. But one thing is that I have believed in that. Okay, ultrasound is a part of the clinical examination. It is not a special examination.
Sir.
And everybody should, all urologists should learn, because kidney can be seen. There are so many pathology in kidney. The bladder can be seen. The prostate can be seen. Even the urethra you want to see, you can put a small probe, 5 megas, and put into the urethra and inject it jelly, and you will see a stricture. But stricture, you will see the narrowing, but you will also see the thickening of the
lining,
spongeous tissue.
Spongy of fabric. Sir, can I ask you one question, sir? Kulkarni sir asked, how many of us undergone PCNL or TURP? Sir, how many of urologists have undergone TRUS examination by himself? Sir, take this opportunity to kudos to all this group from Apollo Hospital, right from Manohar, Ravi, Prashant. Kudos, very well job done. And the same thing goes for the KUA office bearers and leadership. Thank you so much for this fantastic program, sir.
Now, Manohar, I'm really feel proud that the way you have organized the thing. I'm sitting here from morning 9 o'clock. I have not gone out except for the this thing. And every talk has been interesting, and they have justified the giving a talk. I think the students who are here, I think there is lots of take-home message from this thing. Even I learned a few things which I didn't know about the medical management of the complication of the medical management of the thing was very, very interesting.
Transrectal drainage of the prostatic abscess. For the postgraduate students who are facing the exams of DNB MCH, it advised them to answer like that without derufing can go the transrectal drainage?
I don't think that is a standard mode of treatment. So I'm just doing extended thing. But best thing is like what I did here, aspirate multiple times and then put an antibiotic, and then because preservation of that kidney is important. By putting the perineal thing, you are inviting more complication. So I think that was and that only I heard he doing it, but I have not done it, and I would probably think 10 times before I do that. Yeah, it reflects, so you can follow the drill. But you can feel when it gives way into the cyst, you feel you're gone in.
Thank you. Sir, Mahesh Desai, sir, I kindly request you to stay back and felicitate our moderator for panel discussion, Dr. Manish Sinha, sir. Please, sir. Sir, and can you kindly stay back and felicitate our dynamic Secretary of KUA, Dr. Narendra JB, sir. Please, sir. Thank you, sir. Thank you, one and all. It has been a wonderful day of deliberation on benign prostatic diseases. Me being a uro-oncologist, I was quietly mocking what is there to discuss benign prostatic disease for a whole day. But I think I should swallow my pride and get back to basics. There's so much more happening, and it was a revelation of a kind for me, and such a remarkable advancements and technological developments have been happening in this space. I think something which we all should look forward to. Thank you, Manohar sir, for drafting a wonderful program, truly amazing. And I thank all the faculty and moderators for delivering probably a best show, best academic show for all of us. And I thank our doyens of Indian urology, Mahesh Desai sir and Sanjay Kulkarni sir, for being here for whole day and giving us a wonderful deliberation. With this, I sign off. Dr. Ravichandran, being an anchor for today, has been a truly pleasure thing for me. I now request Dr. Narendra JB to give us a closing remarks, followed by a vote of thanks by Prashant sir, and then we'll have a dinner and.
Good evening, all my dear teachers, colleagues, and all the KUA members. We are coming to an end of CV on benign prostate diseases and an update which includes invited lecture symposia, and there is a lot of interactions among the members which help them their activity in future. Hope all the delegates gain an update on BPH disorders. I personally feel every one of us got a wisdom and tips from our urology gurus of India and abroad, Dr. Mahesh Desai sir and Dr. Sanjay Balwant Kulkarni sir, who conferred a National BC Rai Award in 2000 and 2016 respectively, which is the highest honor that can be achieved by a doctor in India. The new council, the KUA Council 23-24 has taken over from November 5th from Shimoga. We have lined up with a host of activities like council member activities which has been happened now, and we have KUA sports activity in the March. Last year we had a sports activity in Mysore. It was a wonderful kickstart event. We have a sports activity from KUA in Bengaluru, which probably we keep watching our websites. And followed up, we have a quiz program for postgraduates and KUA mock programs, which is a preparatory exam for urology residents and hands-on workshop for postgraduates. To conclude, we have a 29 KUCon hosted by ANU Bengaluru on November 8th, 9th and 10th. Our details will be updated further. I request all the members to participate in all KU activities and get benefit of this. And I congratulate Dr. Manohar and team, Dr. Ravi, Dr. Prashant Ganesh and team Apollo, Bangalore for having a good event. Thank you once again. Thank you all. And over to Dr. Prashant to give a vote of thanks.
Good evening, everyone. Distinguished guests, esteemed speakers, chairpersons, and fellow colleagues. It is with immense gratitude and sense of fulfillment that I stand before you today to deliver this vote of thanks for this remarkable urology meet. Over the course of the day, we have witnessed an exceptional gathering of experts in the field of urology who have shared their knowledge, experiences, enriching our understanding and opening new horizons in the management of benign prostatic diseases. First and foremost, I would like to express my deepest appreciation to all the esteemed speakers, chairpersons, who have graciously shared their expertise and insights and for smooth conduct of the sessions. I would like to extend my heartfelt gratitude to our Karnataka Urological Association office bearers for giving this opportunity to host the meet and their constant support. And most importantly, to our sponsors and exhibitors, we extend our sincere appreciation for your support and contributions for this conference. Your partnership has allowed us to create an enriching and engaging environment. I would also like to acknowledge the invaluable contribution of our delegates. Without delegates and their active engagement, insightful questions and meaningful discussions have elevated the quality of this meet. I would like to express my gratitude to Apollo Sheshadipuram team led by our COO, Mr. Uday Dauda, and Ravi and Bharat, and all the supporting staff who have worked tirelessly, audiovisual team, technical team. They worked tirelessly to ensure the smooth execution of this conference. We truly are grateful for your efforts. At last, I would like to express my deepest appreciation to our organizing chairman, Dr. Manohar, whose tireless efforts and meticulous planning have made this conference a resounding success. Your commitment to excellence and attention to detail and ability to bring together such an distinguished guest of speakers and participants is truly remarkable, sir. As we conclude this conference, once again, thank you all for your invaluable contributions and for being a part of this meet. May we meet again in future, united in pursuit of excellence and our shared commitment to improve urological care. Thank you. Then kindly it will be followed by dinner and meet. Thank you.